بارت 1. اوكي اكسلنت. خلاص معناته احنا نبدأ بالضبط بعد 5 دقائق. اوكي. We will start at 3 p.m. ان شاء الله. Thank you. الو، السلام عليكم. واضح. طيب، والباوربوينت واضحة، البيسك اوف ميديكال تيرمينولوجي. اوكي ممتاز. طيب نبدأ على بركة الله سبحانه وتعالى. Welcome everybody, and this is the first part. Objectives. We will name parts of medical terms, and then we will recognize importance of combining forms and related body parts. Okay, so this is how we built the medical terminology. احنا كده نبني المصطلح الطبي. اوكي، اللي هو نربط ما بين البودي بارت and the term. Parts of medical terminology. Any medical terminology, okay, any medical terminology is made of form, okay. It is we call it combining form, okay. We call it combining form اللي هو شكل التركيب, okay. Then we have combining vowel, and we have root اللي هو الجذر, suffix which comes before the root, and the prefix which comes after the root, okay, of the medical term. What are the combining forms? Combining forms, they end with O or I, okay? When I say combining form, اللي هو الرابط ends with O or I. Usually it's a body part, okay? Usually it's a body part. Now, when I say derma, refers to skin. So we say dermato or dermo. Cardio or corono, okay? So the O or the I are the combining. You have gastro related to stomach, and neuro, okay, which is related to brain. Okay, yes. Skin, dermo, heart, cardio or corono, stomach, gastro, and nerve we refer to as neuro. Okay. So skin, heart, gastric, or neuro. This is which part that we add in order to make a terminology. So in order to relate your diagnostic terminology to a body system, you need to end it with I or O. So dermo or dermato, cardio or corono, gastro, and neuro. Okay. So this is exactly how the medical term is built. Okay. Is built in order to relate it to the body system. Of course, there will be lectures in details about each body system during the presentation, but here I am just talking about the fundamentals of building the medical terminology. If you talk about skin, we will use dermato, heart, corono, or cardio. When it comes to liver, liver goes as hepato, okay? And for kidneys, we say renal, okay? Or nephro. So this is how we built the terminology for this, okay? Entero, when we talk about entero, we are talking about intestines, okay? So when you say enteritis, okay? ايوه مفروض الشاشه بتتغير، هل الشاشه بتتغير عند الجميع ولا بس عند تركي ما بتتغير؟ طيب خلينا اعمل ستوب شيرنج، اوكي. I'll do a new share. الحين تغيرت الشاشه ولا لا؟ ما تغيرت ابدا، ثابته على 2. ما تغيرت. طيب الان تغيرت الشاشه ولا لا؟ Yes. طيب اوكي very good. طيب so here we are talking about intestine. We say entero, kidney, nephro, colon, we say colono, and for the blood, we say hemato. Okay? Okay. So when we go to small intestine, or when we talk about kidney, we talk about intestine, okay, or blood. So we employ the term entero, okay, and for the colon is colono, for the kidney is nephro, and for the blood is hemo. طيب بس أحب أتابع، هل الشاشة بتتغير معكم ولا ثابتة؟ أوكي ممتاز. So when we talk about parts of the GI, for example, when we talk about stomach, we say gastro, duodenum is duodeno, jejunum is jejunum, and all together, duodenum, jejunum, and ileum, all are referred as entero, okay? All are referred as entero, okay? Okay, so this is exactly how we build the term, for the small intestine, okay? They go as duodenum, jejunum, ileum, and the small intestine, and together become the entero system, okay? When it goes to the colon itself, you have a ascending, transverse, and descending colon, but we all refer to as colon, okay? And these are the parts of the GI system, which are the stomach, the liver, the gallbladder, the transverse ascending and descending colon, and the small intestine, okay? So to build your terminology again, gastroenterocolono, okay, and for appendicitis or appendectomy, okay. طيب Let's have a question here. Gastro, we refer to GI system. Entero, intestine. Colon, colono, and appendo or appendico. Okay, this is for the appendix. Body parts, you have the food pipe, which is the esophagus, the rectum, the anus, and the rectum and anus. So to talk about them together, okay, you have to have a combining form. How do we create a combining form? When we say oesophageal recto, okay, ano and procto, okay? So this refers, so we use the O in order to make our terminology, okay? To make our terminology. So here we are making a combination of rectum and anus together to call them procto, okay? To call them procto. So what do we call the food pipe? This is a question for you. How do you make a combination? You put the part plus O, then this become oesophageal. Rectum, recto. Anus, ano. Rectum and anus together is the procto. Okay? So this is how the medical terminology is built. Okay? So for ileum is ilio. Okay? So O is mainly the combining vowel that is used in the GI system. Okay? Again, if you want to make a combination for the duodenum, you add an O. For jejunum, O, and for ileum also is O. Okay. Cecum is part of the colon. Okay. Cecum is part of the colon. So it becomes ceco. Okay. If you are talking about appendix, اللي هي الزائدة الدودية, you have the appendico or appendo. Okay. That's why I say appendectomy. Okay. Appendectomy. Sigmoid also is part of the colon. So it becomes sigmoid. Okay. It becomes a sigmoid. Cecum we refer to as ceco, appendix, appendico or appendo, and sigmoido. Okay, and sigmoido. We will keep going. Root. Okay. When we say root, it's the main part of a medical term. Okay, root is a main part of a medical term. And O or I is the combining form. Okay, so this is how you make a medical term. It is composed of root and a combining form. And the root and the combining form is always O or I. Okay, so that's why if you want to talk about head, you want to talk about lung, you want to talk about stomach, you have to take the name of the part of the body. When you add that letter, which we call it combining letter or combining vowel, it will make it as a combining form. Okay, it is a combining form in order to talk about medical terminology. Root examples. Okay. Derm. Derm refers to what? Skin. Dermat refers to a skin disease. Okay. That's why you say dermatitis. Okay. We add I plus I will talk about the suffix and the prefix when we will talk about disease as it is. Okay. Gastri or gastro. Of course, if you are using it in a procedure or if you are using it in description, okay, you can add this O or I. Card become cardio, okay? Enter, it is for the small intestine, so we say entero, okay? Or enteri. Neuro is for the brain, so you can say neuro or neuri. It depends on how you are utilizing or in which aspect or in which كيف انت توظف المصطلح. هل انت تتحدث عن procedure ولا تتحدث عن مرض؟ اوكي. طبعا في اختلاف في في الوصف المرض او في وصف البروسيجر حسب استخدام الفول. اوكي. نفرو. اوكي. I say nephrectomy or we say nephritis. It's here either O or I. Okay. Ren, also renal. So we say reno or renai. Col from colon. Okay. Heme goes to the blood. And hemato goes to blood and blood cells. Okay. So this is a root example, and this is a combining vowel that makes it a combining form. Okay. فهنا كيف احنا نأسس المصطلح الطبي؟ ناخذ جزء من جسم الإنسان ونربطه بفاول اللي هو الرابط. اوكي. فهذا الرابط ينقلنا لما بعد المصطلح الطبي اللي هو نسميه للسفكس، نسميه السفكس. اوكي. فالسفكس حيعطيك اللي هو اما بروسيجر او يعطيك ديزيز، بس دائما الحرف الرابط ما بين ما بعد المصطلح اللي هو O or I. Okay. طيب. الكومباوندينج فاولز makes pronunciation easy. احنا ليش نستخدم combining vowels؟ علشان اللفظ المصطلح الطبي يكون أسهل. Neuro is the nervous system. Okay. But imagine يا تركي you wanna say التهاب الجهاز العصبي، فأنت you say neuritis. Okay. You are using I. If you wanna say neurologist, you say neuro. So you are using O. اوكي. فهنا زي ما قلنا الفاول يسموه combining vowel. الفاول هو حرف العله بالانجليزي الاو اور اي اللي يربطك مع المصطلح، اللي يحول المصطلح من بروسيجر لاختصاص لمرض. اوكي. ف this is exactly how the medical terminology is built. Okay. Here you have the throat. Okay. Which is the larynx. So you say laryngo or laryngi. But when you say laryngo, okay, blood vessel, okay, you have the lungs and you have the blood and its components. Okay. So how we are gonna utilize the vowels in creating the terminology for the locations. Pharyngo, okay, from pharynx, which is the throat. Okay. We say vasculo or angio or vaso. فده blood vessels. طبعا الارتري الشريان اسمه لوحده ارتري، الفين لوحده اسمه فين. لكن لما نتكلم عن الأوعية الدموية نقول blood vessels we are using vasculo or angio or vaso. okay. فهذه هي الثلاث مصطلحات. those are the three terms using in describing blood vessels. okay. pulmono goes to lung. okay. pulmono. and flippo or veno in particular for veins. That's why when you see phlebotomy, okay, اللي هي سحب الدم. veno, okay, it's either flippo or veno. Those are the terminology used to describe the veins. But in particular to the artery, we say arterio. Okay, we say arterio when we talk about arteries. So pharynx is the throat, blood vessel, which is arteries and veins, lungs, and we have the veins. So to make the combination, okay, hepato-renal. Now we are talking about combining. Okay, we are talking about combining two systems. Combining two systems. So hepato from liver, renal is from kidney. So you say hepato-renal. طبعا في مرض اسمه hepato-renal syndrome or hepatorenal syndrome. okay. So when the disease affects liver and kidney together, or they are connected together as a disease process, we say hepato-renal. Hepato-renal. okay. We say hepato-renal. Clear? How do we connect colon to rectum? So we say colorectal. Colorectal. Okay, it's from colon and rectum. Sometimes someone go for colonoscopy or colonorectoscopy. But he is doing a scope for the colon and the rectum. Okay, cardiopulmonary. When you say cardiopulmono, okay, together. Like in CPR, we say cardiopulmonary arrest. So we use cardiopulmono, okay? So we can combine them together. And when you are inserting a tube from your patient nose down to his throat, down to his stomach, what do you call that tube? You call it nasogastro, okay? Nasogastro or nasogastric. So this is how we make a combination between the nose to the pharynx, nasopharyngeal, okay, for example, or nasogastric, nasogastro, okay? So this is, we are using the letter O, which is the combining vowel, in order to connect between two body parts, okay? السلايد ماشية معكم كويس؟ تمشي السلايد معكم ولا ما تمشي؟ تمشي كويس. طيب we will go to the part 2 of this presentation, which is basic medical terminology for diagnostic suffix. okay, for diagnostic suffix. احنا خلصنا في الجزء الأول كيف نعرف، كيف نربط البادي بارت. okay, كيف نربط البادي بارت بالفول. Now we will talk about diagnostic suffix. طيب ايش يعني suffix؟ Suffix is a small part at the end of a medical term. Okay? It is used in diagnostics and procedures. Okay? It is used in diagnostics and procedures. فهو عبارة عن جزء من الكلام يوضع في نهاية الميديكال تيرم in order to make a diagnosis or to talk about procedure. فإحنا عشان نعبر عن تشخيص طبي أو عن إجراء طبي لازم في جزء تنتهي فيه المصطلح الطبي، وهذا اللي احنا نسميه السفكس. اوكي، يعني بالعربي يسموه المذيل، او يسموه في ابيات الشعر عجز البيت. اوكي، او القافية. طيب، السفكس meaning related to ايك او اك او ال او إيل او ار اري اور اوس. هذول هم السفكس. اوكي، حرف أو اثنين في نهاية المصطلح الطبي يعبر عن diagnosis أو procedure. أوكي، يعبر عن diagnosis أو procedure. فإذا جبنا كلمة جاستر اللي هي المعدة، أوكي، وحطينا وراها اي سي تصير جاستريك، فصير هنا مصطلح يعبر عن المعدة جاستريك، زي ما نقول جاستريك diagnosis، تشخيص خاص بالمعدة. اوكي، الهارت مثلا ياخذ اي اي. ليش ماخذ اي اي؟ لانه ينتهي اصلا بفاول، فما تقدر تحط اي. اوكي، فما تقول كارديك، لازم تقول كاردياك علشان تحرك الفاول in order to make the letter pronounceable. okay, in order to make the letter pronounceable، حتى يكون قابل إن نلفظه. اوكي، نقدر ننطق الحرف الكلمة. آل زي رينال، اوكي، او فرنجيال. اوكي، فرنجيال. اوكي، طبعا جت اليال هنا لانه هنا في فاول متحرك، فصعب انك تربط بين ساكن متحرك، فصارت فرنجيال. اوكي، طبعا احنا ما الفناها، هم علمونا اياها اصحابها. اوكي، طب الار او الاي ار زي فاسكيولار. اوكي، فاسكيولار. ار واي pulmonary. اوكي، فصارت هنا vascular يعني related to or meaning of something related to vessels. pulmonary related to lungs. venous C. took O U S. اوكي، طيب، فthis is exactly يعني هذه المصطلحات الطبية زي ما يقولوا يعني تحفظ عن طريق الرواية. اوكي، عن طريق التوارد. طيب، الsuffix means related to. when I say gastric I'm talking about stomach, cardiac heart, renal kidney, pharyngeal pharynx or throat, vascular blood vessel which is mainly artery and vein together, pulmonary is lungs, and when I say venous I am talking or trying to describe something related to the venous system. okay, فإذا المعدة stomach say gastric، انه ما عمرنا قلنا stomatitis لانه this is English و this is Latin word. اوكي، فلا زال الطب يكتب باللغة اللاتينية. اوكي، يكتب باللغة اللاتينية. اوكي، فرينال from kidney من الكلية، وفارنكس اللي هو من الحلق، وفاسكولار blood vessel، وبلمونري from lungs اللي هي رئتين، وفينوس اللي هي الأوردة بالذات بالتحديد. اوكي، فthis is IC AC AL EAL AR ARY and OUS. we call them suffix. okay, we call them suffix. فييجوا يركبوا مع المصطلح المتعلق بالبودي بارت علشان يرمزوا ل procedure أو diagnosis متعلق بهذا الجهاز بالذات. أوكي؟ طيب. Exercise. Create a medical term using related suffixes. يلا هذا لكم الاكسرسايز. أبغى مشاركة الحين. الفين. How do we create medical term using a suffix? الفين we say فينوس. ممتاز. اللنج. pulmonary. ممتاز. blood vessel. vascular. أحسنت. kidney. لا طلع هذا عربي. renal. pharynx. pharyngeal. أحسنت. esophagus. esophageal. yes. heart. cardiac. لا cardio is connection but suffix is cardiac. اوكي. السفكس cardiac. طيب nerve. nervous. ممتاز. مو نيورو. nervous. artery. arterial. ممتاز. colon. colonal. أحسنتم. ممتاز جدا. أوكي. طيب الانسرز. pulmonary. vascular. renal. pharyngeal. esophageal. coronary or cardiac. nervous or neural. artery arterial. اوكي and colonal. اوكي and colonal. ممتاز جدا. اوكي. طيب احنا في عندنا لوجي ولوجيست. اوكي. when I connect logi or logist we talk about study of specialities. اوكي. study of a specialist. اوكي. study of a specialist يعني يعبر عن الشخص. اوكي. او عن الدراسه. شو يعني دراسه؟ يعني when you say logi. when you say logi you are talking about studying a specific system. when you say logist you are specialized in this system. اوكي. فلوجي تعبر عن study اللي هو البحث في هذا المكان. اوكي. في هذا الجهاز. واللوجست الشخص او الطبيب المتخصص بهذا الجهاز. cardiology. what does cardiology mean? لا الكاردياك القلب. كارديا قلب. cardiology is the study of the heart disease of the heart system. اوكي. طيب الكارديولوجيست ايش دارس؟ what did the cardiologist study? he studied cardiology. okay. so when you study cardiology you become specialized in cardiologist. okay. الكاردياك دكتور هو cardiologist but what did he study? he studied cardiology. okay. طب النفرولوجي دراسة أمراض الكلى studying the nephro system. If you study nephrology you become a nephrologist. اوكي خلاص انت درست امراض الكلى يصير اسمك استشاري كلى. اوكي فنقول nephrology is the study of the renal problems and the nephrologist is the specialized person. اوكي طيب neurology studying الأعصاب. okay studying neurological system. okay neurologist is the person who is specialized in neurology. okay dermatology جلدية skin disease. okay dermatologist أخصائي الجلدية he's the specialized person. شروق اللي يحضر هنا حاضر خلاص مجرد ما انت مسجلة في الزوم اسمك في التحضير ما تحتاجوا تسألوا عن التحضير مجرد انك موجود في المحاضرة فانت مسجل اوتوماتيكيا. you are automatically signed in once you are logged to Zoom. اوكي فما فيها داعي تسألوا عن الحضور مجرد وجودك في الليستة هنا انت حاضر. طيب gastroenterology اللي هي دراسة لا الجاسترو انترولوجي دراسة أمراض الجهاز الهضمي. فهنا أنا عندي تو سيستمز. إيش هم التو سيستمز؟ معدة جاسترو وانترو أمعاء. أوكي فالمعدة والأمعاء مع بعض أنا استخدمت تو بادي سيستمز ربطتهم اثنين بأو وربطتهم مع التخصص اللي هو مع الدراسة بأو فصار عندي جاسترو انتيرولوجي. اوكي فدراسة الجي اي سيستم اللي تاخذ معها المعدة والأمعاء فالمتخصص بالجهاز الهضمي اسمه جاسترو انتيرولوجيست. اوكي فهو متخصص في الجاستريك اللي هي المعدة ومتخصص في الانتيرو سيستم اللي هي الأمعاء فيصير اسمه جاسترو انترولوجيست. اوكي ف this is how we are using the suffix logi to express the study and the suffix logist to express the specialty. اوكي طيب الحين which suffixes we are using to talk about disease problems. okay I wanna go back. ابغى ارجع. اوكي فاحنا عندنا ايتس. اوكي talks about inflammation. اوكي ايتس يعني inflammation فاي كل مصطلح طبي ينتهي بايتس اوكي يعبر عن inflammation اللي هو الالتهاب في ذاك السيستم. اوكي and when I talk about algia and dynia. okay algia and dynia it means pain. فالسفكس الالجيا والسفكس دينيا يعبروا عن الألم. they express pain in that body system. okay طيب pathy means disease. okay pathy means disease. if you use a medical term and the suffix pathy it means a disease. okay أوما it is a tumor. بعيد عنكم الشر إن شاء الله. اوكي it's the cancer اللي هو السرطان. اوكي فإذا itis inflammation التهاب والجيا دينيا pain تعبر عن الألم وباثي اللي هو مرض أو خلل في هذا السيستم وأوما اللي هي تعبر عن وجود الأورام في هذا السيستم. اوكي inflammation ايش قلنا inflammation ايش what is the suffix for inflammation يلا المتابعين معي. ايتس ممتاز. والبين الجيا او دينيا. ممتاز. طيب وبالنسبة بالنسبة للديزيز باثي وتيومر اوما. طيب ممتاز جدا. طيب خلينا ناخذ اوكي اللي هم الخمس اعراض رئيسية للالتهاب. اوكي الخمس اعراض رئيسية للالتهاب. Any patient has inflammation he will have pain. يصير عنده ألم. يصير عنده fever اللي هو heat. اوكي يصير عنده redness احمرار. يصير عنده swelling ولوس اوف فانكشن، ما يقدر يستخدم هذا الجزء اللي فيه التهاب من جسمه. اوكي وين ما في ايتس يعني في inflammation. اوكي we will just explain more about it. اوكي طيب how to rule out how to remember. okay how to remember if the suffix begins with a vowel. okay delete the OI from the combining form. اوكي فإذا كان السفكس يبدأ بفاول اوكي فاحنا نحذف الاو او الاي. عندك فور اكزامبل جاسترو ما نقول جاستروايتس فنحذف الاو ويصير اسمها جاسترايتس. اوكي يعني لو جينا قلنا جاسترو هذا ستومك. طب التهبت المعدة ما عمرنا سمعنا واحد يقول جاستروايتس لأنه ممنوع تجمع two vowels. You are not allowed to mix between two vowels. فإحنا we say gastro we remove the O which is the combining vowel and we just use the inflammation which is itis so it will become gastritis. اوكي طيب لما نقول هيباتو أنا عندي أوما فما يصير نقول هيباتو أوما، لا نشيل واحدة منهم وتصير اسمها هيباتوما. أوكي هيباتوما ما تصير هيباتو أوما غلط. أوكي فوي سي هيباتوما. طيب رينال أوكي ونيورو تصير نيورالجيا. أوكي هذه تصير رينال وتصير هنا نيورالجيا. اوكي فاحنا حذفنا الاو في الرينال والاو في النيورو من رينو نيورو لانه انا عندي في السفكس هنا يبدا بفاول. فاذا كان السفكس يبدا بفاول والميديكال كومبينيشن ينتهي بفاول فلازم نحذف الاو والاي الموجوده بالميديكال في البيسك تيرم. اوكي في البيسك تيرم كلير. الآن هذا اكسرسايز. يلا لما نقول guess the meaning itis. What is dermatitis? Inflammation of skin. ممتاز. طيب لما أقول gastritis مو الأمعاء، لا الجاسترايتس خاص بالمعدة الستومك. أيوة فgastritis is the stomach فit is the inflammation of the stomach. طيب لما أقول gastroenteritis how many medical terminology here I have? How many systems? معدة وأمعاء. I have gastroenteritis. فأنا هنا علشان أربط ما بين الجاسترو والانتيرو الأو موجودة لكن because itis cannot mix with O فما نقول gastroenteritis، لا نقول gastroenteritis. فI remove the O of the entero. اوكي، فهنا التهاب المعدة والأمعاء مع بعض. اوكي، inflammation of the stomach and the small intestine. اوكي، طيب hepatitis inflammation of the liver. اوكي ممتاز. ونفرايتس الكلية بالذات. اوكي، الكلية بالذات، لانه النفرون هو المشكل الاساسي له. احسنت يا سعيد، نفرون نفرايتس، فهي النفرون is part of the kidney. That's why we call inflammation of the kidney. طب النيورايتس النرفز. اوكي، التهاب الاعصاب. ممتاز. فنشوف الإجابات الصحيحة. أنا عندي dermatitis inflammation of the skin, gastritis inflammation of the stomach, gastroenteritis inflammation of the stomach and the intestine, وhepatitis the liver, ونفritis the kidney, and neuritis inflammation of the nerve. State the medical term. When I say inflammation of the skin, how do I say it? Dermatitis. ممتاز. Inflammation of the stomach. Gastritis. طيب. وinflammation of the stomach and the intestine together. Gastroenteritis. والliver. Inflammation of the liver. Hepatitis. وكدني. نفرايتس. اوكي، مو يجي واحد يقول لي كدنايتس، غلط. لانه نقول عن نفرون is the component of the kidney. فinflammation of the nephrons together they make the kidney, we call it nephritis. طب والنيرف نيورايتس. اوكي، النيرف نيورايتس. ممتاز. طيب so now we talk about pathy. اوكي، عشان نعبر عن الديزيز، عشان نعبر عن الديزيز. فلما اقول جاسترو enteropathy, what does it mean? مرض ايش؟ It's pathology. It's disease. It's the disease of المعدة والأمعاء. انتبهوا. When I say gastroentero together، هذول جهازين. They are two systems. Yes، مرض في المعدة والأمعاء. Okay. Cardiopathy disease of heart. ممتاز. ونفروباثي اعتلال الكلى. عجبتني كلمة اعتلال، لغة عربية ممتازة. اوكي، طيب نفروباثي في الكلية، وديرماتوباثي يعني سكين ديزيز، صح؟ ديرماتوباثي سكين ديزيز. وفاسكيولوباثي disease of the blood vessels، الأوعية الدموية. أحسنتم جميعا. طيب إذن gastroenteropathy disease of stomach and intestine, cardiopathy disease of heart, neuropathy is disease of nerve, nephropathy disease of kidney, dermatopathy disease of skin and vasculopathy disease of blood vessels. واحنا نستخدم كلمة pathy لما يكون في خلل بس غير محدد للآن. اوكي، يعني ما عندي specific disease. اوكي، يلا مسألك ايش اسمه، ايش مال هذا المريض، تقول لي هذا المريض عنده مرض في القلب. انت ما قلت لي هل عنده جلطة، هل عنده صمام، هل عنده انسداد أوعية، هل عنده تضخم، هل عنده ضمور، ما حددت. You did not specify the disease. They say he has cardiopathy. You did not specify. Is it myocardial infarct? Is it hypertrophy? Is it dilated cardiomyopathy? Is it whatever? Is it valve disease? You did not specify. The word or the suffix pathy, it talks about disruption of the function of the normal function of any system in the body without a specific diagnosis. Okay, without a specific diagnosis. ما حدد. اوكي، ما حدد على وجه التأكيد والتحديد ايش الخلل. اوكي، طيب state the medical term. okay, for the disease. What do we call disease of the stomach and intestine? gastroenteropathy. اوكي، disease of the heart. لا، مو الأوعية. اوكي، هنا مو الأوعية. disease of the heart is cardiopathy. اوكي، cardiopathy. طيب disease of the nerve neuropathy. ممتاز. و disease of the kidney nephropathy. ممتاز. و disease of the skin dermatopathy. ممتاز. و disease of the blood vessels together vasculopathy. okay, vasculopathy. okay. Guess the meaning of OMA. OMA ايش قلنا تعني؟ cancer of. I would say gastroma, it's cancer of the stomach. صح؟ ونيوروما, it's the cancer of the nerves. وهيمانجيوما, هيم انجيو. اوكي، هيم انجيو. دايما كلمة هيم انجيو معناتها blood vessels. اوكي، معناتها blood vessels. معناتها blood vessels، ورم دموي. اوكي، ورم في الأوعية الدموية، مو دموي بالذات، في الأوعية الدموية. اوكي، شايفين هذه this is hemangioma. اوكي، hemangioma ورم يحتوي على كمية كبيرة جدا من الأوعية الدموية. ورم يحتوي على كمية كبيرة جدا من الأوعية الدموية. اوكي، that's why we call it hemangioma. اوكي، طيب فاحنا we said gastroma it's the stomach, والneuroma is the nerve, and the hemangioma it's the tumor of the blood vessels. okay. طيب الحين we will talk about pain. okay. طيب when I say myalgia, okay, from mayo. ومايو هي العضلات. اوكي، مايو هي العضلات. فلما اقول myalgia it's pain in the muscle، ألم عضلي. اوكي، ألم عضلي. طيب arthralgia from arthro جاية من المفاصل. اوكي، آلام المفاصل. نعم. اوكي، والنيورالجيا ألم مصدره وين؟ عصبي. It's a nerve or a neurological pain. فالفودينيا. اوكي، فالفودينيا هذا ألم في الفالفس. اوكي. إذا myalgia, pain in the muscle. Arthralgia, pain in the joint. Neuralgia is pain in the nerve. And vulvodynia is pain of the vulva. Okay. Vulva is part of the female, external female organs. Okay. طيب. How to read a medical term? Okay. You need to read the suffix first. Okay. Then the prefix, if there is one. Then combining form plus, which is root, and read the term from left to right. Okay. From left to right. This is how we read the medical term. Okay. gastroenteropathy. اوكي، هذا medical terminology صح؟ فنقرا gastro، هذه الاو، وانتيروباثي. اوكي، ف this is how we read it. What does it mean? It's a disease of stomach and intestine. Okay, disease of stomach and intestine. طيب لما I say myocarditis، فأنا I have myo means عضلة، وكارد يا means قلب، وايتس means التهاب. فهنا صار اسمه inflammation of the heart muscle، التهاب العضلة القلبية. اوكي، فالتهاب العضلة القلبية، فصار عندي مايو وكارديو وايتس. فالمايو للعضلة، والكارديو عشان اقول هذه عضلة القلب، والايتس عشان اقول عن انه هذا الديزيز انفلاميشن. اوكي، فانا صار عندي اللي هو روت وكونكشن فاولز وانذر روت، وصار عندي هنا suffix. اوكي، صار عندي suffix اللي هو المذيل او القافية هذه. اوكي. طيب، هيباتو ميجالي، تضخم في عضلة في الكبد. اوكي، هيباتو ميجالي، لانه الميجالي تعني دائما ضخامة في الكبد. طيب، نيورال معناتها related to neuro. ممتاز. اوكي، ونفرايتس inflammation of the kidney. ممتاز. وجاستروما جاستروما ورم في المعدة، ورم في المعدة. اوكي، ورم في المعدة. طيب، احنا في عندنا الايا اللي هي condition، واوسز abnormal condition، وايميا اللي هي blood condition، ويوريا or اوريا هي urine condition. اوكي، urine condition هذه عشان نكمل السفكسز. طيب، اذا الايا condition، والاوسز abnormal condition، والايميا blood condition، والاوريا urine condition. اوكي. طيب، لما اقول ريا معناتها discharge. احنا هنا دخلنا في الدياجنوستكس. اوكي، دخلنا في الدياجنوستكس. طيب، وانا حاب اخلي الدياجنوستكس للنكست بارت اوف ذا lecture. اوكي، for the next part of the lecture. فإحنا رح نتوقف عند هذا الجزء من السفكسز هنا ونعطي المجال for the next presenter. Okay? For the next presenter. All right? يلا. And I will see you after 1 hour. إن شاء الله next presenter ready to join. Okay? Thank you.
Yes, I'm ready. Hello, everyone. Can you hear me? Okay, and the slides are clear? Okay. Okay, perfect. First, I want to introduce myself. أنا Dr. Antoine El-Khouri. أنا a cardiologist, a medical doctor. بشتغل بفرنسا بباريس. I want to thank Mr. Amin for his excellent presentation and the organizer for medical reports related to specific body system. So here now we will talk a bit about how to interpret the medical report we have, how to interpret lab tests, how to interpret imaging, chest x-rays, CT scan. We will give few examples. Okay. The slides are moving. Can you see the next slide, or it's the same problem from the previous lecture? Did you see the next slide? Okay, perfect. Okay, so you are seeing it. Great. So we'll start by interpreting medical lab tests. So before we start, you need to know that when we take blood from a patient, this blood tube contains 3 parts. So it contains the red blood cell part. You can see them in red here. So here is the blood rich in red blood cell. It contains a small portion of white blood cells and platelets. So this is the smallest portion of the tube from the blood we took. And the rest, which is the most predominant part, is the plasma. So the plasma will contain water, ions, proteins, nutrients, wastes, and gases. So we have 3 main portions: the red blood cells, the white blood cells and platelets, and the plasma. The plasma, which is the most predominant part, and it will be divided in several other components. So you need to understand this before you try to interpret any lab test results. So if you look now on this lab report, so you can see that on top of the report, we should mention the name of the laboratory or the university hospital that the test was performed and analyzed at. So here it is, in this example, it's University Medical Center, Department of Pathology, and you need to mention the address, so the full address, so University Way, city, and with the postal code. So step 1, we need to check always the place or the lab where the test was performed. Second, when we look at number 2 is the report date and time. So we need to have the exact date and the exact time. Why the time is important? Because a lot of lab tests are performed in the morning before eating. So fasting blood test, while others are performed during the day or at night. So we need to mention the time. So here the time was where this lab test was performed is at 4 p.m. So here the test was not performed in the morning. So it's important to know that. Step 3, you always need to check for the name of the patient. For example, here is Mr. John. So we need to make sure the labs are for this patient, because a lot of times we have errors. So we have the labs from another patient. We need to check the age. The date of birth is very important, because sometimes two patients have the same exact name. So we need to differentiate by the date of birth. Then we need to check for the patient ID as well, and who is the physician that who has ordered this test, and for which physician we need also to send a copy. So here the physician that ordered the test is different from the physician that also we need to send him a copy. So for example, a patient is being followed by a GP or by a family doctor and a cardiologist or a nephrologist. So we need to send copies for all his referring physicians. It's important also to note on the lab report to check the medications that the patient is taking. For example, this patient is on multivitamins. Why it's important to check the medications? Because a lot of medication can interfere with lab test results. For example, if the patient is taking anticoagulation, so the PT, PTT, or INR levels sometimes will be disturbed. If the patient is on nephrotoxic drugs, sometimes the renal function tests we order, the creatinine is elevated. So we always have to check the list of medication, and we have to note it on the lab report. The specimen also, each specimen, it's different from the patient ID. So number 8 here we see the lab specimen. So here it's each lab test has a number also to differentiate from another patient. So we have the patient ID, and we also have the specimen number for the specific lab test. And we need also to check the specimen. So here we took it from the serum, from the blood. For example, sometimes we take urine tests, sometimes we take saliva, sometimes we take different specimens. So we need to mention it as well. If we sometimes we can have comments. So if you see here, so the specimen is not fasting. We said it was performed in the afternoon at 4 p.m. So it was not fasting, and it's slightly hemolyzed. So we need to check all these details before we analyze the lab report we have. It's clear for you? Any questions? Any questions? All is clear? Okay, perfect. So now we move to give an example. For example, this is a basic metabolic panel. So this is a blood test performed for a patient. You can see it's the sodium, the potassium, the carbon dioxide, the chloride. These are the electrolytes. So it's the metabolic panel. So if you look on number 14, we have the normal values. So if the test is normal, we note it here. If the test is abnormal, we note it in the abnormal section. So for example, in this test, can someone tell me what is the problem here? What does this patient have? So look on the sodium and the potassium. What do you think here is the problem? Okay, so here the patient is having electrolyte disturbances. So he has a low sodium level, which is 124. We call this hyponatremia. Yes, it's Dua said it's low sodium, exactly. And he has also a high potassium, so he has a potassium of 5.8, exactly. So low sodium and high potassium. So if you look on the lab report, it mentions L and H. So L is low, which is hyponatremia for the sodium, and H is high, which is hyperkalemia for the potassium. And you can see the unit because some labs do the test and it gives us the results in different units. And you can see also the reference range. For example, the sodium should always be between 136 and 145, and the potassium should be between 3.5 and 5.1. Yes, Mohammed, exactly. The glucose is a bit elevated. It's not very high. Here we need to make sure, and we need to, the test was performed at 4 p.m. So for sure the patient has eat during the day. So for sure the glucose will be a bit elevated, but it's not very high. 107 is acceptable. Yes, exactly. So we have also a very low hemoglobin level. If you look on the bottom here of the picture, the hemoglobin level is 7.0. And if you look on the right, we have the L, which is low, and we have 2 stars next to it. So this is a critical value. So when we see 2 stars, here the laboratory doctor or technician should directly inform the physician that ordered this test, because here it's an emergency. Well, when you see a hemoglobin level of 7, we need to suspect, for example, the patient is bleeding or is having blood loss. So here we need to directly mark it as a flag value, and we need to inform the physician that ordered this test directly. So it's an urgent situation. So you need to look for low levels, high levels, the units, the reference range, and to check if there's flagged value. So these flagged value are critical value. Like this case, we have very low hemoglobin and hematocrit level. So this is a severe anemia in that case. Okay, so now sometimes the labs will send with the report comments. So here's a comment is that the sample, for example, this blood test, which is HIV test, was performed in a different laboratory, because the laboratory where the blood sample was first taken at does not have this tool to test for HIV RNA. So they sent this specimen to a different laboratory, and we need to mention the laboratory name and the address as well. And sometimes the lab also will interpret the result, so it will give you, it will tell you if it's normal, if it's borderline, if it's low. But we always need to interpret it ourselves. We don't have to rely on these values, because we have sometimes errors. So we need to always double check. Here is another example. So can someone tell me here what is the most likely diagnosis in this patient? What do you see here? So we have the hemoglobin level. We have a hemoglobin level at 6.5. So this is a critical value. So this patient has severe anemia. Okay. So this patient, in the report, we can see the 2 stars, which is critical value. And in that case, the physician should be informed immediately about the result, because that patient should be hospitalized immediately. So we should not keep this patient at home. Moving now to the urine analysis. So sometimes you see a urine analysis lab report. So in the urine analysis, we always has to check the color. Why the color? Because sometimes the urine is dark, sometimes it's red. So when it's red, we need to suspect blood in urine. When it's dark, we need to suspect that the patient is dehydrated, so it's concentrated urine. When it's too white or yellow, so this patient is drinking well, he's not dehydrated. We need to check for if we have glucose in the urine, if we have bilirubin, if we have ketones. For example, if we have glucose and ketones, so for sure this patient has high glucose level in the blood. So when you see glucose in the urine and ketones in the urine, so for sure here we have uncontrolled diabetes. We need to check the pH. We also need to check the proteins. Proteins, for example, if the patient has chronic kidney disease, if the patient has long-standing hypertension, if it has diabetes, so this will cause loss of protein in the kidneys. So in the urine analysis, we can detect it in the urine analysis tests. It's very important to check for nitrite levels and leukocyte esterase levels. So these 2 tests, when we have nitrite positive and leukocyte esterase positive, so here we need to suspect urinary tract infection. So when we have nitrites and leukocyte esterase, so mainly it's a gram-negative bacteria. So we need to rule out an infection in that case. We need also to check for presence of red blood cells if we have red blood cells in the urine. So here we need to suspect hematuria, so blood in the urine. And we need to check for white blood cells. So when the white blood cells are elevated, as you can see here, so we have high white blood cells, 20 to 30. So in that case, the patient is having a urinary tract infection. So he has a nitrite positive, he has a leukocyte esterase positive, and he has white blood cells in the urine, and he has positive bacteria. So this patient is having a urinary tract infection. And in that case, we need to order a urine culture to know what kind of bacteria that this patient has in order to start the treatment. So here, the next step to do is to order a urine culture analysis in order to check which kind of bacteria does this patient have. Any questions for now? All is clear? Okay, perfect. You're hearing me well, right? عم تسمعوني مظبوط؟ Okay. So we will continue. So we need to know that the reference range for each laboratory test, we should have a reference range which will define the normal limits, because every laboratory test has a normal range. So the values between this normal range are considered normal. So sometimes we have high and low numbers. Here it will indicate that we have abnormalities. And how do we establish a normal range? So we do a lot of studies, so statistics and studies on a large population, and they check for healthy population, for example, the potassium level. They checked that for almost all healthy patients, they have a potassium level between 3.5 to 5. So now they consider that the normal range of potassium is between 3.5 to 5. So that's how we define a normal reference range. So now how to interpret potassium and sodium levels in laboratory tests. So here is the potassium. So we said when the potassium is between 3.5 to 5, so in the green colored area here, we have this is the safe zone. So here the potassium is normal. But when we go down, so it's between 2.5 to 3.4, here is a caution zone. So we have a hypokalemia. And when we go below 2.5, here is a very severe hypokalemia. So it's a danger zone. It's a critical value. So here we need to act immediately. We should not wait on this. When we have the potassium level above 5, so between 5.1 to 6, here it's also a hyperkalemia. So we have a high potassium level. This is a caution zone. And when it's go up above 6, so the red area here on top of the picture, so here it's the higher danger zone. So here also we need to consider it as a critical value because of the risk of complications. We'll see the complication associated with hypokalemia and hyperkalemia on the next slides. So you need to know that here is the cell membrane. So this is this is the cell membrane, and in the cell membrane we have like a channel which will allow for the movement of sodium and potassium. So here it's the extracellular space, so outside the cell, and here is the cytoplasm, so here is the inside of the cell. So here it's inside the cell. The sodium normally will go from inside the cell to outside the cell. So we have more sodium in the extracellular space as compared to sodium in the intracellular space. While the potassium, for the opposite, will go from the extracellular space and will go inside the cell. So the potassium is higher in the intracellular space as compared to the extracellular space. So just you need to know that sodium is higher in the extracellular space, while potassium is higher in the intracellular space. And this is because we have this channel which will allow for the movement of ions, sodium and potassium from inside to outside the cell. And when we see hypokalemia on the lab tests, so how to interpret the hypokalemia, especially if we have hypokalemia that is moderate and severe, because as you know, when we have severe hypokalemia or moderate hypokalemia, we have a risk of ileus. So ileus is when the intestines stop working and stop contracting. So we have severe constipation, and sometimes we can have GI obstruction, so gastrointestinal tract obstruction from the hypokalemia, because we need potassium inside the cell in order for this cell to contract and to preserve its function. So when we have very severe hypokalemia, we can have ileus, so GI obstruction, constipation, we can have muscle cramps, weakness, we can have arrhythmias, so we can have life-threatening arrhythmias or risk of death from the arrhythmia. And we can have also rhabdomyolysis, so we can have muscle breakdown as well due to severe hypokalemia. So when we see when we see hypokalemia, we always have to ask for urinary potassium as well. Here we're going a bit into the details. You're not supposed to know all of this, but you need to know that when we see severe hypokalemia on the labs, the next step we should ask for urine potassium level as well, because when the urine potassium level is low, we have different conditions causing hypokalemia as compared to a high urine potassium, for example. So, for example, when the urine potassium is low, we need to suspect loss of potassium from the GI tract, for example. So if the patient is vomiting a lot, or if we have diarrhea. So here we need to suspect GI loss, for example. While if we have high urinary potassium, here in that case, we need to suspect other conditions. So we need to ask different urinary tests and lab tests in order to reach the diagnosis. We'll not go deeper, but you just need to know that we have next step to do when we see a low potassium level in a blood sample. As opposed to hyperkalemia, so we said hyperkalemia mainly when the potassium is above 5.5. So here, when we see high potassium level, the first thing to do is to repeat the potassium level, because sometimes the tube is hemolyzed, and we said that the potassium is inside the cell most commonly. So when the tube becomes hemolyzed, all the cell will break down. So the potassium will go from inside the cell to outside the cell. That's why we'll have a high potassium level. So first, we need to ask the lab to repeat the potassium level in order to make sure it's a true hyperkalemia. Because a lot of time when we repeat, we make sure the tube is not hemolyzed. We see a normal potassium level. So it's very important to repeat it, because when we see hyperkalemia, the first thing we need to check is production issue. For example, if we have cell lysis, as we said, the tube is hemolyzed. If the patient is having increased potassium intake, so he's taking foods that are rich in potassiums, like banana, like tomato, so these food will increase the potassium level. Sometimes we have clearance issues, so we have problems in the kidneys, so the kidneys are not able to filter the potassium to the urine, so the potassium will accumulate in the blood, and this is the most important, is the most common cause of hyperkalemia, so chronic kidney disease or impaired kidney function. So this is the most common cause of hyperkalemia. So it's easy. Hypokalemia, we have workup to do, and hyperkalemia as well, we have different workup to do in order to reach the diagnosis. But the most important point here I want to stress on is when we see hyperkalemia, you always first thing to do is repeat the blood sample, make sure it's not hemolyzed. And if it's not hemolyzed, then we can say it's true hyperkalemia. And we need to check for the kidney function, because it's the most common cause of hyperkalemia. So chronic kidney disease or acute kidney injury is the most common cause. Clear for everyone? Okay, perfect. So what can go wrong when we have low potassium level or high potassium level? So what we fear the most is when the potassium goes up above 7. So you can see here the potassium is above 7, above 8, and above 10. So here the risk of death is very high. When you see a potassium of 8 or 10, we need to know that the patient can have cardiac arrest at any moment. So first on the ECG, so this is the heart tracing, you can see these are the T wave normally. When we have potassium going up, you can see that the T waves becomes peak. So we call this peaked T wave. So the P is the T wave. Yes, exactly, Muhammad. Elevated T wave, which we call it peak T wave. So the T waves become P wave, will become higher in amplitude. So it's higher. And when the potassium keep on going up, you can see that the QRS will be prolonged. So the duration of the QRS, this is the QRS, you can see that it's becoming wider as compared to this one, which is narrower. So it's becoming wider. And then when we move to values of about 10, we see a sine wave. So here, there's a systole. The patient here, for sure, he will go in cardiac arrest within seconds. So when we see this tracing in a patient, for example, with chronic kidney disease, here, sure, we need to suspect hyperkalemia even before doing the lab test. So when we see this in a patient with chronic kidney disease and dialysis patient, see this is called sine wave, and this the risk of asystole or cardiac arrest is very high within next minutes. So it's very critical condition, the potassium. We always need to make sure we have normal potassium levels. So how do we treat? So if the potassium is low, we can give per os, so we can give tablets of potassium. And if potassium is lower, so if we or if the potassium did not increase when we give tablets, then we can give intravenous potassium. So for example, we can put a quantity of potassium, 20 or 40 max, and 500 milliliters of normal saline, and we give them over 4 to 5 hours. So we can do this. We need to make sure we don't give potassium rapidly, because if we give potassium rapidly, the risk of arrhythmia is very high and the risk of death is very high. So potassium should be administered slowly, as if we're given it intravenously. While when the potassium is high, so here we need to give medications that can bind potassium in the GI tract in order to eliminate the potassium in the feces, in the stools. So here we have the K-oxalate, which is a medication that bind excessive potassium in the GI tract, and it will cause elimination of potassium in the stools. And when we see a very high level of potassium, so potassium above 7, above 8, we need to give calcium gluconate, because calcium gluconate will stabilize the cardiac cell membranes. And here we prevent arrhythmias. So this medication will prevent arrhythmia. And we can give intravenous insulin. Why we give insulin? Because insulin will cause the shift of potassium from the extracellular space. So when we measure the blood test, we take blood from the extracellular space for sure. So when we give insulin, the insulin will cause a shift of potassium from the extracellular space to the intracellular space. And that's how we can decrease potassium rapidly. So when we have very high potassium level, we need to give, for example, 10 units of IV insulin. So Mohammed is asking if we give dextrose plus insulin. Yes, exactly. So because here we're giving IV insulin, there's a risk of developing hypoglycemia. So here it's better to give dextrose. So we give 2 or 3 ampoules of D10 or the D50. You can give 1 ampoule, for example, with the insulin in order to prevent the development of hypoglycemia, because insulin is the most rapid way to treat hyperkalemia. So for sure, we need to give glucose with insulin. Thank you for asking, because I forgot to mention it. So for sure, we need to give glucose to prevent hypoglycemia with it. The most important two treatments are calcium gluconate and insulin when we're talking about hyperkalemia. So calcium gluconate to prevent the arrhythmias by stabilizing the cardiac cell membranes, and the insulin is to shift the potassium from outside to inside the cells. You need to make sure to check the blood glucose level and to give glucose with it to prevent hypoglycemia, as we said. So this is a summary about potassium, hypo, and hyper. Now we move to sodium. So sodium also we have low levels and we have high levels. We said the normal levels of sodium are between 135 and 145, plus or minus 2, depending on the labs, different labs. But we're not going to the details because it's very complicated. Here we just need to know that when we have low sodium in the blood, you always need to check the serum osmolarity. So we need to ask the lab to do the serum osmolarity. So most of the cases it's low, unless in the case of hyperglycemia, it will become high. So when we have high glucose level, the concentration of sodium in the blood will become lower, so we will detect hypoglycemia, hyponatremia. But in all other cases, when the glucose level is normal, so when we have a normal serum osmolality or low serum osmolality, we have different diagnosis. And in that case, we need to order urine osmolality also to differentiate. So you can see we have different differential diagnoses, but the most common cases are chronic kidney disease, like we said in the case of potassium, hypovolemia, so when we have loss of fluid or when the patient is dehydrated, sometimes the sodium will go down as well because of the loss of fluid. Sodium sometimes will go with water, so we have loss of sodium and water. Sometimes the patient is using diuretics, so if the patient is hypervolemic and is on diuretics, so this is a medication to drop the excessive fluid in the body and eliminate water and sodium in the urine, so the sodium level will become lower. If the patient is vomiting a lot, also sometimes the sodium goes down. So we have a lot of conditions. We have a condition called psychogenic polydipsia. So here the patient is drinking a lot of water. It's a psychological or psychiatric condition where the patient start drinking a lot, even if he's not if he doesn't need water, he will drink a lot. And when we have excessive water, what will happen to the sodium? So the sodium, we have the same quantity of sodium, but what we measure in the lab is the concentration of sodium. So the concentration of sodium will drop. So we'll have low sodium, not because we have low quantity of sodium, but the concentration of sodium is lower because we have excessive water around it. So here we're measuring the concentration. So as we said, chronic kidney disease, hypovolemia, diuretics, vomiting, and psychogenic polydipsia. These are the most common causes. And don't forget to always measure hyperglycemia, the glucose level, when we see low sodium, because it's associated sometimes with hyperglycemia. You can see hyponatremia. So it's very important to measure glucose when you measure sodium as well. Moving now to hypernatremia. So hypernatremia is a bit different. As we said, for hyperkalemia, always ask for a repeat. Do not start treatment before you confirm. So when we see sodium level, for example, of 160, here we need to ask the lab to repeat the test and to make sure. When we repeat the test and we confirm it's a true hypernatremia, then we can confirm the diagnosis. And to go further to look for the etiology, here you can measure urine osmolality. So when it's above 600 or when it's below 600, it's not the objective of our talk today, but you just need to know that there's different workup to do. And the common causes are GI losses, for example, diarrhea and vomiting. Sometimes can cause higher level of sodium to compensate. Skin loss, for example, burn patients tend to have hypernatremia because these patients are dehydrated. So the concentration of sodium becomes higher because we have less water in the system. So these are the most common causes. So GI losses and dehydration. Any question on this before we move to anemia? Any questions or clear? Okay. No questions. Okay, great. So now we will just talk a bit about anemia. So anemia is very important because it's very common. Most of patients tend to have anemia. Some of them have mild anemias. Some of them have severe forms of anemias. So you need to know that in the blood we have a molecule called transferrin. So this is transferrin molecule, and this is the black molecule inside is the iron molecule. So in order for iron to move inside the bloodstream, we need to have transferrin, and transferrin is secreted by the liver. So transferrin is the vehicle, if you want. It's the carrier of iron inside the bloodstream. So it's very important to have an intact kidney in order to produce transferrin in the blood, in order to transport the iron molecule, because iron is very needed for the metabolism of different organs. And also iron is present in the hemoglobin. So for oxygen transportation to the peripheral organs, it's very important. So we need iron to have adequate values of iron. So when we see anemia, so when the hemoglobin level is less than 12.5 or less than 13, here we have anemia. So low hemoglobin and low hematocrit. The next step to do is to check on the MCV. So we call the mean corpuscular volume. So this is a test that we do systematically. All labs will do it systematically when they measure hemoglobin. So when the MCV is low, here we need to suspect iron deficiency and thalassemia. So this is the most common cause, iron deficiency and thalassemia. So when the MCV is normal is between 80 to 100. Here we need to suspect early bleeding. So in the early stages of bleeding, hemolysis, bone marrow failure, and anemia of chronic disease. So most commonly, if it's anemia of chronic disease when the MCV is normal. While when the MCV is high, so when the MCV is above 100, here we need to suspect different etiologies. So here the two most common causes are the B12 deficiency and folic acid deficiency. So folate deficiency is vitamin B9 deficiency, and this is seen most commonly in alcoholic patients. So if a patient drinks a lot of alcohols or these kind of things, so these patients will tend to have low B9 level or low folate level, so they tend to have anemia. And when the vitamin B12 is low, so here most commonly in patients that are vegetarian, so they don't eat meat at all, these patients will have also anemia due to low vitamin B12 deficiency. So a hemoglobin level to start, then after that we need to look for MCV in order to differentiate the different etiologies of anemia. So we said we look for MCV. When the MCV is low, it's microcytic. When the MCV is normal, it's normocytic. And when MCV is high, it's macrocytic. And after the MCV, you always need to look for also another lab test, which we do systematically as well, which is the MCHC. So we have also different differential diagnosis, but we're not going to go into the details. I just want you to know when you check the hemoglobin and it's low, so the next step is to look for the MCV, the mean corpuscular volume, and to see if it's low, if it's normal, if it's high, because this is that will lead you to the accurate diagnosis. So here is also another table. So here we're talking about iron deficiency. So iron deficiency anemia, here the problem is that we have low iron level. The transferrin, which is the molecule that is responsible for the transportation of iron in the blood, is normal because the liver here is normal. There's no problem in the liver. So in order for the liver to compensate this low iron levels, the liver will start to produce more transferrin in order to bind the iron that is present in the blood to the maximum. So when we see low iron and high transferrin levels, so this means we have iron deficiency anemia. It's the only condition that will give you low iron and high transferrin level, which is iron deficiency anemia. So iron deficiency anemia comes from malnutrition. It will come also for chronic blood loss. We can have iron deficiency anemia. Most common cause is blood loss, especially in females, premenopausal females. We always tend to see iron deficiency anemia due to menstruation blood loss. So when we see low iron, high transferrin, so here it's most commonly it will be iron deficiency anemia. And ferritin is the indicative of the iron stores in the body. So when the ferritin is low, so we need to confirm that the patient has iron deficiency because he has depleted stores, so the iron here is very low. And when you see a serum ferritin level of less than 30, this is very sensitive to diagnose iron deficiency anemia. So when we see hemoglobin, always look low hemoglobin, always look for MCV. And when we see low MCV, always ask for iron, ferritin, and transferrin levels in order to confirm iron deficiency anemia. Because here the treatment is very easy. So when we diagnose it, we can start medications. So we can give iron supplementations, tablets for us, or we can give also intravenous iron supplementation as well. Clear? The anemia part is clear. Any questions? Okay, clear. Great. So now we will move, we'll just also talk a few slides on renal function. So this is the kidney. So the kidney will contains a lot of nephrons inside. So the nephrons are responsible of filtering. So here the nephrons are contained here. They are responsible of filtering the urine or the toxins present in the urine. So the main functions are control of solutes and fluids, so control of sodium, potassium, and other solutes and fluids, control blood pressure, control acid-base balance, control drug metabolism, because as you know, a lot of drugs are excreted in the kidneys. So the renal function is very important, especially when the patient is on a lot of medications, because there's a risk of kidney injury due that all these medications are acting altogether on the kidney at the same time. So the risk of acute kidney injury becomes high in such patients. It's very important to know that the urea, BUN, and creatinine levels, so these two markers are the markers of kidney function. So when we see a creatinine level between 0.7 to 1.2 milligram per deciliter, this unit is used in the US. Some other countries, they use the micromole per liter, but you should always look for the unit. So normally it's between 0.7 to 1.2. Values of above 1.2 are considered elevated creatinine. So we have here decline in kidney function. While when we see low creatinine, so usually we see low creatinine in a dehydrated patient or malnourished patient, a patient that does not have muscle mass, because creatinine is a part of muscles. So when we see a patient without muscles or very thin patient, so here's for sure the creatinine will be low in such patients. It's very important also to calculate the creatinine clearance. So we have two formulas. We have the MDRD and we have the CKD EPI. So these, the lab usually will calculate it for us. So we don't have to go into the details of this formula. It's a very complex formula, but every lab should put the creatinine clearance value below the creatinine, because I will tell you why. Because when we want to classify the chronic kidney disease, we classify it based on GFR, so glomerular filtration rate or creatinine clearance. We don't classify it based on creatinine value. We always have to calculate the GFR. And you can see that when the GFR is above 90, it's a normal kidney. But when the GFR starts to drop, so it's from 90 to less than 15, so we become in stage 5 when the GFR becomes less than 15, and this is a stage of kidney failure. And if we keep this patient untreated, this patient will progress to dialysis. So it's very important to calculate the GFR, because based on the GFR, you can have an idea about the stage of chronic kidney disease that this patient have. Another important thing about the GFR, don't look here at numbers, I will just briefly explain it. So the most important thing about GFR is to adjust the dosages of the medication. So for example, this is an antibiotics. Most antibiotics, they act on the kidney, so are renal elimination. So the dose of these antibiotics should be modified based on the GFR or clearance, the creatinine clearance of this patient. So for example, here is an antibiotics called piperacillin tazobactam. It's an antibiotic, it's a broad spectrum antibiotics used to treat infections, severe infections. So when the creatinine clearance is above 40, here we should not change the dose. We keep the dose as it is. So if we talk about nosocomial pneumonia, so pneumonia acquired in the hospital, the dose is 4.5 Q6 hours. So every 6 hours we need to give him 4.5 milligram of piperacillin and tazobactam. But for example, if the creatinine clearance drops below 20, so we're here, in that case, the dose should be modified, and it will become 2.25 milligram every 6 hours. So here we reduce the dose to half, from 4.5 Q6 to 2.25 every 6 hours. So it's very important to not just look on the creatinine. We need to also calculate the creatinine clearance. Normally the lab will do it for us. If not, you can find the formula, or you have it on the internet. You just type creatinine clearance calculator and you can calculate it easily using the apps and the formulas. So clearance is important to classify chronic kidney disease, and it's important also to adjust the medication dosages, mainly the antibiotics dosages. Glycemia is also very important. So blood sugar levels in diabetes patients, we need to make sure the patient is having the blood test in the morning. So fasting blood test should be no diabetes when you have blood sugar less than 100 milligram per deciliters. Pre-diabetes are patients that are predisposed to become diabetics if the patient doesn't change his lifestyle or doesn't receive treatment. So when the glycemia is between 100 to 125, and when we find a fasting blood sugar level above 126, here we can confirm diabetes. Same for hemoglobin A1C. So when the A1C levels are normal, so hemoglobin A1C, it's like the average values of glucose in the last 3 months. So when the level is less than 5.6%, so here there is no diabetes. Pre-diabetes is 5.7 to 6.4, and diabetes is above 6.5. So combination of these two, fasting blood sugar and hemoglobin A1C. So when we have fasting blood sugar above 126, and hemoglobin A1C above 6.5, we can confirm the diagnosis of diabetes, but we need to make sure that the test was performed in the morning before eating. Okay, so now any questions on laboratory test interpretation? I will now move to how to interpret chest X-rays. We'll talk briefly about it. Any questions till now on laboratory tests? It's clear? Okay. No questions. Great. So we'll just have a few slides about chest X-ray and CT scan interpretation and how to analyze the report when we see it. So this is a chest X-ray, so for every patient. Can someone tell me what is the structure here on this red arrow? What is the structure? Does anybody know? What is the structure? Okay, exactly. Zainab is said in and Muhammad as well, the trachea. So this is the trachea. So we have the trachea will bifurcate, will give uh, the right trachea and the left trachea. Here we have the ribs. So we need to look for rib fractures. We can here we see the ribs are intact. There is no fractures. Here is the right lung, and here is the left lung, and this is the heart. And you always have to look on this space here, particular space here. It's called the pleural costophrenic angle. So when we have pleural effusion, this space will be filled with fluid. So when we see the angle clearly, we can confirm there is no pleural effusion. So the patient is not overloaded. He's not having any condition. So this is a normal chest X-ray. So the trachea is not deviated. It's in the midlines. You can see the two lungs that are expanded. You can see the ribs clearly. There is no rib fracture. You can see the heart. The heart is not enlarged. So this is the heart from here to here. There is no heart enlargement. And you can see the costophrenic angles here. So this confirms that there is no fluid accumulating in the pleural space or in the lungs. Okay, so this is the normal chest X-ray. So always this is a summary of what we said. We'll move on. So can someone tell me here what is the problem? So this one is a normal chest X-ray. The second one is a bad inspiration chest X-ray. So the patient did not take a good inspiration when we took the image. Can someone tell me how did we know that this is a bad inspiration chest X-ray? On what are the signs to indicate that? Any answers? Okay, Dua is saying that the heart is enlarged. Yes, it's a bit enlarged. It's not enlarged a lot. But there's another sign that confirms that the patient here did not take a good inspiration when we ask him to do it. And we need to mention this in the report. And when we analyze the report, we need to mention that that X-ray was done in a bad inspiration. So if you count the number of the ribs here, we can see just 1, 2, 3, 4 ribs. So normally, if you look on the normal one, so we have more ribs. We have 6 ribs that are visualized. So here the patient took a limited inspiration. Muhammad is saying that we have disappearance of costophrenic angle. Yes, a bit. There's a bit of, we don't see it clearly, but here the patient is the problem is that the patient did not take a good inspiration. So you will have the appearance that the angle has disappeared. So here the angle, we don't see it clearly. But here the problem is that the patient did not take a good inspiration. So less number of ribs. When we see low number of ribs, you can confirm that the inspiration was not adequate, and you note this in the report. So the radiologist will write it in the report when the patient did not take a good inspiration. What is the problem here? So I will always show you a normal X-ray. So this one is normal, and the abnormal one will be on next to it. So what do you see as abnormal in this chest X-ray? What is the condition here? Any answers? So here, do you see the angle? The angle that we mentioned, the costophrenic angle. So Here we don't see it on the right. There is disappearance of this angle. All of this is fluid. Yes, so it can be a right lung collapse, Zainab. It can be, but in that case, it was a pleural effusion. So exactly, Abdullah, he said it's a pleural effusion. So here we have accumulation of fluid in the right lung. And you can see in the next, on the other lung, there is no fluid. So here we just have a unilateral pleural effusion. So we just have unilateral fluid accumulating in just one lung. The second lung is normal. We don't have any accumulation of fluid in the costophrenic angle. And here the patient took a good inspiration because you can see we have a good number of ribs that are appearing. So we have 1, 2, 3, 4, 5, 6, 7, and 8. So the patient took a good inspiration, but the problem here is that we have a right pleural effusion. Here, if you look on the left one, the patient has this one. Yes, Zainab, there is a mediastinal shift. There is a bit of mediastinal shift towards this lung. You're right. You're right. This patient here, anyone want to comment on this patient? What do you think this patient is having? What is the problem here? Okay. Okay. So this patient is having accumulation of fluids. So we call this acute pulmonary edema. Pulmonary edema. You can see all of this is fluid accumulating in the vascular lung space of the lung. So this patient is most probably having heart failure, acute heart failure, because when you have heart failure, all the fluid will accumulate in the lungs. So this is most commonly acute pulmonary edema. So we need to check the report if we have if it's written or not. And this device here is it's a defibrillator device, so most commonly, or a pacemaker. So most commonly, this patient is having heart issues as well. That's why he developed acute pulmonary edema. The next one, anyone want to interpret? What do you see here? Any abnormalities on the X-ray on this one? On this X-ray, any abnormalities? So the first one is a normal X-ray. The second one is a pathologic X-ray. So what do you think here? What do we have here? So this is not a pleural effusion because we see that the angle here is preserved, the costophrenic angle is preserved. So there's no pleural effusion. Here is a consolidation, so we have infiltrates in the lung. So this is a pneumonia. So we have a bacterial infection of the right lobe. Yes, Abdullah, and Abdullah is saying pneumonia. Exactly, this is a case of bacterial lobar pneumonia. So it's affecting the lower lobe of the right lung. So this is a right lower lobe pneumonia X-ray. So here I will tell you, if you look here, you can see that the heart is enlarged. So the diameter of the heart is enlarged. So this is a case of cardiomegaly. So it's a cardiac patient also. You can have an indication from the X-ray when you see the heart is enlarged. And how to confirm that the heart is enlarged? You measure the heart diameter and you measure the thoracic diameter. When the heart diameter is less than half of the thoracic diameter, so there is no cardiomegaly. But when the heart diameter is above the half of the thoracic diameter, so in that case, we have cardiomegaly. So in that case here, there is no cardiomegaly, and in the report, we can say that the heart has normal size. So, and how this is how we do it. Zainab is saying that there's cardiomegaly with valve replacement exactly. So this is an aortic valve. This patient had an aortic valve replacement exactly. Excellent comment. So there's a valve. The patient has a mechanical valve because he had a severe aortic stenosis, and we can confirm because we can see here the strictures. So this patient has an open heart surgery. You can see here are the sutures that remain after that. Excellent, Zainab. Good comment. Okay, so how does how the report of a chest X-ray should look like? So we should, we should note all these findings. So we talked about cardiomegaly, we talked about pneumonia, we talked about pleural effusion, we talked about good inspiration, bad inspiration. We should note all of this here. And the impression, it's like the conclusion. So mild pulmonary edema, for example, the radiologist will write this. He can, the observation, he can mention organomegaly, lung opacity, atelectasis. So this is how the report of a chest X-ray should look like. Okay. We'll talk a bit about the scan now. We'll just, like we did for chest X-ray, I will show you a few examples about CT scans, and we'll try to interpret them and try to write a report at the end. So we need to know that the scan of the brain, if you look, this is a normal CT scan of the brain. The white color here is bone, and we call this hyperdense. So it's hyperdense because the color here is more dense than the normal brain tissue. And the brain tissue you see here is isodense, so it's a normal density. This is how the tissue should look like. And the fluid inside here, we call it hypodense, so the density is less than the density of the brain. So this is the cerebrospinal fluid. So it's like the fluid circulating inside of our brain, in the ventricles of the brain. So you just need to know three things: hyperdense, which is the bone; isodense, which is the brain tissue; and hypodense, which is the cerebrospinal fluid circulating in the brain. These are the three main components in order to understand and to interpret and analyze the CT brain report. So hyperdense, isodense, and hypodense. Also, when we look on the brain, you need to know the different lobes contained in the brain. So here you have the frontal lobe, we have the right frontal, which is here, we have the left frontal, which is here. So we have lobes on each side, the temporal lobe, we have the insular lobe, and we have the occipital lobe. So we have right-sided and left-sided. So the right-sided is here, the left side is here. It's always the opposite on what you see on the screen. So the right is on your left and the left is on your right. So these are all the brain lobes that we should note on our report. And if we find, for example, a bleeding in the temporal lobe, I will show you example. We need to write temporal lobe hemorrhage or bleeding in the report. So we need to know how to divide the brain when we see a CT scan. So hyperdense, isodense, and hypodense, and you need to know how to locate the different structures. This is a summary of the CT brain. So the hypodense structure, we call it, it's cerebrospinal fluid. It will circulate in the ventricles. So we have ventricles in the brain like carriers for this fluid. It will allow for the circulation of the fluid between different brain parts. Sometimes you can see calcification. So calcifications will look like bones. So like the bone we see here, you can see sometimes calcium inside the ventricle. We see this in patients with older age. So anyone wants to comment on this scan? So can someone tell me what lobe of the brain is this and what do we see here? Any idea? Okay, so here if you look on, yes, exactly, Amal and Abdullah, they are saying it's occipital lobe, exactly. It's occipital and temporal, and it's a right lobe, exactly. So it's on the right. So here it's the right, and here it's the occipital part, and here it's the temporal part. So here we have hyperdense signal in the right occipital and right temporal lobes. And yes, exactly, Afnan, it's occipital and temporal. So we have blood. So because we said bones should look hyperdense, but blood also has a hyperdense signal, but a bit less than bone. So here we confirm it's blood, not bone. For sure, we won't have bone in this area. So this is for sure blood. So occipital and temporal right lobes bleeding in the brain. We can have different types of blood and bleeding in the brain. We can have the subdural hematoma. So subdural hematoma is due to rupture of veins. So this is a venous Okay, Amal is saying there is also yes. Okay. You're mentioning here that we have a shift. We have the shift midline shift in the brain. Yes, we'll mention this in the next slide as well, if I understood right. Yes, exactly. So here it's an epidural hematoma. Here is an epidural hematoma, and here is a subdural hematoma. So the difference, we have the shape difference. So the subdural hematoma has a concave or crescent-like shape. So here it's like a crescent, while the epidural hematoma has a convex or lens-shaped. So to differentiate here, the problem there is, the blood is originating from veins, while here the blood is originating from arteries. So here it's more dangerous because there is arterial origin of the bleeding, while here it's a venous origin of the bleeding. And usually the subdural hematoma, you can see it in older individuals, so fall on his head, he present to the emergency with a subdural hematoma. So this is a disease of the old individual. It's due to venous bleeding, while the epidural is due to arterial bleeding. So here is the difference. So this is the subdural. So you can see it has a crescent or banana shaped, while the epidural it has a convex or a lens shape. So it's look like this. So this picture is just to memorize. Okay, here what do we see here? Tell me if it's on the right, on the left, the pathology, if which lobe. And what do you think is going on here? Tell me if it's hyperdense, hypodense. Any answers? Okay. Subarachnoid hemorrhage, someone is saying. Safora is saying subarachnoid hemorrhage. Amal is saying right MCA infarction. Okay, I agree with Amal. This is an infarct. It's not a bleeding, because bleeding, we said it should be hyperdense. Here it's hypodense, exactly. Excellent answer. So here it's a hypodense signal. So this is an infarct. And most common, it's a middle cerebral artery infarction. So here it's a stroke. It's an ischemic stroke, this area. It's an ischemic stroke. As you compare to this normal brain, there's a normal brain tissue. Here we have hypodense tissue. So here we have an infarct, an MCA infarct, exactly. Just a few slides and we finish. So here we have a midline shift, because we have here, this is a subdural hematoma. So there's high intracranial pressure. This fluid, blood here causes the shift of the midline of the brain. So we have what we call midline shift of the brain towards the other opposite side. So when we see this, we need to say that we have with that we have a high intracranial pressure. Yes, it's a right subdural hematoma, exactly, as you said in the comments. Here is also a midline shift, because we have an excessive hematoma forming here, and so we have a midline shift towards the opposite side. So here we're going into a more critical condition. The CT brain can also give us indication of brain tumor. So if you look here, we have a tumor here, we have tumor here, tumor here. Sometimes so we have different signals here. This is an injected CT brain with contrast. That's why we see the tumor as hyperdense. Usually we see it hypodense. But here it's a patient with lung cancer with brain metastasis. So the patient has different location of brain metastasis, and this patient should receive radiation therapy in order to treat all of these brain condition metastasis. So, and this is how the report should look like. I'll finish in 2-3 minutes. We'll finish, and we'll. I just want to mention a few things, and we'll finish. Yes, Amal is saying that it's a right frontal mass with surrounding edema, exactly. So it's the mass here, the most big one. Actually, it's a metastatic lesion, and this is edema surrounding it, exactly. So the edema will look like hypodense surrounding the mass. Due to inflammation in this area, you will see edema around it. There's a risk of seizure here because of the edema, so we need to follow up this patient on regular intervals. So the CT brain, here is the CT brain. So we need to mention the technique. If it was done on a multi-detector scanner, what type of scanner? If it was an injected, so with contrast or without contrast, we need to mention this in the report. All the findings we discuss here, we need to mention them in the findings. So the normal and the abnormal things, and in the impression, it's like the conclusion. We either say it's normal, or we said it's abnormal, and we mention what is the disease, and it should be signed by 2 radiologists and by the radiologic technicians that performs the CT. So it should contain 3 signatures. This is very important. It should be signed by 3 signatures at the end. So last brief topic will be about the CT scan of the chest. So you can see on the scan we told about the chest X-ray. Here the CT chest. So here we have the lungs, right lung, left lung. Here we have the trachea. So this is the trachea. These are the most important structures. So here, as you have the what is white is hyperdense, so bones, as we said, bones. What is white is bones or blood, and what is black is hypodense, it's air. So here in the lung we have air, and here we have bones. Okay, so like the brain, exactly like the brain, but here we have air, and the brain we don't have. So the black tissue here is air, so in the lungs. So when we go down a bit down, you can see, you start seeing the aorta. This is the ascending aorta here. Okay, this one is the ascending aorta, and this one here is the descending aorta. So any pathologies, dissections or dilation or aneurysm, you can start to detect them here. So here is it's hyperdense because it's blood. So blood is hyperdense, but it's a bit less dense than bones. So here are the bones. Here are the blood, so it's a bit less dense than bones. And if we go down more and more, you can start to see the pulmonary artery. This is the pulmonary artery. It will divide into right pulmonary artery and left pulmonary artery. So it's very important here to check for blood clots. When we have pulmonary embolism, we need to check for blood clots. And if you go down, you start to see the heart. This is the left ventricle. This is the right ventricle of the heart. And this is the descending thoracic aorta here. So we can see different structures. Can someone tell me here, what do we see? What is this pathology here? Any idea? So this is the right lung here. This is the left lung. This is the heart here. And what do we see here? What is this? And what is this? Yes, Ala is saying it's a pleural effusion, exactly. So here it's a bilateral pleural effusion, but it's a pleural effusion that is more common on the right. So the effusion is larger on the right. So here is the right. We always said it's the opposite on what we see, right and left. So here it's right effusion and left effusion. It's more common on the right. Here is the last slide. So what do we see here? This is the aorta, ascending aorta, and this is the descending aorta. So you can see that we have a rupture here of the aorta. So this is aortic, what? Yes, exactly. This is aortic dissection. Excellent. Excellent interpretation of this scan. It's a case of aortic dissection. It's a life-threatening condition. So we need to operate this patient immediately. The death rates are very high. Okay. This one here, you can see this is the last case. This is the right lung. This is the left lung. Here is the aorta, ascending, descending. This is the pulmonary artery here. Sorry, it's the pulmonary artery, so PA. And what do you see here in the pulmonary artery? What do we have? Yes, excellent answers. Ala and Amal, excellent answers. You can see a clot, a large clot here. This is a clot. So the clot will look hypodense. It's a thrombotic clot. So there's something occluding the pulmonary artery, mainly the left pulmonary artery here. So this is a case of pulmonary embolism. And you can see there's another clot here more distally on the right pulmonary artery. So this is a case of bilateral high-risk pulmonary embolism because it's a proximal pulmonary embolism and the proximal division of the pulmonary artery. So this is a very high risk, should be hospitalized, and we should start him on anticoagulation directly. So these are the two most dangerous condition. And that was it for my presentation. If we have any questions, you can ask me now before we move to the next presentation. Any question? It was clear? Okay.
Okay, thank you. And we will proceed with our next part of the terminology. We are going to complete the basics of terminology, and I want to just to know if the slide is clear for you and you can hear me again. Yes, please. Okay. So we talked about from the beginning the conditions and the abnormal conditions and the blood and the urine conditions, okay? There is no photo. Oh, sorry. Okay, let us. Now, do you see the photo now? Okay. So, to continue with the terminology, okay, we refer to the, we are still talking about the prefixes, okay? RIA, which means discharge, okay? And when you add to that RIA a G for gal, it becomes rage, okay, or ragia, which talks about excessive blood discharge, okay? Sclerosis is talking about hardening. So any tissue in the body that become hardened, we call it sclerosis. Like when we say atherosclerosis, يعني hardening of the blood vessels. احنا we are referred to the تصلب الشرايين, okay? Stenosis is abnormal narrowing, okay? There is difference between constriction and stenosis. The constriction might be a temporary state, while stenosis, it refers to permanent change in the internal lumen of a vessel in the body, okay? So we have RIA, ragia, or rage. We have sclerosis, and we have stenosis, okay? So those are four suffixes that represent four different meanings, okay? So when I say discharge, I'm talking about RIA, like diarrhea or otorrhea, okay? Excessive discharge of blood, otorrhagia, like when there is a blood coming from the ear, okay? Sclerosis, which is the hardening, and stenosis is the narrowing, abnormal narrowing. Do you see the slide moving? Because I am afraid that the slide might not be moving as well. It is not moving.
Mr. Amin, you need to put full screen, I think. أنا هيك كانت عندي المشكلة. Try full screen.
Is it full screen now? Not moving. طيب. Is it okay now? Still? Let me do something. Is it okay now? Still? I don't know what's the problem. I'm trying online. Now is okay? Okay, so we were talking about, thank you for your support, for your interaction, okay? So we were talking about RIA, which is discharge, and RAGIA, which is excessive blood discharge, and we were talking about sclerosis, which talks about hardening, and we talk about stenosis, which is abnormal narrowing, okay? Abnormal narrowing of a vessel of anything that is tubular in the body, okay? We will just keep moving. So megaly talks about enlargement, okay? So when you say cardiomegaly or hepatomegaly, we talk about enlargement of an organ. Spasm is a constriction, okay? Like a vasospasm, which is a constriction under the effect of any stimulation, or maybe sometimes sympathetic response, something get spasmodic, okay? Or inflammation. Right. When we talk about ectasia, okay, or ectasis, we talk about widening, a space in a body that gets widened, okay? So enlargement اللي هو التضخم ميجالي، والسبازم اللي هو التضيق، اوكي، او الانقباض بصورة ادق. ectasia or ectasis we talk about widening اللي هو توسع. Penia, okay, always related to deficiency, okay, which is يعني loss of something or loss of decreasing component in a body, okay. If something enlarged, if the liver enlarged, what do we say? Megaly. If something is constricted, طيب, if something is widening or dilated, ectasis. And what does deficiency related to? Pnea, okay? Excellent. طيب. Here we have an example of a condition, we call it thrombophlebitis, okay? So we have the first medical or body part is the thromb, which related to infarction, okay, or a clot. A combining vowel, which is O, and the flap is always related to vein. So when we say the thrombophlebitis, we are talking about the inflammation and the clot in the vein, okay? It could be due to trauma, and it can be due to other causes. But if there is a thrombus that is associated with inflammation in the vein, the condition will become thrombophlebitis. So the disease is the thrombus, the location is in the vein, okay? And the situation here is inflammation, okay? So it's an inflammation because of the presence of a clot in the vein, okay? So this is how do we combine a medical terminology, okay? طيب. DVT, which is related to deep vein thrombus, or we call it deep, yeah, okay? It is a condition where a clot might be developed in the large veins. So when we say phlebitis or thrombophlebitis, it's a vein thrombus with inflammation. But here it is only a clot, okay? It's only a clot. But with the presence of the clot, sometimes there might be some inflammation and there will be congestion of the surrounding capillaries, which will lead to dilation, which will lead to accumulation of blood, and that will lead to swelling and hotness around the DVT. Okay, so how do you know that your patient has a deep vein thrombus? His limb will be swollen, منتفخ, will be red in color because of the congestion of the blood, and will be hot because of a combination of an inflammation and pooling of blood in that area. Okay, so this is a deep vein thrombus or thrombosis. So we used, okay, basics of medical terminology, part 4, which will be the last part for the combining medical terminology, are the prefixes. احنا اتفقنا انه suffixes, they are the part that end the word, okay, or it comes at the end of the word or at the end of the medical part. Here the prefixes they come before. فالprefixes هي عبارة عن جزء من المصطلح الطبي يأتي في المقدمة. It comes at the beginning. So the prefixes are a small part beginning of word. we talked about root, which is related to the body part. We talked about combining vowels, which are O and I. We talked about suffixes that are related to diagnosis or disease process or procedures. And now we talk about the prefixes. We talk about the prefixes, okay? So in the prefixes, we have number prefixes. يعني it's a prefix that relate to numbers. يعني هذا السابق أو الجزء اللي يسبق المصطلح يرمز إلى الأرقام أو الأعداد. When I say nully means zero, nothing. Sorry. When we talk about uni or mono, it means one or one side. Okay? When I say unilateral means it is only in one area. And this is always related to areas of the body that has two areas, like lungs. We have right lung, left lung, okay? Now when we say unilateral, okay, it means on one side only. Okay, mono means in one place, okay? Bi and di means two, اثنين, okay? Tri is for three, tetra or quadri is for four things, يعني four numbers or four areas, and 10 it's deci, okay? And many is multi or poly. When numbers are too many, we refer to as multi or poly. When we say polyneuritis, يعني there is inflammation in too many areas in the kidney. Okay, so this is the prefixes that talk about numbers. Okay. Unilateral fracture or rash. What does that mean? There is a unilateral fracture because I have two legs or 2 feet, يعني two sides, right and left, but the fracture happened only in one side. Okay? Of course, I can say right foot fracture, and then you understand it's uni, okay? But here, when you talk about rash, it's only in or on one side. That's why we call it unilateral rash, unilateral fracture. And why do we say unilateral? Because I have two sides. I have left lateral and I have right lateral, okay? So when I use uni, means it's only on one of both sides, okay? Bi, tri, and quadri. So we use bi to refer to the muscle that has two heads, okay? This muscle, okay, is the biceps. And why we call it biceps? Because it has two ends or two heads. While the triceps, it has three tendons or three heads, two at the up and one near the elbow here. That's why we call it triceps. While the quadriceps is the muscle of the thigh, and we call it quadri, means it has four heads. العضلة رباعية الرؤوس، العضلة ثلاثية الرؤوس، العضلة ثنائية الرؤوس. So bi, two, tri, three, and quadri means four. Okay? Directional prefixes, okay? When it هذا تشير إلى الاتجاهات. This is referred to directions, okay? The first direction is surrounding. Surrounding means it's around the organ. It surrounds the organ from all directions. Okay, we call it peri. Example, when we say pericardial. Pericardial or pericardium is the sac that covers the heart entirely. So it is surrounding the heart. That's why we call it pericardium. Peritoneum, okay? It is the structure that surrounds the whole abdominal organs. We call it peritoneal. Okay. When I say through, يعني it goes within, من خلال dia وper وtrans. When I say transvenous, it is through the vein. Okay. When I say parenteral, okay. When I say, okay, so this is exactly how we use the term. So it is through. Against is anti or contra. They say antibiotic. Okay. Between is inter. Okay. We say intercostal means between the ribs. Okay. واضح? Those are the prefixes for directions or directional prefixes. If you put peri, it's around. Dia, per, trans is through. Anti, contra, against, and between is enter. Okay, so those are the prefixes اللي هي مصطلحات قصيرة توضع قبل المصطلح الطبي لتعطي معنى معين. Okay. When I say peritoneal, okay, perinasal and periumbilical, okay, so peri means surrounding, okay, surroundings. When you say percutaneous, it is through the skin, okay, perrectal, okay, through the rectum, peroral, this is for PO, okay, من خلال الفم, transdermal and transhepatic, okay. So this is exactly how we employ those prefixes. So that's why, because they come before the medical, before the root, we call them prefixes. Okay? So when I say perioral is around the mouth, the area that is surrounding the mouth, we call it perioral. Perinasal is around the nose, and periumbilica is around the umbilica, okay? Percutaneous through the skin, perrectal through rectum, and peroral is through the mouth. Also, you have the transdermal, something through the skin, and transhepatic through the liver, okay, through the liver. So those are the prefixes. We need to memorize them in order to use them in the proper location, okay, and to understand them when we are exposed to them. Right. Classic exercise. Find a sentence with one prefix word and share with the class. Give us a sentence with one prefix word. أعطينا مثال على prefix. Give us an example. Put it in a meaning, okay? بشاير, you said pinia. أعطينا عليها example. طيب, if I said thrombocytopenia, what does it mean? Osteopenia. Thrombocytopenia is decreased number of platelets. Osteopenia is the thinning of bone. Okay, so that refer to pericardial. ممتاز. هذا pericardial effusion from أمل. It's effusion around the heart. So it's pericardium is the sac, is the anatomy. Pericardial is the term that refers to pericardium, and effusion is the fluid that collects around the heart. Okay, excellent example. Okay, so this is a pericardial effusion. It means a collection of fluids around the heart. Okay, around the heart. So this is the peri is the prefix that refer to a terminology. Okay, thank you for this. Bradycardia. لا, brady means slow. Okay, ممتاز. Okay, وتكي means fast. Also, this is another example of prefix. Let's continue with directional prefixes above, like supra, epi, hyper. Okay, means up or high. Okay, example, suprarenal gland. Okay, epicardium, epigastric. This is all up. Hypercalcemia means potassium is sodium, or hypercalcemia, hyperkalemia, hypernatremia means electrolyte level is up. Okay, below is sub, like subdural, infra, and hypo. Okay, those three prefixes refer to below. Okay, so when you have suboptimal, يعني it is less than optimal. Okay, طيب. Inside is intra or endo. And when I say intra-aortic, يعني means inside the aorta. Endocardiac, inside the cardium. Endometrium, inside the uterus. Okay, so those, that's all referred to inside. Outside is ecto or exo or extra. Okay, and we say extradural means above the dura. Okay, when I say an exocrine, it is something produced outside the circulation, while endocrine is something produced inside the circulation. Okay, the ecto, exo, extra means outside. Okay, يعني it is produced or it is happening outside a certain location. Okay, so that's why we use it in the glands. Any gland produce inside the blood, we call it endo. Okay, anything produced outside the blood, we call it exo. So we say endocrine or exocrine. Okay, so this is how we use the prefixes in for inside and outside, and for above and below. Okay, when I say suprarenal, it means above the kidney. Subhepatic, below the liver. Okay, so here supra means above, renal refers to the kidney, sub means below, and hepatic refers to the liver. Epidermal, epidermal is something above the skin. When if I say intradermal, it is within the skin. Okay, epigastric, above the stomach, hypogastric, below the stomach, intravenous, inside the vein. So those are the suffixes or prefixes. Are we talking here about suffixes or prefixes? prefixes. Okay, we are talking about prefixes, and prefixes means they come before the body part. Okay, before the body part. Okay, and the body part, what did we call it in the medical term? No, yeah, Christine. The body part, we did not call it prefixes. Maybe you are still answering. Root. Yes. So the body part, we call it root. The letters that comes before the root, we call them prefixes. Excellent, yeah, Christine. Or Christian. Okay. And the letters that comes after is the one that we call it suffixes. Okay. Hypertension, this is a prefix, means up, and because tension is related to blood, it is a high blood pressure. Okay, hypo as a prefix refer to something low, so it's a low blood pressure. Hyperglycemia is high blood glucose, and hypoglycemia is the low glucose in the blood. Okay, so those are the prefixes for up and below. Okay, examples. Hypercalcemia is high calcium, while hypocalcemia is low calcium. Hyperlipidemia is the high lipid in the blood, and hypolipidemia are low lipid in the blood. Okay, so we are still in the prefixes. And we will talk about procedural suffixes. Okay, we'll talk about procedural suffixes. Okay. We will list important procedural suffixes, and we will define a number of procedural medical terminology. Okay. Now, what do we use in the body organ in order to operate on that part? Okay, so the prefixes for chest is thoraco. Okay, so we use thoraco. Okay, so for the combining forms. Appendix, we use appindo and appendico. Okay, for wind, okay, pipe, the wind pipe or trachea اللي هو قصبة الهوائية يعني بالعربي wind pipe. Okay, or trachea, we use tracheo. Okay, it's a tracheo. For breastbone, which is the sternum, the combining form is the sterno, because the root here is the sternum. Urinary bladder is the cyst, so that's why the combination is cysto. Okay, O is the combining vowel. Okay, O here is the combining vowel. Gallbladder is cholecysto. Okay, cholecysto. Nose is rhino or naso. Okay, that's why we say nasal drop. And al, O was dropped because the suffix here is al. Ear is auto or oro. That's why we say oral. We don't say auroral. Okay, because we have to remove the O if the suffix start with a vowel. We don't keep two vowels together. We don't put O and A. Okay, that's why this become nasal and this is become oral, because according to the rules in the medical terminology, if your suffix starts with vowel, you have to remove the connective vowel, which is O or I. Okay, so that's why the naso become nasal, because the suffix is al, and the oro becomes oral because the suffix is also a vowel. Okay, which is al. Now, this is just a review. When I say thoraco, I'm talking about something happening where? On the chest. So when say thoracotomy, okay, or thoracostomy, okay? Appindo, it goes to the appendix, and tracheo goes to the trachea, and the sterno goes to the sternum. Cysto goes to, where does cysto goes? When your patient goes for cystectomy or cystoscopy, okay? He is operated where? Bladder, correct? ممتاز. And cholecysto, choly related to bile, and cysto related to the gallbladder, okay? To the gallbladder. Rhino or rhino, nose, and auto or auro is ear. ممتاز. طيب. We'll just skip this because it's just a repetition, okay? And we will go to the procedural suffixes, okay? Tommy is a surgical cut or incision, okay? يعني فتح جراحي, okay? It's a surgical cut. We call it incision, okay? Ectomy is surgical cut and removal. There is excision, okay? So incision without removal. Excision is with removal, okay? So tummy and ectomy, surgical operation with opening, and ectomy when there is removal, okay? Stomy is surgical opening to outside of the body. That's why the opening of the anything outside the body, we call it stoma. Okay? We call it stoma. فأي فتحة تؤدي إلى وجود فتح في الجسم خارجي anything that cause permanent opening in the body to the outside is always a stoma. Okay? But that's why we have either gastric or intestinal stoma, or we have tracheal stoma. Those are the area where you see openings. Okay? Sometimes they operate on the head, they call it craniectomy. Okay? It's opening. Okay? Plasty, surgical repair or correction. Always, this is from plastic. So that's why plasty is always surgical repair or correction. Okay? So those are 4 major procedural. Are they suffixes or prefixes? يعني do they come at the end of medical term or at the beginning of the they are suffixes. Suffixes means at the end. Okay? Prefix is easy because you are saying pre, means before. Okay? So if I want to explain a surgical cut, what shall I use? When I say gastomy. Okay? طيب. If I am removing, ectomy. طيب. If I am creating an opening outside, stomy, from stoma. And if I am doing a repair, plasty, okay? والحين, yeah, plasty, everybody now is aware about it. Everybody is doing plasty now. طيب. Here we have thoracotomy, okay? Thoracotomy. It's opening of the chest, okay? And actually, this is an actual opening of the chest during procedure. It's like that, thoracotomy. They open the chest in order to operate inside the thoracic cavity. That's why you call it thoracotomy, okay? Craniotomy is opening in the cranium, okay? So this is a craniotomy, a craniotomy. So the root is thorac, the connecting vowel is O, and the suffix is tomy, okay? And that refers to surgical opening in the chest and surgical opening on the skull and the brain, okay? So that's why the cranio is the skull bone, okay? Cranio is the skull bone. This is a colostomy. It's opening of the colon to outside. That's why we call it colostomy. And here is opening of the trachea to outside. That's why we call it tracheostomy. So stomy, here for the colon, and here is for the trachea, okay? And these are the two common tomies we see in our practice, okay? In our practice. طيب. Procedural medical term. So when I say thoracotomy, incision of the thorax, sternotomy is incision of the sternum, okay? Pneumonectomy, when I say pneumo, lung. Ectomy means removal, okay? So pneumonectomy is excision of part of the lung or excision of the lung totally. So that's why it's either you say partial pneumonectomy or lobectomy. Lobectomy is excision, which is removal of loop, okay? Excision of loop. So that's why tomy is incision and ectomy is removal, okay? Is removal. So we say incision, and here we say excision, okay? Excision. It is removal through a surgical opening. Here we have the lobectomy, okay? We have the lobectomy here. If you go at the left side of the screen, this is removal of part of a lung, which is the loop, okay? This is wedge resection, the only partial lobectomy. We call it partial lobectomy. This is total lobectomy. This is an excision of the upper loop of the right lung, and here is a total right lung excision, okay? A total pneumonectomy. It's the total removal of a lung, okay? So lobectomy, pneumonectomy, and partial lobectomy. While here we are talking about thoracotomy. Thoracotomy is opening through the chest, okay? It's an incision through the chest wall, which is the thorax, okay? Procedure medical terms, okay? We are still in the same examples. I'm just gonna, okay, skip this because we already covered it. okay? And this is the procedure that we call it sternotomy. Sternotomy is opening through the sternum, and usually sternotomy is an exclusion procedure where من هم الناس اللي يعملوا sternotomy. Where do you see the sternotomy procedure? In which operations? In open heart surgery and in patients who have removal of their thymus gland. Okay, for they call it retrosternal excision. Okay, retrosternal excision of a thymus gland, thymectomy. Okay, thymectomy. Some patients, they come with retrosternal masses. Also, they have opening of the sternum. So sternotomy is the medical terminology, refers to opening of the sternum, okay, in order to operate on anything behind the sternum. But we see it most commonly in patients with open heart surgery, okay? So tracheostomy is surgical opening, okay, of the trachea. Colostomy, we talked about it. Rhinoplasty, what does rhinoplasty means? It is correction of the nose, okay? Any surgical correction of the nose, we call it rhinoplasty, okay? We call it repair of the nose. And otoplasty, any surgical repair of the ear, okay? Of the ear. We will skip this of repetition, and هذه مو دعاية للتجميل, but this is a nose before rhinoplasty and a nose after rhinoplasty, and here is an ear before otoplasty and an ear after otoplasty, okay? When we talk about suffixes like synthesis, it is surgical puncture to remove fluids, okay? Surgical puncture to remove fluids, like paracentesis, okay? Pixie is surgical fixation, okay? Surgical fixation. When you fix something using surgery, okay? Like orchidopixy. We use orchidopixy in order to fix the testicles for torsion testicle or for kids who have migration testicles. They call it orchidopixy. Okay, orchidopixy, it's fixation. Okay, Rafi is surgical sutures. Okay, Rafi refers to surgical suturing. And lysis is separation or destruction, okay? When I say hemolysis, the blood is separated, okay, into plasma and cells, okay? When I say hemolysis, okay? When I say rhabdomyolysis, it's rapid destruction of protein structures, okay? So this is where we use these prefixes. So I have synthesis is a surgical puncture to remove fluids. You have a patient who has pleural effusion, okay? The procedure to remove pleural effusion is pleural paracentesis, okay? So this is an example. So amniocentesis Okay, amniocentesis. So we said synthesis is remove fluids, and amniocentesis is the procedure of removal of the amniotic fluids from the uterus. So you are taking a sample of an amniotic fluid through abdomen, through uterus. So this is what we call it, amniocentesis. Okay. Thoracocentesis is getting a needle inside the thoracic cavity in order to remove pleural effusion, for example. Okay. طيب. Here, gram means record, like electrocardiogram, okay? Or electroencephalogram means record. You are recording, okay? Graphy, a record of, okay? When you say cardiography, okay? Yeah, it's the record of heart electricity. Therapy, treatment, like chemotherapy. Okay? Metry, measurements. Optimetry, when you measure the pressure of the, when you measure the function of the eye. When you say otometry, measurement of the function of the ear. Scopy is visual examination، ومعروف زي الاندوسكوبي and the bronchoscopy اللي هو منظار يعني. Scope is the instrument to view. So when I say a bronchoscope is the device. فالبرونكوسكوب هو المنظار، لكن البرونكوسكوبي هي العملية. So bronchoscope is the instrument and bronchoscopy is the procedure. Okay, so those are the suffixes used for these procedures. Okay. Now we went through all this. Okay. طيب. Okay. So this is the end of medical terminology. I will move to the next presentation. Which is physical examination. Okay. Can you see the new slide? Break is after this presentation, okay? The break will be after this presentation. Can you see the physical examination slide? طيب. معلش لأنه اليوم أنا خارج نطاق التغطية الطبيعية والله. Can you now? Yes? Okay, تمام. الحمد لله. طيب. Now we will talk about physical examination. I will try. This will take around 1 hour, less than 1 hour, okay? And 7 to 7:30 will be your break. Now, when we do physical assessment, of course, we will go head to toe, but I will just go system by system. Now, when we do chest or respiratory assessment, طيب السؤال الأهم الآن، هل السلايد يتحرك؟ لا. طيب هذه قضية أخرى الآن. اوكي. طيب الآن السلايد اتحرك؟ لا. الآن الو. not yet. غير شيء؟ صورة الكمبيوتر. لا حول ولا قوة إلا بالله. طيب. الآن في ولا ما في؟ now is okay. في physical examination. راح. يا ساتر. ممتاز. عنوان المحاضرة. طيب. حرك السلايد. يس. طيب يعني شايفين صورة الآن الثوراسيك and lungs؟ يا خلاص اوكي. طيب. البوستيريور ثوراسيك، احنا لما نتكلم على البيشنت، هذه مشكلة. الآن والله إني أعتذر. احنا الآن بالشريحة اللي اسمها ثوراسيك and lungs. يس. طيب احنا we will test. Is it moving؟ not moving. Now is it moving? لا صح؟ غير شيء؟ Anything happening؟ ما أعرف، أنا في شيء، أنا في جهة والزوم بجهة مختلفة. الحين تشوفوا أنتوا الصورة اللي فيها البالبيتيشن؟ أوكي خلاص. الآن when we do a respiratory assessment, the most important thing is inspection. Okay, هلا احنا we inspect the chest. Okay, what do we inspect the chest for? We inspect the chest for deformity. فأني patient has increase in the posterior anterior okay diameter، هذا احنا نسميه البيجن chest. اوكي، فغالبا تشوف البارل chest، هذا البارل chest اللي هو increase in the anterior posterior، يكون شكل الصدر المريض زي البرميل. اوكي، هذه مشكلة السي او بي دي بيشنت. اوكي، مشكلة السي او بي دي بيشنت. فممكن كل مريض عنده بيجن تشيست او فانل تشيست، هذول ابنورمال congenital abnormals. البارل تشيست نشوفهم في مرضى السي او بي دي. الكايفوسيس والسكوليوسيس they are related to spinal cord change. اوكي، when we do palpate احنا نحط يدنا على صدر المريض. اوكي، تغيرت الشاشة بالله ولا لا؟ you are in the palpitation. In the palpation yes. اوكي، فاحنا we place our hands in order to assist for symmetric movement of the chest. Okay, and we check if there is any abnormal masses externally. Okay, externally. Usually when the patient takes a deep breath we should see symmetric chest movement. طيب، بالنسبة للبالبيشن اللي هو القرع أو النقر على اللي هو المريض، على صدر المريض، من أجل أن نشوف إذا كان في عنده هايبر ريزونانس أو لو ريزونانس. اوكي، هذه اللي احنا نسميهم الفوكال تاكتايل فيرمنتس. اوكي، الفوكال تاكتايل فيرمنتس. ويوجوالي the presence of bullae او consolidation or pneumothorax, usually there will be absence or decrease in in the pneumothorax. في حالة النيوموثوركس هذه الترددات اللي انت تشعر فيها غالبا تنخفض في حالات النيوموثوركس. اوكي، طيب. فthis is how we do the percussion. طبعا البركشن is used to identify whether the patient has consolidation or he has any accumulation of fluids or air inside the pleural cavity. Okay. هذه بالنسبة للبركشن. Okay. طيب بالنسبة للأوسكالتيشن، الأوسكالتيشن is the most important task after اللي هو observation and palpation. اوكي. البركشن يعني still not very specific diagnostic، بس احنا نتكلم عنه لانه موجود في التكست بوك. اوكي. ففي الاوسكالتيشن usually you have to go systemic zigzag as percussion. اوكي. كيف يعني systemic zigzag؟ تروح من الفيرست intercostal space to the first intercostal space at the same level. اوكي. بعدين تنزل للnext level في الانتركوستال space, then you go to the same level on the other side. فدائما تقارن up down and right to left with your auscultation. طبعا ننتبه لقضية هامة جدا. اوكي. بالنسبة للأوسكالتيشن ما ننزل تحت مستوى الانتركوستال سبيس نمبر 8، لأنه تحت عندك الليبر والسبلين والستومك. They are interfering with your auscultation. Okay. You have to compare the right side with the left side. Okay. You have to inspect. فاحنا تكلمنا عن البالبيشن. بالنسبة للأوسكالتيشن anteriorly نفس القضية. Okay. So you place your stethoscope at the first intercostal space, which is under the clavicle directly, and then you go from right to left if you start, or you go from left to right. بس احنا دائما نوقف على يمين المريض على اساس ناخذ الكاردياك اوسكالتيشن مع الريسبيرتوري auscultation. Okay. So you go from one level to the other level, and as you see here, you don't exceed down, because here you have the stomach, which is going to give you abnormal bubble sound sometimes. طيب. Okay. تكلمنا عن البركشن. التايبس of breath sounds. Okay. In normal breath sounds are 3 types according to the location. Now we have الvesicular, which are base of the lungs. يعني هذه غالبا ناخذ الأوسكالتيشن at the lower lateral zone of the chest, and inspiration lasts longer than expiration. The bronchovesicular in the middle of the chest, على الفيرست and second intercostal space, mid-clavicular line, equal inspiration and expiration phase. والبرونكيال يكون over the trachea. Okay. Expiration lasts longer than inspiration. Okay. غالبا البرونكيال sound louder. البرونكيوفيزيكولار is less louder. والفيزيكولار sounds are soft muffled sounds. اوكي. يعني يكون الصوت انعم. اوكي. طيب الابنورمال sounds are related to the presence of fluids, okay, or secretions, or the presence of inflammation of the pleura, or it is related to obstruction of the airway, either inspiratory wheeze or expiratory wheeze. When I say crackles, it is a fluid and mucus, and the description is like rolling hair together. لو تمسك شعر كده وتفرك الشعر ببعضه يعطيك هذا الصوت, as you are rubbing 2 hairs together. الجارجلز اللي هو الرونكاي narrowing وsound with a snoring quality. وغالبا الرونكاي او الجارجلز related to the secretions in the main airway. اوكي. الفريكشن راب usually هذه عباره عن rubbing sound اللي هو granting sound. كيف واحد كده الانسان اللي يفرك اسنانه ببعض. اوكي. like you are scrolling your teeth together. اوكي. الويز we have inspiratory wheeze, وغالبا الانسبيراتوري wheeze related to upper airway, والexpiratory wheeze is related to asthmatic bronchial spasm. اوكي. ففي اللارنجايتس والفورين airway والفورين body in the airway غالبا يكون في عندك inspiratory wheeze، مع الازمتك patient يكون في expiratory wheeze. طيب الكارديوفاسكولار and peripheral vascular system، طبعا انت تضيف بالنسبه للريسبيراتوري اسسمنت اللي هي ريسبيراتوري باترن اللي هو الريت والدبث والريجولاريتي، وتحتاج انك تقيس الاكسجين ساتوريشن as part of respiratory assessment. اوكي. بالنسبه للكارديوفاسكولار and peripheral vascular we need to identify the location of the heart and the location of the pulses. The heart is located mediastinally tilted to the left side. You have the sounds of the heart are related to the valve movement, closure of the valves. And how many valves do I have? I have 2 intraventricular valves اللي هو atrioventricular valves, and I have 2 semilunar valves. The 2 atrioventricular valves اللي هم ما بين الرايت اتريوم والليفت فنتريكل، الرايت اتريا والليفت فنتريكل اللي هو الترايكاسبيد فالف، وبتوين الليفت اتريا and the left ventricle the mitral valve. Okay. I have the pulmonic valve and the aortic valve. طيب لو جينا للايورتيك فالف، الايورتيك فالف الاريا for aortic valve is at the right sternal border. Okay. Second intercostal space. البلمونيك valve second intercostal space left sternal border. الترايكاسبيد valve on the third and fourth intercostal space left sternal border. والmitral valve usually apical. Okay, usually apical, which is almost mid-clavicular at the fifth intercostal space. فاحنا نقول all doctors takes money، يعني aortic pulmonic. Okay, or all physicians takes money aortic, pulmonic, tricuspid and mitral valve sounds. Okay. طيب. Okay. you have the aortic valve, pulmonic valve, Erb's point, tricuspid valve and the mitral valve. Okay. You have APTM. Okay. This is the location of auscultation for valve sounds. Okay, for valve sounds. Now we listen there to the S1, S2, and S3, S4, and murmurs. Okay, and murmurs. So this is where you place your stethoscope. Okay. طيب. بالنسبة للإنسبكشن palpation and auscultation of the heart, we inspect and palpate the aortic, pulmonic, tricuspid, apical area pulsation. Okay. And we listen to the heaves. Inspect and palpate the epigastric area base of sternum for abdominal aortic pulsation, and auscultate the heart in 4 anatomic area. فأنت you inspect and palpate for the pulses, and on the abdomen on the epigastrum for the pulsating aorta. لأنه sometimes the patient comes with abdominal aortic aneurysm, okay, or aortic dissection. They will have pulsation and thrill over the abdomen. Okay. طيب normally no pulse except, okay, no pulse expect in epigastric area, no lift or heaves. هذه معروف. S1 is louder at the apex and S2 is louder at the base. S3 in child and young adult is normal, and S4 in many older adults is observed لأن it represents cardiomegaly. Okay. فالS1 والS2 are the normal systolic and diastolic heart sounds. Okay, in the auscultation. Carotid arteries in patients who are suspected to have carotid insufficiency, you might listen to something we call it carotid bruit. it's like a whooshy sound or a thrill sound over the carotid, which is an indication for carotid insufficiency. Okay, so you always have to avoid exerting pressure or massage on the carotid. لأنه massaging the carotid will lead to some parasympathetic stimulation. Patient will go bradycardia and hypotension. Second, you might dislodge some of the atheromas in the carotid artery, and it will travel up to the brain and will cause a stroke. اوكي، فممنوع انه احنا نعمل مساج للكاروتيد عند الناس اللي عندهم هايبر ليبيديميا وهايبر كوليسترول، لانه هذول الاشخاص عندهم ترسبات في الكاروتيد ارتري، فلما تيجي انت تعمل كاروتيد مساج ممكن انه جزء من هذه الترسبات تنفلت وتطلع فوق تجلس في الدماغ وتعمل ستروك. فذاتس واي كاروتيد مساج and excessive pressure on the carotid artery is not recommended at all. Okay. طيب بالنسبة للjugular veins احنا we put the patient at 30 to 45 degrees and we inspect for jugular vein distension. الjugular vein distension will always represent right heart failure. You see it with patient with fluid overload and patient with obstruction of the liver flow. اوكي، obstruction of the liver flow. بالنسبه للناس اللي عندهم liver cirrhosis يكون عندهم دائما distended neck veins. اوكي، طيب how do we assess the peripheral vascular system اللي هو peripheral pulses؟ احنا usually الكاروتيد we check it for life only. If the patient is unconscious we might check the carotid to determine whether he's alive or not. For other areas, we assess for peripheral pulses for the quality of peripheral circulation. Okay, for the quality of peripheral circulation. What do we assess for? We assess for the strength of the pulse, which we call it amplitude, and the width of the pulse. هل البلس narrow or wide? Okay, طبعا النورمال pulse it is throbbing against your finger. احنا نسميها the pulse is tapping your finger، يعني البلس كأنه بينقر على إصبعك. if you can feel the tapping of the pulse normally we call it +2. If you can barely feel it, +1. If you cannot feel it you put 0. Okay, or you need to use a Doppler machine to assess the pulses. غالبا الناس اللي عندهم arterial ischemic disease يكون عندهم decrease in pulse in the peripherals. Okay, decrease in pulse in the peripherals تبدأ من الفيمورال للبوبليتيال and the anterior and posterior dorsalis arteries. Okay. طيب بالنسبة للperipheral veins usually we inspect veins in the arms and the legs for the presence of superficial vein when limbs are dependent and limbs are elevated. Okay, normally you should not see the veins obvious, and the most important thing assessment in the vein is looking for signs of DVT. اوكي، ايش هم الساينز اوف دي في تي؟ احنا نسميهم كاردينال ساينز اوف دي في تي. الكاردينال ساينز اوف دي في تي اللي هم redness, hotness and swelling on one side of the legs. يعني الكالف اللي هي الليج مصل تكون swollen منتفخة red and hot and it is pain to touch. هذه حنسميها signs of DVT in patient with high risk. طيب بالنسبة للperipheral perfusion we have to inspect the peripheral perfusion. Patients who have decrease in blood supply to their peripheries they will have cold and decreased capillary refill, called the skin decreased capillary refill. Okay, هذه it is a sign of arterial insufficiency or arterial adequacy is not there. Okay. بالنسبة للبريست and axilla we inspect for the presence of nodes. Okay, for the presence of nodes, lymph nodes with other abnormal nodes in the axilla and the breast. Okay, usually the breast If there is any hardened area, something feels like a lump, it has to be reported for more examination. Okay? And usually there is a specific technique for breast assessment. Okay? طيب. بالنسبة للأبدومن, okay, we have to assess the abdomen for the areas. Now we can divide the abdomen into 8 zones. Okay, we have the aortic zone here, which is zone 1 and zone 4. Okay, zone 1 and zone 4, those are the aortic areas. Okay, so we have right upper, middle upper, and left, okay, and right lower. We have middle upper, middle here, and we have the lower middle, and we have right, left, left middle, and left upper, and left lower. In some other techniques, we can consider it 4 zones. We have right upper, right, left upper, right lower, and left lower. Okay, so it depends on how you want to divide the abdomen for auscultation and for assessment. Usually we do inspection first. Okay, so we inspect for abdominal counter if there is any abdominal distension, and you can ask the client to take a deep breath and hold it, and you can assess the symmetry, okay, while standing in the foot of the patient. Okay, any patient with abdominal distension, like it looks abnormally distended, we need to see whether this is related to gastric inflation, or the patient has a history of liver cirrhosis, then this patient has ascites. Okay, when you do auscultation, you auscultate the abdomen for bowel sounds and vascular sound. So you listen for active bowel sounds for every 5 to 20 seconds. Normal bowel sound as described as audible, absence, or hypo or hyper active. Okay, so this is for the auscultation of the bowel sounds. For vascular sounds, use the bill over the aorta, renal artery, iliac, and you can use this diagram. Okay, normal absence of arterial bruit. Okay, there يعني when you auscultate there should be no bruit. البروي اللي هو like a thrill or vibrating sound. Okay, loud bruit over aortic area indicate aneurysms. دايما اذا حطينا السماعه على الايورتيك اريا اللي هي في السب جاستريك هنا substernal. Okay, if there is bruit there يعني في صوت زي الخربشه، صوت زي الذبذبات، فهذا يعطيك انطباع انه المريض he is at a high risk or for abdominal aneurysm. Okay, aortic abdominal aneurysm. طبعا if there is pulsation, it is more confirmatory for abdominal aortic aneurysm, this is considered one of the most high acuity emergencies. Okay, because patient needs to be seen by surgical team, vascular surgical team. طيب. For percussion, you can do percussion on the 4 quadrants in this direction, okay, to identify high resonance and low resonance areas. Okay, and for the percussion of the liver, percuss the liver to determine the size of the liver at the mid-clavicular line. Okay, so this is where do you do percussion for the liver. Okay, usually the percussion is gonna happen here. If you percuss here, يعني you do percussion and there is decrease in the resonance, it means the liver size is increasing. Okay, it means the liver size is increasing. Perform light palpation first for tenderness or muscle gland. So you just touch the abdomen. If the patient has pain to your touch, this is what we call a tender abdomen. Okay, usually patients with internal bleeding, patient with peritonitis, perforated appendicitis, okay, they will have always, or appendicitis, they will have a tender abdomen, okay? طيب, hold the palm of your hand parallel to the abdomen, depress the abdomen wall about 1 centimeter in depth, بس 1 centimeter, okay? Move the finger pad slightly circular motion. Note any tenderness, okay? Ask the client to tell you about them and look at the patient facial expression, okay? So now we palpate to see whether the patient has pain to touch, okay? Any patient has pain to touch, it means he has tender abdomen. He has tender abdomen. Deep palpation, okay, over 4 quadrants, press the distal half of your palm surface and about 4 to 5 centimeters. Normally, tenderness may be present near xiphoid as a normal, okay? Over cecum and over sigmoid. Check for rebound tenderness. Rebound tenderness, يعني when you remove your hand, suddenly the patient might have peritoneal inflammation or suspected appendicitis, okay? The palpation of the liver. So this is how you palpate the liver. You put your hand under the right upper quadrant and stand the client right side and place your left hand posteriorly. Place your right hand parallel to the rectus muscle, اللي هي الabdominal muscle, الميدل muscle, with the finger pointing toward the rib cage. Okay. During exhalation, palpate with a depth of 4 to 5 centimeters. Maintain your hand position. Ask the client to inhale deeply while the client inhale. Feel the liver borders moving against your hand. So you will feel the liver as a mass coming to your hand. Then you go and palpate the bladder and area above the pubic symphysis. In the client has a history of urinary retention. Normally, the bladder is non-palpable unless it is fully distended, okay, and full of bladder. Now we have the ultrasound, the bladder ultrasound machines that can do the job for you, okay? طيب. In musculoskeletal system, usually we assess the muscle, okay, symmetry for sensation and strength and reflexes from up down, okay? Inspect the muscle for size, inspect for the muscle for and tendons for contractures. What does contracture mean? Contracture means shortening of the tendons. يعني the normal posture of the tendon, the joint is abnormal. It is abnormal, either flexed or extended. Inspect the muscles for tremors. Inspect any tremor over hand and arm by having the client holding the arm out in the front of body. So you ask the patient to elevate his arms and extend them, and you will observe for tremors. Okay. Palpate muscles at rest to determine muscle tonicity. احيانا بعض المرضى يكون عندهم تصلب في العضلات، اوكي، خاصه مرضى النيورو او مرضى الستروك. Palpate muscles for flaccidity, weakness or laxness. وغالبا هذه تشوفها عند المرضى اللي عندهم جيليان-بري syndrome او ماستينيا جريفيز او عندهم spinal cord injury. اوكي. وتست the muscle strength. You ask the patient to squeeze your hand to elevate against gravity and with gravity and against resistance. This is for the sternocleidomastoid, triceps, deltoid, wrist, fingers, biceps, for the triceps, and for the grip strength. So this is exactly how do you assess the strength of the muscles. So you place your hand on the muscle and ask the patient to move his muscles, okay, against your pressure. Okay, so you can assess all the muscles. For the hip, abduction and hip muscles, you can do the same thing. This is for the quadriceps, for the hamstring, and for the dorsiflexion. You ask the patient to push and pull his feet up, okay? So this is how we assess the strength of the muscles. Bone, inspect the skeleton for normal structure and deformity. Okay, palpate the bone to locate any area of edema or tenderness. For the joint, inspect the joints for swelling. Palpate each joint for tenderness, smoothness of movement, swelling, and the presence of nodules. Assess joints' range of motion. The amount of joint movement can be measured by jointometer. This is the device. Okay, the device that measures the range of motion in degrees. Okay, and the new document. Assess for neurological system. Language. If the patient displays difficulty in speaking, ask the client to name common objects. Ask the client to respond to simple command as raise your arms. اوكي، هذا بالنسبه لللانجوج. هل يفهم عليك المريض ولا ما يفهم عليك؟ مرضى الستروك غالبا ما يكون عندهم motor aphasia، يعني they cannot speak, or they have sensory aphasia, they don't understand what you are saying. الهيد injury patients or الناس اللي عندهم chronic neurological disorders, they might be permanently confused. Okay, so you need to consider the patient history and the reason of your assessment. Orientation, the patient should be oriented to time, place, or persons. Okay, any lack here, we convert it from orientation to confusion. Okay, memory, usually it's if you suspect difficulty or memory deformity, like the patient has any memory loss like dementia, you might focus on that. طيب, immediate recall, recent memory and remote memory. What do you mean by recent memory? The patient, when you tell him something, he can respond and can memorize it. Majority of patients in elderly, they have decrease in recent memory, but they keep their remote memory. They tell you about their histories. Okay? So the average person can repeat 5 to 8 digits in sequence. الشخص العادي ذاكرته تسمح له انه يتذكر 5 إلى 8 أرقام. اوكي؟ طيب، بالنسبة للاتنشن سبان and concentration calculation, test the ability to concentrate and maintain attention. Ask the client to count back 100 or ask the client to subtract 7 or 3 progressively from 100. Okay, this is to test their attention and their mentation. Okay, for level of consciousness, usually we apply the GCS, Glasgow Coma Scale. Glasgow Coma Scale is composed of 3 components: the best eye movement, the best eye opening. If the patient open eye spontaneously and he keeps his eye opened for more than 20 seconds, you will give him 4. If the patient respond only to voice or only to pain, or he is not responding at all. For verbal response, whether the patient is oriented or confused, or inappropriate talk or incomprehensible sounds, or he has no sound at all. And the best motor response, obey commands. When you ask the patient, open your mouth, raise your hand, he is obeying commands. Otherwise, when you apply pain, the patient is localizing the pain. If not, we will observe for withdrawals, okay, which is flexion or abnormal flexion or abnormal extension. Normal coma scale is 15. Any patient below 9 is considered severe neurological deficit and requires good attention. Okay, between 10 to 13 is considered moderate, and anything 14 to 15 is considered mild deterioration. Okay, if you are interested in assessing the cranial nerve, usually with patients with lower brain injuries, we consider checking their brainstem functions. Okay, so we can test olfactory by giving patients something to identify ريحة القهوة, coffee smell. Optic, we can assess the patient visual fields. Oculomotor, which is the movement of the sphincter of the pupils, had usually we assess it with light. Trochlear motor movement of the eyeball down and up, we ask the patient to look up and down. trigeminal ophthalmic branch and maxillary branch, okay, which is the trigeminal has 3 branches, okay, اللي هو cranial nerve number 5. Okay, usually blink reflex وtest light sensation, okay. وعندنا الابديوسنس اللي هو السادس number 6 is responsible for the lateral movement of the eye. Number 7 الfacial nerve, we ask the patient to show a smile, okay. ونمبر 8 اللي هو الاوديتوري sensory, usually you need to have the rhombing test اللي هو تستخدم التانينج فوركس، اوكي. ونمبر 9 glossopharyngeal, motor and sensory, swallowing ability and the tongue movement. The patient, if he has difficulty in swallowing and he cannot move his tongue normally, he might have a problem with his glossopharyngeal facial nerve. The vagus nerve assesses speech for hoarseness. اوكي، هذا العصب العاشر. assess اللي هو الاكسسوري muscles، هذا responsible for the movement of the scapulas. فthe patient can shrug his shoulders، يعني يقدر يضم ويرفع الاكتاف. اوكي، the patient can move his shoulders. ونمبر 12 اللي هو الهايبوجلوسال tongue movement. اوكي، the patient usually cannot fold his tongue. His tongue will be protruded out. Okay, this is for the cranial nerve assessment. For the reflexes, you can assess using the biceps, bronchioradialis, Achilles, okay, the patellar response, okay, and the quadriceps and the plantar. So those are the reflexes. Usually patient with abnormal neurological deficit, they might have hyperreflexia. Patient with sensory and lower brain and spinal, they might have decrease in their reflexes. Okay, طيب. Usually we to test the gait, which is the function of the hypothalamus, okay, and the vestibular function of the ear, which is responsible for the balance. Usually we assist the patient walking gaits. So we ask the patient to walk on a straight line, or we ask the patient to stand with feet together and arm resting at the bedside, and we see whether he's going to swing right or left. Standing on one foot with eye closed, this is for perceptual function, okay? And heel to toe walking. خلي المريض يمشي بخط مستقيم، okay? طيب. To here walking, finger to nose test and alternating supination and pronation of hands to knee. اوكي، فهذه اللي تخلي المريض يعمل حركات بشكل يعني بشكل مستمر، اوكي، حتى تشوف الكوردينيشن. فif the patient cannot do the coordination, he has a problem. Okay. Finger to finger, this is a test. Okay, this is to test patient coordination. Okay, يعني the patient close eye, extend his arm, or he keep fingers together, okay, in this movement. Okay, but this is to coordinate to test the coordination. Also, you have this test to assess the coordination and to the nurse fingers, okay, also to assess patient coordination. Like sensory function, usually we assess the patient by cotton or pain sensation by tongue depressor, okay? So you have to assess the patient ability to feel, okay? Usually temperature sensation, cold and hot, okay? Those are, we use them to assess the sensation, okay? Assessing the female genitalia and inguinal area by inspection, same thing for male. So we report any bleeding, we report any fungal or any abnormal discharges or any abnormal swelling, okay? And we do the same thing for the rectum and anus. We look for hemorrhoids, we look for nodules, we look for bleedings, okay? طيب. That is quickly for the physical assessment. Now we will, if you don't have any question about this presentation, and I apologize for the technical, because today I am presenting outside my normal location, okay? That's exactly what happened. فبالنسبة للمحاضرة خلصت، نطلع بريك الحين، نرجع الساعة 7:30. Okay? So we will go for a break and we will come back at 7:30. Okay? 7:30 نرجع. Okay? We will come back 7:30. Thank you very much. Control, please, you might put the break sign. Okay?
تمام. تمام. Okay, I'm Dr. Elisa. I will be your host for this two upcoming sessions. إذا سأتكلم في الإنجليزية وفي العربي. Okay, I will be speaking about integumentary nervous and endocrine system terms. مصطلحات الجهاز الجلدي أو الغذائي والجهاز العصبي، ومصطلحات تتعلق في جهاز الغدد الصماء. تمام؟ اوكي. As per the introduction, working knowledge of anatomy is important. المعرفة العملية للتشريح أمر مهم. Knowledge of anatomy helps to communicate correct information to professionals who know medical terms, also to others who may not understand medical terms. إذا كما نعلم أن المعرفة بالتشريح تساعد على إيصال المعلومات الصحيحة إلى المهنيين في طبيعة الحال الذين يعرفون المصطلحات الطبية، وللآخرين الذين قد لا يفهمون المصطلحات الطبية. Topographic anatomy, we have the superficial landmarks which serve as guides to structures that lie beneath them, and topographic anatomy applies to a body in the anatomic position, like patient stands facing you, arms at sides and palms forwards. إذا علم التشريح والتوبوغرافيا في علم التشريح بشكل عام هي معالم واضحة، وهي بمثابة أدلة للهيكل التي تقع تحتنا أو للهياكل التي تقع تحتنا بشكل عام. وينطبق هذا التشريح على جسم الذي هو في وضع التشريح، وكما نعرف يقف المريض في مواجهتنا وذراعيه إلى جنبيه وكفيه إلى الأمام كما تعلمون. Nervous system control of the cardiovascular system. التحكم في الجهاز العصبي لنظام القلب والأوعية الدموية. We have the sympathetic nervous system is responsible for fight or flight response. It sends commands to adrenal glands, and epinephrine and norepinephrine are secreted to stimulate heart and blood vessels. Blood vessels have alpha adrenergic receptors, and heart and lungs have beta adrenergic receptors. So the parasympathetic nervous system also has effects on cardiovascular system. So addresses actions that do not require immediate response. إذا الجهاز العصبي الودي sympathetic هو المسؤول عن استجابة لما يعرف في flight or fight، الهروب أو القتال. يرسل الأوامر إلى الغدد القذرية، ويتم أيضا إفراز الابنفرين والنورابنفرين لتحفيز القلب والأوعية الدموية. وأيضا تحتوي الأوعية الدموية على مستقبلات الأدرينالين ألفا أدرينالين، وكما أيضا يحتوي القلب والرئتين على أيضا البيتا أدرينالين. وكما نعلم الجهاز العصبي الباراسمباتيك له أيضا تأثيرات على نظام القلب والأوعية الدموية، ويعالج الإجراءات التي لا تتطلب استجابة فورية. The nervous system anatomy and physiology. ندخل في الموضوع شوي. So الجهاز العصبي وأيضا ما يعد في علم التشريح وعلم وظائف الأعضاء. The nervous system is perhaps the most complex organ in body. إذا ربما يكون الجهاز العصبي هو الجهاز الأكثر تعقيدا في الجسم. Consists of brain and spinal cords كما تعلمون، ومتكون من الدماغ والspinal cord النخاع الشوكي. Divided into two main portions, central nervous system and peripheral nervous system. مقسم إذن إلى قسمين رئيسيين، الجهاز العصبي المركزي والمحيطي أو peripheral nervous system as you know. So the central nervous system, as you know, it's the brain, who controlling organ of the body, subdivisions. So we have the cerebrum, cerebellum, and brain stem. إذن الدماغ وهو يتحكم في أعضاء الجسم بشكل عام، وهناك أيضا تقسيمات ما دون الدماغ هم السيربرم، المخ والمخيخ وجذع الدماغ brain stem. The central nervous system also, we have the spinal cord as we said before, إذن الحبل الشوكي أو النخاع الشوكي. It's a continuation of the brain، إذن هو استمرار للدماغ و transmits message between brain and body as you know. ينقل الرسائل بين الدماغ والجسم كما تعلم. So we have the cerebrum, cerebellum, brainstem, foramen magnum, and spinal cord, and the spinal nerves. The peripheral nervous system divided into two main portions, somatic nervous system and autonomic nervous system. إذن الجهاز العصبي المحيطي مقسم إلى قسمين رئيسيين، الجهاز العصبي الجسدي واللا إرادي. So starting with the somatic nervous system, transmits signals from brain to voluntary muscles, allows for walking and talking. إذن الجهاز العصبي السوماتيك الجسدي ينقل إشارات من الدماغ إلى العضلات الإرادية ويسمح بالمشي والتحدث. Anatomic nervous system or autonomic nervous system الجهاز العصبي اللا إداري أو لا إرادي. Involuntary actions, gesture dilation, and split into two areas. إذن هو يتعلق بالأفعال اللا إرادية مثل الهضم والتمدد إلى آخره، وأيضا split into two areas مقسم إلى منطقتين sympathetic and parasympathetic nervous system الجهاز العصبي الودي والجهاز العصبي parasympathetic. وهنالك أيضا نوعان two types of nerves within peripheral nervous system. Sensory nerves carry information from body to central nervous system, and the motor nerves carry information from central nervous system to muscles, as you know. Okay, now let's start with the terms. Okay, terms related to the nervous system. إذن المصطلحات المتعلقة في بالجهاز العصبي. Okay. Any question till now? The neuron, it's a basic structural and functional unit of the nervous system responsible for transmitting signals. إذن الخلايا العصبية هي الوحدة الهيكلية والوحدة الوظيفية الأساسية للجهاز العصبي، وهي المسؤولة عن نقل الإشارات. The central nervous system, as you know, also encompasses the brain and spinal cord responsible for processing and interpreting information. إذا هو الجهاز العصبي المركزي يتكون من الدماغ والحبل الشوكي وأيضا هما مسؤولان عن معالجة المعلومات وتفسيرها. Peripheral nervous system consists of nerves and ganglia outside the central nervous system, connecting it to the rest of the body. إذا أيضا كما تعلمون يتكون من أعصاب وعقد تقع خارج الجهاز العصبي المركزي وتربطه ببقية أجزاء الجسم. Brain, the organ inside the skull that controls various functions including cognition, emotion, and motor activities. الدماغ كما تعلمون هو العضو الموجود داخل الجمجمة والذي يتحكم في وظائف مختلفة بما في ذلك الإدراك، العاطفة، والأنشطة الحركية وما إلى هنالك. The spinal cord, النخاع الشوكي, it's a long tubular structure extending from the brainstem, responsible for transmitting signals between the brain and the rest of the body. إذا الهيكل هو كما نعلم هو شكل طويل يمتد من جذع الدماغ وهو مسؤول عن نقل الإشارات بين الدماغ وبقية الجسم. ممكن هنالك معلومات تعرفونها إنما لازم نمرق بكل هذه المعلومات قبل الدخول في التفاصيل. Nerve. So, a nerve, a bundle of fibers that transmit electrical impulses between the central nervous system and other parts of the body. إذن العصب هو حزمة من الألياف التي تنقل النبضات الكهربائية بين الجهاز العصبي المركزي وأجزاء أخرى من الجسم. Sensory neuron أو الخلايا العصبية الحسية transmit sensory information from sensory organs to the central nervous system. إذا ينقل المعلومات الحسية من الأعضاء الحسية إلى الجهاز العصبي المركزي. Motor neuron transmit signals from the central nervous system to muscles or glands, controlling movement and physiological responses. إذا الخلايا العصبية الحركية motor neuron تنقل الإشارات من الجهاز العصبي المركزي إلى العضلات أو الغدد ويتحكم في الحركة والاستجابات الفيزيولوجية. Synapse, junction between two neurons where signals are transmitted via neurotransmitters. إذا السينابس أو العصب البون الداخلي هو نوع من الخلايا العصبية التي تنقل الإشارات بين الخلايا العصبية الحسية والحركية داخل الجهاز العصبي المركزي. و السينابس أو التشابك العصبي هو junction between two neurons where signals are transmitted via neurotransmitters، تقاطع بين خليتين عصبيتين حيث تنقل الإشارة عبر الناقلات العصبية. Also continue with the neurotransmitters. It's a chemical messenger that transmits signals across synapses. إذا هو يعرف بالناقل العصبي وينقل رسائل كيميائية أو هذه الرسائل الكيميائية تنقل الإشارات عبر مشابك العصبية. Axon أو المحور العصبي long slender projection of a neuron that conducts electrical impulses away from the cell body. إذا الأكسون أو المحور العصبي هو نتوء طويل ورفيع لخلية عصبية تقوم بتوصيل النبضات الكهربائية بعيداً عن جسم الخلية. Dendrite branched projections of a neuron that receives signals from other neurons and convey them toward the cell body. Dendrite أو ما يعرف بالتغصنات هي نتوءات متفرعة للخلية العصبية تستقبل الإشارات من الخلايا العصبية الأخرى وتنقلها نحو جسم الخلية. Myelin sheath, fatty covering around some axons that insulates and speeds up the transmission of nerves or of nerve impulses. الميلين هو غطاء دهني حول بعض المحاور ويعمل على عزل وتسريع انتقال النبضات العصبية. Cerebrum, largest part of the brain, responsible for conscious thought, memory, language, and voluntary movement. المخ كما معروف أو السيربروم هو الجزء الأكبر من الدماغ، وهو المسؤول عن التفكير الواعي والذاكرة واللغة والحركات الإرادية. سيربيلوم كله تمام للحين؟ Okay, everything is good. Everything is good. Any question? تمام. Okay. So, cerebellum, it coordinates voluntary muscle movements, balance, and posture. إذا ينسق حركات العضلات الطوعية والتوازن وأيضا البوستشر أو وضعية الجسم. Brain stem includes the medulla oblongata, pons, and midbrain, and also regulates basic life functions such as breathing and heartbeat. إذا البرين ستام أو جذع الدماغ يشمل النخاع المستطيل والجسر والدماغ المتوسط، وأيضا ينظم وظائف الحياة الأساسية مثل التنفس ونبض القلب. Okay. Sympathetic or autonomic nervous system (ANS) controls involuntary bodily function such as heart rate, digestion, and respiratory rate. And إذا يتحكم في وظائف الجسم اللا إرادية مثل معدلات ضربات القلب وعملية الهضم ومعدل التنفس. Sympathetic nervous system أو الجهاز العصبي will activates the fight or flight response, preparing the body for intense physical activity and response to stress. ينشط هنا استجابة الانتقال أو الهروب ما يعرف fight or flight، وإعداد الجسم لنشاط بدني مكثف واستجابة للتوتر. Parasympathetic nervous system الجهاز العصبي السبتاوي activates the rest and digest response, promoting relaxation and conserving energy. إذا ينشط استجابة الراحة وعملية الهضم مما يعزز الاسترخاء ويحافظ على الطاقة. أوكي. meninges أو السحايا إذا ما يعرف السحايا. So protective membranes, dura mater, arachnoid matter, pia matter surrounding the brain and spinal cord. إذا هي الأغشية الواقية بشكل عام والمحيطة بالدماغ وبنخاع الشوكي. Gray matter contains nerve cell bodies and dendrites often found on the surface of the brain. إذا هي مادة رمادية تحتوي على أجسام الخلايا العصبية والتي توجد غالبا على سطح الدماغ. White matter, المادة البيضاء, consists of myelinated axons forming the inner part of the brain and spinal cord. إذا تتكون من محاور عصبية تشكل الجزء الداخلي من الدماغ والنخاع الشوكي. Ganglion consists it's a collection of nerve cell bodies in the peripheral nervous system. إذا هي مجموعة من أجسام الخلايا العصبية موجودة في الجهاز العصبي المحيط. Plexus, it's a network of nerves or vessels. إذا شبكة من الأعصاب أو الأوعية الدموية. The reflex, it's an involuntary rapid response to a stimulus that bypasses the conscious brain involving the spinal cord. إذا reflex أو هي العملية اللا إرادية وهي استجابة سريعة وغير إرادية لمحفز يتجاوز الدماغ الواعي بما في ذلك النخاع الشوكي. Neurodegenerative diseases. Okay. إذا ننتقل الآن لنتكلم عن neuropathology terms أو مصطلحات علم الأمراض العصبية. نتكلم الآن عن الأمراض بشكل عام. Neurodegenerative diseases الأمراض العصبية. إذا it's a conditions involving the progressive degenerative of nerve cells, example Alzheimer's disease, characterized by memory loss, cognitive decline, and behavioral changes. إذا الأمراض العصبية بشكل عام هي الحالات التي تنطوي على التدهور التدريجي للخلايا العصبية. على سبيل المثال مرض الألزهايمر الذي يتميز بفقدان الذاكرة والتدهور المعرفي كما تعلمون والتغيرات السلوكية. Stroke, cerebrovascular accident, it's a sudden disruption of blood supply to the brain, leading to brain damage. We have types like ischemic stroke due to blocked blood vessel and hemorrhagic stroke due to bleeding. نتكلم عن السكتة الدماغية هنا، الحوادث الدماغية التي تتعلق بالأوعية الدموية. هي انقطاع مفاجئ في إمداد الدم إلى الدماغ مما يؤدي إلى تلف في خلايا الدماغ، خلايا العصبية موجودة في الدماغ. وأيضا هناك نوعان بشكل عام، هي سكتة دماغية تتعلق بالنشاف والتي هي تكون بسبب انسداد الأوعية الدموية، والسكتة النزفية الهيموراجيك تكون بسبب نزيف. Okay, so epilepsy أو الصرع chronic neurological disorder characterized by a recurrent seizure. We have we have many types. We have generalized seizure, partial seizures, and absence seizures. إذا نتكلم عن الصرع، هناك اضطراب عصبي مزمن يتميز بنوبات متكررة. إذا هنالك عدة أنواع مثل نوبات معممة أو generalized وجزئية ونوبات غيابية يحصل فيها غياب عن الوعي. Multiple sclerosis (MS) it's an autoimmune disorder causing the demyelination of nerve fibers in the central nervous system. Symptoms: fatigue, numbness, difficulty walking, and vision problems. إذا التصلب اللويحي إذا هو اضطراب المناعة الذاتية الذي يسبب إزالة الميالين من الألياف العصبية كما قلنا فيما قبل. إذا إزالة الميالين من الألياف العصبية في الجهاز العصبي المركزي. الأعراض: التعب والخدى والشعور بالتخدير وصعوبة المشي ومشاكل في الرؤية. Okay. Neuropathy, it's a dysfunction or damage to peripheral nerves, often causing numbness, tingling, or pain. Causes diabetes, infection, trauma, autoimmune disorder. إذا نتكلم عن الاعتدال العصبي، هنالك يكون لدينا خلل أو تلف في الأعصاب الطرفية مما يسبب غالبا تنميلا أو شعور بالوخز أو ألم بشكل عام. ومن الأسباب هو مرض السكري أو الالتهابات أو الصدمات أو حتى اضطرابات المناعة الذاتية. Okay, we go forward. Meningitis, إذا التهاب الصحايا, it's an inflammation of the meninges, protective membrane around the brain and spinal cord. So the causes are viral or bacterial infections leading to symptoms such as fever, headache, and neck stiffness. إذا التهاب الصحية هي أو الأغشية كما قلنا قبل أو الغشاء الواقي حول الدماغ والنخاع الشوكي. الأسباب عادة هي عدوى فيروسية أو بكتيرية مما يؤدي إلى أعراض مثل الحمى والصداع وتصلب والشعور بتصلب الرغبة. Brain tumor, abnormal growth of cells in the brain, types gliomas, meningiomas, metastatic tumors, symptoms, headaches, seizures, changes in behavior or cognition. إذا الورم في الدماغ هو نمو غير طبيعي للخلايا في الدماغ. الأنواع على سبيل المثال الأورام الطبية والأورام الصحية والأورام النقلية metastatic. والأعراض الصداع والنوبات وتغييرات في السلوك والإدراك أيضا. Cerebral palsy, a group of disorder affecting movement and posture, often due to brain damage during early development. The types are spastic, dyskinetic, or ataxic. causes, birth injury, genetic factors, and infections. إذن الشلل الدماغي هي مجموعة من الاضطرابات التي تؤثر على الحركة والوضعية غالباً بسبب تلف الدماغ أثناء النمو المبكر. عدة أنواع تشنجي أو هناك أنواع حينما يكون لدينا خلل في الحركة، ومن أسبابها أيضاً الإصابة بالولادة وعوامل إضافية والتهابات. Hemiplegia أو الشلل النصفي paralyzes on one side of the body often caused by a stroke. Hemiparesis is a weakness on one side of the body. إذا شلل في أحد جانبي الجسم وغالبا ما يحدث نتيجة السكتة الدماغية. إذا كما قلنا ضعف في جانب واحد من الجسم وبشكل عام. نيورالجيا إذا الألم العصبي أو الألم الناتج عن المشاكل المتعلقة بالجهاز العصبي. sharp serve pain along the course of a nerve. Example trigeminal neuralgia and sciatica. إذا ألم حاد وشديد على طول مسار العصب عادة. على سبيل المثال الحصر ألم العصب الثلاثي التوأم وعرق النساء. Guillain-Barré syndrome. It's an autoimmune disorder affecting the peripheral nervous system, leading to weakness and paralysis. The symptoms are tingling, weakness, and potentially life-threatening paralysis. إذا متلازمة Guillain-Barré هي اضطراب المناعة الذاتية الذي يؤثر على الجهاز العصبي المحيطي مما يؤدي إلى الضعف والشلل. من الأعراض هو الشعور بكوخز الإبر والضعف والشلل الذي قد يهدد الحياة. Huntington's disease. It's a genetic disorder causing progressive degeneration of nerve cells in the brain. The symptoms are involuntary movements, cognitive decline, emotional disturbances. إذا مرض هانتينغتون هو اضطراب وراثي يسبب انحطاط تدريجي للخلايا العصبية في الدماغ. من الأعراض أو عوارضه حركات لا إرادية، تراجع إدراكي، واضطرابات عاطفية. الزهايمر ديزيز تكلمنا عنه فيما قبل. إذن هو اضطراب بالجهاز العصبي تقدمي يتميز بفقدان الذاكرة والتدهور المعرفي وضعف الأداء اليومي. باركنسون ديزيز مرض الباركنسون is a chronic movement disorder marked by the degeneration of dopamine producing neurons. The symptoms are like tremors, rigidity, bradykinesia, and postural instability. Individuals may also experience non-motor symptoms such as sleep disturbances and mood changes. إذن الباركنسون هو اضطراب مزمن في الحركة يتميز بتدهور الخلايا العصبية المنتجة للدوبامين، والأعراضه هو الهزات أو الهزة بشكل عام، تصلب، بطء الحركة، عدم الاستقرار، عدم التوازن، وأيضا قد يعاني الأفراد أيضا من أعراض غير حركية مثل اضطرابات النوم وأيضا تغييرات في المزاج. Okay, let's move to the amyotrophic lateral sclerosis ALS, التصلب الجانبي الضموري. So it's a progressive motor neuron disease characterized by muscle weakness, twitching, and eventual paralysis. Symptoms include difficulty in speaking, swallowing, and breathing as motor neuron degenerate, leading to muscle atrophy. إذن التصلب الجانبي كما قلنا ال ALS هو مرض عصبي حركي تقدمي يتميز بضعف العضلات والشعور بإحساس الوخز وأيضا الشلل في نهاية المطاف. والأعراض هنالك صعوبة إذن في التحدث من عوارضه. إذن صعوبة في التحدث، البلع، التنفس، حيث تتدهور الخلايا العصبية الحركية مما يؤدي إلى ضعف وضمور في العضلات. Migraine is a neurological disorder characterized by recurrent intense headaches, often accompanied by nausea, vomiting, and sensitivity to light and sound. Symptoms may also include visual disturbances and aura before the onset of the headache, lasting from a few hours to several days. كما تعلمون المايجرين أو صداع الشقيقة أو النصفي إذا هو اضطراب عصبي يتميز بصداع متكرر ومكثف، وغالبا ما يكون مصحوبا بالغثيان والقيء والحساسية للضوء والانزعاج من الضوء والصوت. وقد تشمل الأعراض هنا اضطرابات بصرية ورؤية هالة قبل بداية الصداع، وتستمر من بضع ساعات إلى عدة أيام. Peripheral neuropathy. Peripheral neuropathy refers to damage or dysfunction of the peripheral nerves. Symptoms such as tingling, numbness, and pain in the extremities. It can result from various causes, including diabetes, infections, and autoimmune conditions. إذا الاعتلال العصبي المحيطي يشير إلى اعتلال هذا إلى تلف أو خلل في الأعصاب الطرفية، ومن عوارضه هو شعور كوخز الأبر والخدر والألم في الأطراف، ويمكن أن ينجم عنه أسباب مختلفة أيضا، أو ينجم عن أسباب مختلفة بما في ذلك السكري، مرض السكري، الالتهابات، وأمراض المناعة الذكية. Restless Legs Syndrome (RLS). It's a neurological disorder characterized by an irresistible urge to move the legs, often accompanied by uncomfortable sensations. So the symptoms typically worsen during periods of inactivity or at night, affecting sleep and causing restlessness. إذا متلازمة تململ الساقين هي اضطرابات عصبية أو اضطراب عصبي يتميز برغبة لا تقاوم في تحريك الساقين، وغالبا ما تكون مصحوبة بأحاسيس وانزعاج غير مريحة وانزعاج. وتتفاقم الأعراض هنا بشكل عام عادة أثناء فترات عدم النشاط أو في الليل، مما يؤثر على النوم وأيضا يسبب الأرق. Okay, let's move to Tourette syndrome. كله تمام؟ ماشي الحال؟ All good? واضح؟ تمام؟ Okay. شكرا محمد أمان، شكرا. So Tourette syndrome is a neurological condition characterized by repetitive involuntary movements and vocalization known as tics. So tics can range from simple, brief movement to more complex actions and vocal expressions. Onset often occurs in childhood and may improve with age. متلازمة توريت هي حالة عصبية تتميز بحركات وأصوات متكررة لا إرادية، تعرف باسم التشنجات اللا إرادية، ويمكن أن تتراوح التشنجات اللا إرادية من حركات بسيطة وقصيرة إلى أفعال وتعابير أو تعبيرات صوتية أكثر تعقيدا. غالبا ما تحدث البداية في مرحلة الطفولة وقد تتحسن مع تقدم العمر. Traumatic brain injury results from a sudden impact or jolt to the head, leading to damage to the brain. Symptoms can range from mild, such as headache and confusion, to severe, including loss of consciousness, memory impairment, and change in mood or behavior. Even traumatic brain injury أو الإصابات المباشرة في الدماغ تنتج هذه الإصابات من تأثير مفاجئ أو هزة في الرأس، مما يؤدي إلى تلف الدماغ. ويمكن أن تتراوح هذه الأعراض من خفيفة مثل الصداع والارتباك إلى شديدة، بما في ذلك فقدان الوعي وضعف الذاكرة وتغيرات في المزاج أو السلوكيات. Myasthenia gravis is an autoimmune disorder characterized by muscle weakness and fatigue, particularly in the voluntary muscles. It occurs due to the immune system mistakenly attacking the receptors of the neuromuscular junction, leading to difficulties in muscle contraction and control. Symptoms may fluctuate throughout the day. إذن myasthenia gravis أو الوهن العضلي هو اضطراب في المناعة الذاتية يتميز بضعف العضلات والتعب، وخاصة في العضلات الإرادية، ويحدث ذلك نتيجة مهاجمة الجهاز المناعي عن طريق الخطأ للمستقبلات الموجودات في الوصل العصبي أو في العضل أو في الوحدة العصبية العضلية، مما يؤدي إلى صعوبات في تقلص العضلات والتحكم فيها. وقد تتقلب الأعراض عادة على مدار اليوم وتتغير. Dystonia is a movement disorder characterized by involuntary muscle contractions that cause repetitive or twisting movements and abnormal postures. It can affect various parts of the body, leading to sustained or intermittent muscle contraction. إذا الخلل المتعلق بالتوتر العضلي هو اضطراب حركي يتميز بانقباضات العضلات اللا-إرادية التي تسبب حركات متكررة أو ملتوية ووضعيات غير طبيعية، ويمكن أن يؤثر على أجزاء مختلفة من الجسم، مما يؤدي إلى تقلصات في العضلات، وممكن أن تكون مستمرة أو متقطعة. Let's move to spinocerebral ataxia. It refers to a group of genetic disorders that results in progressive coordination problems and balance difficulties. It arises from degeneration of the cerebellum and spinal cord, leading to symptoms like unsteady gait, slurred speech, and lack of coordination. The spinocerebral ataxia هي مجموعة من الاضطرابات الوراثية التي تؤدي إلى مشاكل تدريجية في التنسيق وصعوبات في التوازن، وهذا ينشأ من عملية انحطاط في المخيخ وفي النخاع الشوكي، مما يؤدي إلى أعراض مثل السير الغير المستقر أو المشي غير مستقرة وتداخل في الكلام وعدم التنسيق. Charcot-Marie-Tooth disease is a hereditary neurological disorder affecting the peripheral nerves, leading to muscle weakness and atrophy, particularly in the feet and legs. It can cause difficulties with balance, walking, and fine motor skills. إذا نتكلم عن مرض Charcot-Marie-Tooth. هو اضطراب عصبي وراثي يؤثر على الأعصاب الطرفية، مما يؤدي إلى ضعف وضمور في العضلات، خاصة في القدمين والساقين، ويمكن أن يسبب صعوبات في التوازن والمشي، وأيضا في المهارات الحركية الدقيقة. Wilson's disease is a rare genetic disorder characterized by the abnormal accumulation of copper in the liver, brain, and other organs. Symptoms may include liver dysfunction, neurological issues like tremors and stiffness, and psychiatric disturbances. إذا Wilson disease هو اضطراب وراثي نادر يتميز بتراكم النحاس بشكل غير طبيعي في الكبد والدماغ والأعضاء الأخرى، وقد تشمل هذه الأعراض خللا في وظائف الكبد ومشاكل عصبية مثل الرعشة والتصلب واضطرابات نفسية. Friedreich's ataxia is a progressive genetic disorder that affects the nervous system and heart. It results in muscle weakness, impaired coordination, and balance problem. Other symptoms may include heart abnormalities and, in some cases, diabetes. إذن هو اضطراب فريدريك أتاكسيا هو اضطراب وراثي تقدمي يؤثر على الجهاز العصبي والقلب، ويؤدي إلى ضعف في العضلات وضعف في التنسيق ومشاكل في التوازن، وأيضا قد تشمل الأعراض الأخرى تشوهات في القلب، وفي بعض الحالات مرض السكري. Rett syndrome أو متلازمة ريت is a rare genetic disorder that predominantly affects girls, causing developmental regression, loss of purposeful hand skills, and the emergence of repetitive hand movements. Individuals with Rett syndrome may experience severe cognitive and motor impairment. إذا هي متلازمة تريت هي اضطراب وراثي نادر يصيب الفتيات في الغالب ويسبب تراجعا في النمو وفقدان المهارات في حركات اليد وظهور حركات غير طبيعية ومتكررة في اليد. وقد يعاني هنا الأفراد المصابين بهذه المتلازمة من إعاقات إدراكية وحركية شديدة. Leukodystrophy refers to a group of genetic disorder characterized by the progressive degeneration of the white matter myelin in the central nervous system. This results in a range of neurological symptoms, including impaired motor skills, cognitive decline, and sometimes seizures. إذا المشكلة في الكريات البيض أو الحقل في الكريات البيض أو البيضاء هي تشير إلى مجموعة من الاضطرابات بشكل عام، اضطرابات وراثية التي تتميز بالتدهور التدريجي للمادة البيضاء الميلين في الجهاز العصبي المركزي، ويؤدي هذا إلى مجموعة من العوارض العصبية بما في ذلك ضعف المهارات الحركية والتدهور المعرفي وأحيانا نوبات. Neurofibromatosis is a genetic disorder that causes tumors to form on nerve tissue. There are two types, NF1 and NF2. NF1 is characterized by skin abnormalities and tumors, while NF2 primarily involves tumors on the nerves responsible of hearing and balance. So symptoms vary widely. إذن الورم العصبي الليفي هو اضطراب وراثي يؤدي إلى تشكل الأورام على الأنسجة العصبية، وهنالك نوعان NF1 والNF2. يتميز الNF1 بتشوهات الجلد والأورام، في حين الNF2 ينطوي في المقام الأول على أورام في الأعصاب المسؤولة عن السمع والتوازن، وتختلف الأعراض هنا على نطاق واسع. Spinocerebral ataxia أو الترنح المخيخي الشوكي refers to a group of genetic disorder leading to progressive coordination problems and balance difficulties due to degeneration in the cerebellum and spinal cord. It manifests as unsteady gait, slurred speech, and lack of coordination. إذن يشير هذه المشكلة إلى مجموعة من الاضطرابات الوراثية التي تؤدي إلى مشاكل التنسيق التقدمية وتؤدي أيضا إلى صعوبات في التوازن بسبب مشاكل متعلقة في المخيخ وفي النخاع الشوكي، وتجلى ذلك في طريقة المشي غير المستقرة والكلام الغير مفهوم والتداخل في الكلام وعدم التناسق في الحركات. اوكي تمام. اوكي انتهينا من مرحله النيورو الاذان الجهاز العصبي بشكل عام، و حاولت انه اتكلم عن كل المصطلحات الممكنه ان كانت في الاناتومي او في الباثولوجي اكثريه، ولكن وليس كل المصطلحات. اوكي كله تمام للحين. اوكي قبل الانتقال الى الانتجمنتري سيستم اور ذا سكين، نتكلم عن الجلد او عن السكين. تمام. اوكي so the integumentary system skin, it's two layers. Epidermis, as you know, it's superficial, and dermis is deeper. So below the skin lays subcutaneous tissue, fat that insulates and serves as energy reservoir. إذا هنالك طبقتان، البشرة السطحية والديرمس الأعمق، وأيضا تحت الجلد يكمن الأنسجة وأيضا هنالك الدهون التي تعمل على العزل وتعمل كمخزن للطاقة. Okay, as you can see here. The skin in the largest single organ as a physiology. So the skin is the largest single organ. هو أكبر عضو في الجسم منفرد. Three major function. هنالك 3 وظائف رئيسية كما تعلمون. Protect the body in the environment, regulate body temperature, transmit information from environment to brain. إذن 3 وظائف رئيسية للجلد: حماية الجسم في ضمن بيئته، وتنظيم درجة حرارة الجسم، ونقل المعلومات من البيئة الخارجية إلى الدماغ. Okay, so let's talk here about some terms related to integumentary system. Okay, بعض المصطلحات المتعلقة بهذا النظام. Epidermis أو البشرة بشكل عام function provides a protective barriers against pathogens, UV radiation and environmental hazards. It also helps in preventing water loss. إذا كما تعلمون توفر حاجزا وقائيا ضد مسببات الأمراض بشكل عام والأشعة الفوق البنفسجية والمخاطر البيئية، كما أن البشرة تساعد على منع فقدان المياه. Dermis function contain blood vessels, nerve ending, and various structure. It provides strength, elasticity, and support to the skin. The dermis is involved in temperature regulation and sensation. إذن الديرمس هي تحتوي على أوعية دموية، وتحتوي أيضا على النهايات العصبية وهياكل مختلفة، وأيضا توفر القوة والمرونة والدعم للبشرة، وتشارك أيضا في تنظيم درجة الحرارة وفي الإحساس. Subcutaneous layer hypodermis acts as an insulator helping regulate body temperature. It also provides cushioning and support for underlying structures. إذن الطبقة التي هي تحت الجلد الهايبوديرمس تعمل كعازل وتساعد على تنظيم درجة حرارة الجسم، كما أنه توفر الدعم للهياكل الأساسية. Melanin protect the skin from the harmful effects of ultraviolet UV radiation by absorbing and scattering UV light. It contributes to the color of the skin, hair, and eyes. إذن هي الميلانين هي أو تحمي البشرة من التأثيرات الضارة للأشعة فوق البنفسجية عن طريق امتصاص الأشعة وتشتيتها، وأيضا تساهم في لون الجلد والشعر والعينين. Let's move to hair follicle أو بصيلات الشعر بشكل عام. Serves as the structure from which hair grows. Hair provides some insulation and protection for the skin. Additionally, hair on the scalp helps protect against UV radiation. إذا بشكل عام وسريع هي بمثابة الهيكل الذي ينمو منه الشعر، ويوفر الشعر بعض العزل والحماية للبشرة كما تعلمون. بالإضافة إلى ذلك يساعد هذا الشعر الموجود على فروة الرأس على الحماية من الأشعة فوق البنفسجية. الكيراتين provides structural integrity to the skin, hair, and nails. Keratinization is the process by which cells in the outer layers of the epidermis produce keratin, forming a protective barriers. إذن الكيراتين هو ما يوفر السلامة الهيكلية للبشرة والشعر والأظافر، وأيضا هو العملية التي تنتج من خلالها أو تنتج من خلالها الخلايا الموجودة في الطبقات الخارجية للبشرة، تنتج الكيراتين مما يشكل حاجزا وقائيا. Eccrine glands أو الغدد التي المفرزة secrete watery sweat to help cool the body in response to elevated temperatures. They are found throughout the body. إذن هي حيث يحصل إفراز العرق المائي للمساعدة في تبريد الجسم واستجابة لدرجات الحرارة المرتفعة. Apocrine glands secrete a thicker milky sweat that contain protein and lipids. These glands are activated during emotional stress and are typically found in areas with dense hair follicle. إذن تفرز هنا عرقا حيويا كثيفا يحتوي على البروتينات والدهون، وهنا يتم تنشيط هذه الغدد أثناء التوتر العاطفي، وتوجد عادة في المناطق ذات بصيلات الشعر الكثيفة. تمام؟ Erector pili muscles, small muscles attached on hair follicles. Contraction of these muscles causes hair to stand upright and help trap a layer of hair for insulation. إذن هذه العضلات الصغيرة المتصلة ببصيلات الشعر يؤدي تقلص هذه العضلات إلى وقوف الشعر في وضع مستقيم ما يعرف بالقشعريرة، ويساعد في احتجاز طبقة من الهواء للعزل. Langerhans cells, immune cells found in the epidermis that play a role in protecting the skin against pathogen. إذن هي الخلايا المناعية الموجودة في البشرة والتي تلعب دورا في حماية الجلد من مسببات الأمراض. Sebaceous glands أو الغدد الدهنية produce sebum, an oily substance that lubricates the skin and hair. Sebum helps prevent dehydration, maintains skin flexibility, and inhibits the growth of certain bacteria. إذن هي مادة دهنية تعمل على تليين الجلد والشعر ومنع الجفاف وحفظ على مرونة الجلد وتمنع نمو بعض البكتيريا. Sudoriferous glands produce sweat, which helps regulate body temperature through evaporative cooling. Sweat also plays a role in excreting certain waste products. إذا الغدد العرقية وإذا هي إنتاج حيث ينتج العرق مما يساعد على تنظيم درجة حرارة الجسم من خلال التبريد والتبخر، وأيضا هذه الغدد أو هذا العرق يلعب دورا في إخراج بعض البرودكتس من الجسم. تمام، واضح؟ أوكي. المحاضرة الأولى تنتهي بعد حوالي ربع ساعة ممكن، وهنالك المحاضرة الثانية للساعة 9. عفوا الساعة نعم للساعة 9:30. Okay, let's move to some terms of pathologies related to integumentary system. Okay, إذا بعض المصطلحات المتعلقة بالباثولوجي. Okay. Dermatitis, inflammation of the skin. Okay, إذا التهاب الجلد، وعادة ما يؤدي إلى الإحمرار والحكة والتورم كما نعرف. Psoriasis, a chronic autoimmune condition characterized by the rapid buildup of skin cells. إذا الصدفية أو الصدفية حالة من أمراض المناعة الذاتية المزمنة وتتميز بالتراكم السريع لخلايا الجلد. Melanoma, it's a type of skin cancer that develops from melanocytes. إذا سرطان الجلد وهو نوع من السرطان يتطور من الخلايا الصباغية، وهي الخلايا المنتجة للصباغ في الجلد. Basal cell carcinoma, the most common type of skin cancer originating in the basal cells of the epidermis, often characterized by a pearly or waxy bump. إذا هو النوع الأكثر شيوعاً من سرطان الجلد والذي ينشأ في الخلايا القاعدية للبشرة، وغالبيا ما يتميز بوجود نتوء لؤلؤي أو من نوع الوكسي أو الشمعي. Squamous cell carcinoma, it's a skin cancer arising from the squamous cells, often presenting as a red scaly patch or a persistent sore. إذا هذا النوع من سرطان الخلايا، خلايا الجلد، ينشأ من الخلايا الحشفية، وغالبا ما يظهر على شكل رقعة حمراء متقشرة أو قرحة مستمرة في الجلد. الإكزيما It's a chronic skin condition causing inflammation, redness, and itching. It can have various causes, including allergies and genetics. إذا هي حالة جلدية مزمنة تسبب الالتهاب والاحمرار والحكة، ويمكن أن يكون لها أسباب مختلفة بما في ذلك الحساسية والوراثة. Hives or urticaria, raised itchy welts on the skin caused by an allergic reaction or other triggers. إذا هي كدمات مرتفعة ومثيرة للحكة على الجلد ناجمة عن رد فعل تحسسي أو محفزات أخرى. Vitiligo, it's a condition where the skin loses pigmentation resulting in white patches or depigmented areas. إذا هي البهاق، ما يعرف بالبهاق، حالة يفقد فيها الجلد التصبغ مما يؤدي إلى ظهور بقع بيضاء أو مناطق ناقصة الصباغ. Acne, you know what acne, it's a common skin condition characterized by the presence of pimples, blackheads, and whiteheads caused by the clogging of hair follicles with oil and dead skin cells. إذا هو حب الشباب، وهي حالة جلدية شائعة تتميز بوجود البثور والرؤوس السوداء والرؤوس البيضاء كما تعلمون، والتي هي ناتجة عن انسداد بصيلات الشعر. Cellulitis, it's a bacterial infection of the skin and subcutaneous tissues causing redness, warmth, and swelling. إذا النسيج الخلوي هي الإصابة بالعدوى البكتيرية في الجلد والأنسجة التي هي تحت الجلد، مما يسبب الاحمرار والحرارة والتورم. Okay. Let's move to lichen planus. It's an inflammatory condition affecting the skin, mucous membranes, and sometimes nails, presenting as itchy, purplish, flat-topped, and bumps. إذا هي حالة التهابية تؤثر على الجلد والأغشية والمخاطية وأحيانا الأظافر. Alopecia, it's hair loss which can occur on the scalp or other parts of the body. إذا الثعلبة ألوبكسيا قد يحدث هنا تساقط الشعر الذي يمكن أن يكون على فروة الرأس أو أجزاء أخرى من الجسم. Seborrheic dermatitis, inflammation of the skin characterized by red, scaly patches, commonly affecting the scalp and face and other oily areas. التهاب الجلد الدهني هو التهاب الجلد الذي يتميز ببقع حمراء متقشرة، وعادة ما يؤثر على فروة الرأس والوجه والمناطق الدهنية الأخرى. Okay. Let's move now to the endocrine system. Okay. So let's move directly to terms related to the endocrine system. The endocrine system is a network of glands that produce and secrete hormones to regulate various physiological functions. إذا هو نظام الغدد الصماء، شبكة من الغدد التي تنتج وتفرز هرمونات لتنظيم الوظائف الفيزيولوجية المختلفة. الهرمون تعرفون ما هو؟ الجلاند الغدة، pituitary gland الغدة النخامية. It's often referred to as the master gland. It's located at the base of the brain and regulates other endocrine glands. إذا غالبا ما يشار إليها باسم الغدة الرئيسية، وتقع في قاعدة الدماغ وتنظم الغدد الصماء الأخرى. Hypothalamus, it's a region of the brain that links to the nervous system to the endocrine system, producing hormones that control the pituitary gland. إذا هي منطقة في الدماغ تربط الجهاز العصبي بجهاز الغدد الصماء، وتنتج الهرمونات التي تتحكم في الغدة النخامية. Thyroid gland, الغدة الدرقية, located in the neck, as you know, so it produces hormones like thyroxine and triiodothyronine that regulate metabolism and growth. إذا هي تقع في الرقبة وتنتج هرمونات الغدة الدرقية إلى آخره، والتي تنظم عملية التمثيل الغذائي والنمو. Adrenal glands, situated on top of each kidney. They produce hormones such as cortisol and adrenaline involved in stress response and metabolism. إذا الغدد القذرية والتي تقع فوق كل كلية من الكلى والتي تنتج أيضا هرمونات مثل الكورتيزول والأدرينالين. Pancreas, you know what is it? Islets of Langerhans. هي مجموعة من الخلايا في البنكرياس وتنتج الهرمونات بما في ذلك الأنسولين والجلوكاجون. Adipose tissue. It's a fat tissue that can release hormones such as leptin affecting metabolism and appetite. إذن هي الأنسجة الدهنية التي يمكنها إنتاج الهرمونات مثل الليبتين مما يؤثر على عملية التمثيل الغذائي والشهية. Gonads, reproductive glands, ovaries in females and testes in male, producing sex hormones. إذن هي الغدد التناسلية لدى الإناث والذكور. Estrogen, testosterone, estrogen and progesterone. إذن هي هرمون جنسي. التستوستيرون هو هرمون جنسي ذكري والاستروجين والبروجسترون هو هرمونات جنسية أنثوية كما تعلمون. Melatonin, it's a hormone produced by the pineal gland that regulates sleep-wake cycles. إذن الميلاتونين هي هرمون تفرزه الغدة الصنوبرية وينظم دورات النوم والاستيقاظ. Calcitonin, hormone produced by the thyroid gland that helps regulate calcium levels in the blood. إذن هو هرمون تفرزه الغدة الدرقية ويساعد على تنظيم مستويات الكالسيوم في الدم. Insulin, you know what is it? It's a hormone produced by the pancreas that lowers blood sugar level by promoting the uptake of glucose by cells. Glucagon, it's a hormone produced by the pancreas that raises blood sugar levels by stimulating the liver to convert stored glycogen into glucose. إذن هو هرمون يفرزه البنكرياس ويرفع مستويات السكر في الدم عن طريق تحفيز الكبد لتحويل الجليكوجين المخزن إلى جلوكوز. Cortisol, it's a stress hormone produced by the adrenal glands. إذن هو هرمون التوتر التي تنتجه الغدة الكظرية. Aldosterone, it's a hormone produced by the adrenal glands that regulates salt and water balance, influencing for sure blood pressure. إذن هو هرمون تفرزه الغدد الكظرية وينظم توازن الملح والمياه ويؤثر على ضغط الدم. Also in terms related to pathologies here, diabetes mellitus أو السكري, hypothyroidism, it's a condition where the thyroid gland does not produce enough thyroid hormones. إذا قصور الغدة الدرقية hypothyroidism. Hyperthyroidism هو فرط نشاط الغدة الدرقية مما يؤدي إلى الإفراط في إنتاج الهرمون مما يسبب أيضا أعراض مثل فقدان الوزن وسرعة ضربات القلب وإلى آخره. Cushing syndrome, it's a disorder characterized by prolonged exposure to high levels of cortisol, leading to symptoms such as weight gain, muscle weakness, and changes in skin appearances. إذن متلازمة كوشينج هي اضطراب يتميز بالتعرض لفترات طويلة لمستويات عالية من الكورتيزول مما يؤدي إلى أعراض مثل زيادة الوزن، ضعف العضلات، وتغييرات في مظهر الجلد. Addison's disease, adrenal insufficiency, where the adrenal glands do not produce enough cortisol and aldosterone, leading to symptoms like fatigue, weight loss, and low blood pressure. إذن مرض أديسون هو قصور الغدة القذرية حيث لا تنتج الغدة القذرية ما يكفي من الكورتيزول والالدوستيرون مما يؤدي إلى أعراض مثل التعب وفقدان الوزن وانخفاض في ضغط الدم. Acromegaly, it's an excessive production of growth hormone in adults, usually caused by a tumor resulting in large bones and tissues. هنا يعرف بضخامة الأطراف. إذن الإفراط في إنتاج هرمون النمو لدى البالغين وعادة ما يحدث بسبب ورم مما يؤدي إلى تضخم العظام والأنسجة. Hyperparathyroidism, It's an overactivity of the parathyroid glands, leading to elevated level of parathyroid hormone, causing increased calcium level in the blood and potential bones loss. إذا فرط نشاط الغدد درقيا مما يؤدي إلى ارتفاع مستويات هرمون الغدة الدرقية، مما يسبب زيادة مستويات الكالسيوم في الدم واحتمال فقدان العظام. Okay. Preochromocytoma, it's a rare tumor of the adrenal glands causing excessive release of catecholamines, leading to symptoms such as high blood pressure and rapid heart rate. إذن هي ورم القواطر، نعرف ورم نادر في الغدد الكظرية يسبب الإفراط في إفراز الكاتيكولامينات، مما يؤدي إلى أعراض مثل ارتفاع ضغط الدم وسرعة ضربات القلب وذلك. Hyperaldosteronism, it's an overproduction of aldosterone by the adrenal glands, affecting sodium and potassium balance and blood pressure. إذن هي الإفراط في إنتاج الألدوستيرون من الغدة القذرية، مما يؤدي أو مما يؤثر على توازن الصوديوم والبوتاسيوم وضغط الدم. Okay, I want to thank you. شكرا. سنأخذ 5 دقائق استراحة فقط، الوقت لأبدل الشرائح وننتقل إلى المحاضرة الثانية سريعا عن الماسكولوسكيليتال جهاز العضلي والعظم. فقط دقائق معدودة ولأحضر الشرائح المحاضرة الثانية. ثواني ونبتدي بالمحاضرة الثانية. واضح الصوت لو سمحتم؟ الصوت والشرائح واضحين؟ أعتذر مجددا عن الخطأ التقني. تمام. شكرا. Okay. So let's move to talk about the musculoskeletal system. إذا سنتكلم عن الجهاز العضلي والعظمي بشكل واضح وصريح. إذا so it's in the very young, so the skeleton is composed of mostly, as you know, cartilage and is therefore pliable with a decreased incidence of bone fracture and breakage in childhood. So we have the mature bone. It's a rigid connective tissue consisting of cells, collagen, calcium, and phosphate. Okay, so as you can see here, the skeleton in general, تعرفونه, so the cranium, facial bones, mandibles, the carpal, metacarps, phalanges. Okay. سنتكلم مع بعض بالتفصيل عن كل المواضيع. So as you know, we have 206 bones in the human skeleton. In the hand, we have the carpals, metacarpals, and phalanges. In the foot, we have tarsal, metatarsal, and phalanges. As you can see, it's a skeleton. You have the skull, the clavicle, scapula, the sternum, ribs, okay, the vertebra, ulna here. So you have the ulna and the radius, okay. So the skeleton in general, you have the axial portion, like the cranium, the vertebra, and the ribs. It's the axial portion. The appendicular portion, it's the limb, shoulders and hips. Okay, limbs, shoulders, and hips. The structure and function in general, so the skeletal system, it's a bone formation, maintenance, and healing. Also, you have the articular system, where we have joints, synarthrosis, amphiarthrosis, and diarthrosis. We will talk about this later. Skeletal muscle system, we will be talking about the contraction, tone, actions, and exercises. Not sure about the exercises, but for sure about contraction, tone, and actions. Okay, so let's start with the types of bones. You have the long bone, example femora, the short bones like the metacarpals, and the flat bone like the sternum, and the irregular bones like the vertebra. The functions of bone usually support and protect structures of the body, provide attachment of muscles, tendon, and ligaments. Let's talk here about the characteristics of joints. Okay, so the joints, as you know, allow the movement between bones, formed where two bones join surface are covered with cartilage and enclosed in a capsule. Classification of joints, we have the synarthrotic, immovable, and amphiarthrotic, it's slightly movable joints. And diarthrodial, it's freely movable joint. Okay, so it's contain a cavity, if you want, filled with synovial fluid, ligaments hold the bone and joint to the correct position, and articulation in the meeting point of two or more joints. And as I said about the classification, the synarthrose is so here we're gonna talk about the synarthrosis. It's a fibrous or fixed joint, as you know. It's no movement associated with this joint. Amphiarthrotic, it's a slightly movable, as we said. So cartilaginous joint, slightly movable, as I said. Diarthrodial, it's a freely movable joint. So like ball and socket, synovial joint, like saddle, pivot, blending, etc. And we have the condyloid, freely movable joint, allow frictionless and painless movement. Okay. So this is, let's move a little bit to talk about the muscles. So you have the neuromuscular junction, as you know. This is, we have 4 steps of muscle contraction, and it's good to talk about this also. اللي تعرفوا بعض المصطلحات. Excitation, it's we have the excitation, the coupling, and the contraction, and the relaxation. So the process of the contraction and the relaxation in the muscles. So muscle contraction and relaxation require large amps of adenosine triphosphate. So the contraction also requires calcium, which function as a catalyst. So you have the acetylcholine released by the motor end plate of the motor neuron initiates an action potential, and the acetylcholine is then destroyed by the acetylcholinesterase. Okay. We have the age-related changes of musculoskeletal system, like bones, muscle, joint, ligaments. We're going to talk also about the risk factors: autoimmune disorder, calcium deficiency, degenerative conditions, falls, etc. And the medication, metabolic disorder, all of these factors can ممكن أنها تأثر على age of the musculoskeletal or age-related changes أو عمر أو التغيرات للmusculoskeletal system بخلال العمر والتقدم في العمر. Okay. Let's talk a little bit here about the X-ray in general. As you can know, it's a commonly used procedure to diagnose disorder to the muscular system. The arthrocentesis, it's involves aspirating synovial fluid, blood, or pus via a needle inserted into a joint cavity. And sometimes we have to obtain a consent form before we do it. The arthrogram, it's a radiographic examination also of the soft tissue of the joint structures used to diagnose trauma to the joint capsule or ligament. The arthroscopy provide an endoscopic examination of various joints, as you know. So articular cartilage abnormalities can be assessed, loose bodies can be removed, and the cartilage trimmed. And sometimes a biopsy may be performed during the procedure. Bone scan, it's a radioisotope is injected IV and will collect in areas that indicate abnormal bone metabolism and some fractures if they exist. So the isotope is excreted in the urine and passes within 40 hours or 48 hours and is not harmful to others. Bone of or muscle biopsy in general. It's an act may be done during surgery or through aspiration or punch or needle biopsy. Electromyography, as you know, it's a measures electrical potential associated with skeletal muscle contractions. Needles are inserted into the muscles, and recording of muscular electrical activity are traced on recording paper through on oscilloscope. Myelogram, it's an injection of dye or air into the subarachnoid space to detect abnormalities of the spinal cord and vertebra. So here's the procedures is to obtain also a consent form before we do it, and provide hydration for at least 12 hours before the test, assess for allergy to iodine, and pre-medicate for sedation as prescribed. The musculoskeletal injuries now in general. The fracture, as you know, it's a break in the continuity of the bone caused by trauma, twisting as a result of muscle spasm or indirect loss of leverage, or bone decalcification and diseases that result in osteopenia. So we have types of fractures, you know, we have the complete or incomplete, the open, formerly referred to a compound, and closed, formerly referred as a simple. So the bone is completely separated when we said complete. So the bone is completely separated by a break into two parts. Incomplete, it's a partial break in the bone. We have the open compound, as we said, and the closed or simple. The open compound is exposed to air through a break in the skin, and soft tissue injury and infection are common. Closed or simple, it's a skin over the fractured area remains intact. Okay. In the complete fracture, the bone is completely separated by a break into two parts, as we said, linear fracture parallel to long axis of bone, oblique, it's a fracture line at 45-degree angle to long axis of bone oblique. Transverse, it's a fracture line at 90-degree angle to long axis of pelvic. In general, in the transverse, the bone is fractured straight across. For the spiral, the fracture encircles the bone. Okay, بتكون حول العظم. The complete fracture, we have the comminuted, impacted, pathologic, and evolution. Comminuted, it's the bone is splintered or crushed with 3 or more fragments. إذا عندنا عدة تكسر العظمة إلى عدة fragments. So the impacted, it's a part of the fractured bone is driven into another bone. So the bone fragments are pushed into each other. Pathological, it's a fracture due to weakening of the bone structure by pathological process such as neoplasia or osteomalacia, also called spontaneous fracture. So also we have, as we said, the pathologic, it's a fracture occurs at a point in the bone weakened by disease. The depressed, it's a bone fragment are driven inward. And the evolution, it's a fragment of bone connected to a ligament breaks off from the main bone. Okay, let's talk about the complete fracture. We have the compression, displaced, extracapsular, and intracapsular. The compression, it's a fractured bone compressed by other bone. So the compression, it's a fracture the fracture is wedged or squeezed together on one side of bone. Displaced is a fracture with one, both, or all fragment out of normal alignment. Extracapsular, it's a fragment outside joint capsule. Intrascapular, fragment inside the joint capsule. About the incomplete fractures, we have the green stick, torus, bowing fracture, transchondral fracture, and stress fracture. So green stick, it's one side of the bone is broken and the other is bent, multawi, most commonly seen in children. Green stick, outer surface disrupted, inner surface intact, usually occurs in proximal metaphysis or diphysis of tibia, radis, or ulna. The torus is a bone cortex buckles, but does not break. It's common in osteoporosis. Okay. The bowing fracture, it's bending of bone. The transcondylar fracture, separation of cartilaginous surface from bone shaft. Stress fracture, we have the fatigue fracture and the insufficiency fracture caused by abnormal. So the fatigue fracture is caused by abnormal stress or torque applied to bone with normal ability to deform and recover. Which the insufficiency fracture occur in bones lacking normal ability to deform and recover. Here the types of fracture in one figure. Closed, non-displaced. This is the open wounded. تطلع من الجلد. Comminuted fragment. Displaced, oblique, spiral, impacted, and green stick. Okay. Pathophysiology of a fracture. So we're gonna skip this part and move to a fracture of an extremity. Okay, so let's talk quickly about in a fracture of an extremity. We are going to talk about the assessment. So if there is a pain or tenderness over the involved area, we have loss of function, obvious deformity, crepitation, arrhythmia, edema, and ecchymosis, also muscle spasm and impaired sensation. The intervention for a fracture, here we talk about reduction, fixation, traction, and cast. We're going to talk about everyone. So the reduction in general, we can talk here about the open reduction and closed reduction. So the reduction is restoring the bone to a proper alignment. The closed reduction is performed by manual manipulation and may be performed under local or general anesthesia. And a cast may be applied following reduction. Okay. The open reduction involves a surgical intervention and may be treated with internal fixation devices. The client may be placed in traction or a cast following the procedure. Okay. This is the internal fixation, and this is the closed reduction. Okay. Types of internal fixation for a hip fracture, for example. You have the here the A, it's a femoral head endoprosthesis, and here it's a type of hip compression screwed with side plate. External fixation, it's an external frame, as you can see here, is utilized with multiple pins applied through the bone, provides more freedom of movement than with traction. And the type of the hip fracture, we have the intracapsular and the extracapsular. The intracapsular hip fracture, it's a bone when the bone is broken inside the joint. The skin traction is applied preoperatively to immobilize and prevent pain. Okay, and the capsular hip fracture can occur at the greater trochanter or can be an intertrochanteric fracture. Trochanteric fracture is outside the joint. When we said extracapsular, it's outside the joint. Okay, this is the total hip replacement. So this is the materials, as you know. Okay. About the total knee replacement, it's an implantation of a device to substitute of the femoral condyles and the tibial joint surfaces. Okay, this is the knee prosthesis, as you know. And this is the continuous passive motion. Okay, it's a device when we can do a continuous passive motion for the patient. This is a different kind of cast. Okay. About the cast care, we have the education and so apply eyes, instruct, prevent, and attend. Quickly, I'm gonna say about the educate, why it's necessary and how plaster may feel and extent of immobility. Also, we should tell the patient to apply ice directly over fracture for 24 hours at intervals and instruct no sharp object into cast, expose cast to air as much as possible, prevent skin irritation, clean areas with warm washcloth, and attend to complaint of pain, neuro checks, or are a must. Okay. Now I'm gonna talk about the traction in general and the different kind of traction. Okay. So the traction is the exertion of a pulling force applied in two directions to reduce and immobilize a fracture, provides proper bone alignment, and reduce muscle spasm. The skeletal traction, it's mechanically applied to the bone using pins, wires, or tongue, as you can see here. Okay. So traction applied by the use of elastic bandage or adhesive. We have so many types of skin traction: cervical traction, bucks traction, Bryan traction, pelvic traction, and Russell's traction. This is the cervical skin traction. Okay. The bucks skin traction, the pelvic skin traction, balanced suspension. Okay. So the cervical skin traction relieves muscle spasm and compression in the upper extremities and neck, uses a head halter and a chin pad to attach the traction. The buck skin traction, it's a boot appliance, is applied to attach to the traction. Okay. So weight is attached to a pulley, allow the weight to hang freely over the edge of bed. The pelvic one, the pelvic skin traction, used to relieve low back, hip, or leg pain and to reduce muscle spasm. The balanced suspension, used with skin or skeletal traction, used to approximate fracture of the femur and tibia and fibula, produced by a counter force other than climb. The Dunlop skin traction, it's an horizontal traction to align fractures of the humerus. Vertical traction maintain the forearm in proper alignment. Okay. Some complication of fracture, fat embolism, compartment syndrome, infection and osteomyelitis, avascular necrosis, pulmonary emboly. Okay. So the fat embolism, it's an embolism originating in the bone marrow that occurs after a fracture. Clients with long bone fractures are at the greatest risk of the development of fat embolism, usually occurs within 48 hours following the injury. The compartment syndrome, increased pressure within one or more compartment causing massive compromise of circulation to an area, leads to decreased perfusion and tissue anoxia within 4 to 6 hours after the onset of compartment syndrome. Neuromuscular damage is irreversible. The infection and osteomyelitis can be caused by the interruption of the integrity of the skin. The infection invades bones, bone tissue. Okay, avascular necrosis, it's an interruption in the blood supply to the bony tissue, which results in the death of the bone. Pulmonary embolism, it's restlessness and apprehension, dyspnea, diaphoresis, arterial blood gas changes. Okay, here we should notify the doctor, the physician, if signs of emboli are present, and prepare to administer anticoagulant therapy directly. The other skeletal trauma, we have the dislocation, subluxation, injury to support structure like tendon tear, ligament tear, strain, sprain, avulsion, tendonitis, and bursitis. I'm gonna pass quickly on the strains. It's an excessive stretching. It's a strain, so it's an excessive stretching of a muscle or tendon. The strains or the sprains, excuse me, the sprains is an excessive stretching of a ligament, usually caused by a twisting motion. The RICE acronym, when we use the RICE acronym, rest, ice, compression, and elevation to release pain on the tendon tear or ligament tear or strain or sprain. The carpal tunnel syndrome associated with occupation that require continuous wrist movement. The sport-related injury, it's a musculotendinous or rotator cuff of the shoulder sustains a tear, usually as a result of trauma, characterized by shoulder pain and the inability to maintain abduction of the arm at the shoulder. So the herniation, okay, intervertebral disc, it's a nucleus of the disc protrudes into the annulus, causing nerve compression. The lumbar disc, as you know, it's a must often here occurs in L4, L5, or L5S1 interspaces. It's a postural deformity occurs and produces muscle weakness, sensory loss, and alteration of the tendon reflexes. The client experiences low back pain and muscle spasm and is relieved by bed rest and treatment. Okay. So this is just a quick figures about the low back pain. This is correct and incorrect, as you can see. Type of disc surgery, it's chemolysis. This is the injection to dissolve affected disc. Discectomy, it's a removal of herniated disc tissue and related matter. Discectomy with fusion of vertebra with bone graft. Laminotomy, it's a division of the lamina of a vertebra. Laminectomy, it's a removal of the lamina. Okay, so laminotomy, it's a division of the lamina of a vertebra. Laminectomy, it's removal completely of the lamina. Disc surgery. So I'm gonna skip this one because we are talking just about terms and okay, مصطلحات طبية. So amputation of lower extremity. So the amputation of lower extremity, it's a surgical, as you know, it's a surgical removal of a lower limb or part of the limb. Okay, so as you can see here, how we do the stump wrapping, how we wrap the stump. So we have the below the knee amputation and above the knee amputation. Okay, usually we should prevent edema and do not allow the stump to hang over the edge and do not allow the client to sit for long periods of time to prevent contracture. Let's move here now to talk about disorder of bone, metabolic bone disease, infectious bone disease, and bone tumors. The infectious bone disease, like osteomyelitis, for example. So it can be caused by the interruption of the integrity of the skin. So the infection invades bone tissues. Okay. As an assessment, we have fever, we have pain, we have erythema in the area surrounding the fracture. We have tachycardia, elevated WBC count. Also, as an implementation, notify the physician and prepare to initiate aggressive IV antibiotic therapy when we have osteomyelitis. Bone tumors, it's a highest incidence in adolescent and adults. So it's in adolescents or adults more than or above 60 years old. Okay, so in the disorder of joints now, we have the non-inflammatory joint disease and inflammatory joint disease. In the inflammatory joint disease, we have the rheumatoid arthritis, ankylosing spondylitis, and gouty arthritis as per example, okay? So the rheumatoid arthritis, it's a chronic systemic inflammatory disease. The etiology may be related to a combination of environmental and genetic factors, leads to destruction of connective tissue and synovial membrane within the joint, weakness, and leads to dislocation of the joint and permanent deformity. And also its formation of pannus occurs of the junction of synovial tissue and articular cartilage projecting into the joint cavity and causing necrosis. Okay. So where you have the early stage and the moderate stage and the advanced stage, as you can see here. Okay, and also this is a muscle atrophy in the RA, boutonniere deformity, and swan neck deformity. This is the rheumatoid nodule, as you can see here. Okay, in the rheumatoid arthritis surgical intervention, we have the synovectomy, arthrodesis, and joint replacement. As per the synovectomy, it's a removal of the synovia to help maintain joint function. As per the arthrodesis, it's a bony fusion of a joint to regain some mobility. And for the joint replacement or arthroplasty, as you know, it's a replacement of diseased joint with artificial joints. Ankylosing spondylitis, it's we have the chronic inflammatory disease, the systematic autoimmune disease, the first from RA, and sign. We're gonna talk about the chronic inflammatory disease characterized by stiffening and fusion, ankylosis of spine and sacroiliac joints, It's an systematic autoimmune disease, and differs from the RA in that primary site of inflammation in RA is the synovial membrane. The Coady joint, it's a systematic disease in which urate crystal deposit in joints and other body tissues, leads to abnormal amount of uric acid in the body. Primary gout results from a disorder of purine metabolism. Secondary gout involves excessive uric acid in the blood that is caused by another disease. Okay. The non-inflammatory joint disease, as I said before, like osteoarthritis. Okay, it's also known as the degenerative joint disease. Cause is unknown, but may be caused by trauma, fracture, infection, or obesity. Progressive degeneration of the joint caused by wear and tear. Okay, so severe osteoarthritis here. And Heberden's nodes and Bouchard's nodes. As per the osteoarthritis surgical intervention, we have the osteotomy. When we said osteotomy, the bone is cut to correct the joint deformity and promote the realignment. We have also the total joint replacement, as I said before. It's performed when all measures of pain relief have failed. Hips and knees are most commonly replaced, contraindicated in the presence of infection, advanced osteoporosis, and severe inflammation. Let's talk now about metabolic bone diseases like osteoporosis, osteomalacia, and Paget's disease. Osteoporosis, it's an age-related metabolic disease. Bone demineralization results in the loss of bone mass, leading to fragile and porous bones and subsequent fractures. Greater bone resorption, that bone formation occurs most commonly in the wrist, hip, and vertebral column. Can occur post-menopausal or as a result of a metabolic disorder or calcium deficiency. Okay, and here we put the Milwaukee brace usually. Let's say the brace, we apply a back brace here, are prescribed during an acute phase to immobilize the spine and provide spinal column support, and also encourage the use of a firm mattress, provide a diet high in protein, etc. Okay, osteomalacia. It's a disease characterized by inadequate and delayed mineralization of osteoid in compact and spongy bone. Paget disease, it's a osteotis deformans, a state of increased metabolic activity in bone characterized by abnormal and excessive bone remodeling, both resorption and formation. Most often affects vertebrae, skull, sacrum, sternum, and pelvis and femur. Occurs with equal frequency in men and women older than 40 years old, and may occur in one or more bones without symptoms, usually no symptoms. Overgrowth of bone can compress areas of the brain, producing altered mentality and dementia. Impingement on cranial nerves may cause sensory abnormality, impaired motor function, deafness, atrophy of optic nerves. Okay, I want to thank you so much. This is the end of this presentation. It was a bit straight to the point. Okay. Any question? هل هنالك من أسئلة؟ Okay, thank you so much. Okay, ناخد break about less than 10 minutes, maybe 9 minutes, and at 10 تبتدوا مع زميلي دكتور أنطوان. Okay, in 9 minutes. Okay.
Okay. And can you see the slides as well? The slides are clear? Okay. So we'll start. So we still have the last lectures of today. We'll talk now about cardiovascular and respiratory medical terminology and disease. So we'll start by talking about cardiovascular diseases. So just to summarize what we said at the start of these lectures. So cardio means heart. It's from Greek origin. When we say logist, we mean specialist. So when we combine the two, cardio and logist, we will have cardiologist, which is heart specialist. And when we talk logi, so it's a study of, and when we combine the two together, cardiology is a study of the heart. So we have cardiologist and cardiology. When we say itis at the end of the word, we mean inflammation. So when we say carditis, it's the inflammation of the heart. And when we say pericarditis, it's the inflammation of the pericardium, which is the outer cover of the heart. And when we say myocarditis, it's the inflammation of the myocardium, which is the heart muscle. So the term pericarditis, as we said, has origin from Greek. The peri word means around, and cardia means heart. And the suffix itis at the end denote inflammation, as we said. So when we combine the two together, we have pericarditis, which means inflammation around the heart, so the cover of the heart. And pericardium, which is a sin, it's a double-layered sac that surrounds the heart and helps protect it. The pericardium consists of two layers. We have the outer fibrous layer and the inner serous layer. So it covers the heart, but it consists of two separate layers. So the outer layer and the inner layer. And in between, we have a physiologic fluid that helps decrease the friction around the heart. So it allows the heart to move inside this space without friction. So when we have pericarditis, we have inflammation of the pericardium, which you can see here, it's the outer layer of the heart. And sometimes when we have inflammation, we have a fluid accumulating in this space. We said we have a cavity between the two layers of the pericardium. And when we have this, we call it a pericardial effusion, so accumulation of fluid inside of this space. The most common causes are viral infections. So we saw a lot of cases during the coronavirus pandemic. We saw a lot of cases also after the coronavirus vaccine. So it's associated with viral infections most commonly. Uremia, so if a patient has chronic kidney disease on dialysis, he can develop pericarditis due to accumulation of toxic products like uremia. And it can be due to autoimmune disease. So a lot of autoimmune condition will lead to production of autoantibodies. These antibodies will go attack the pericardium and will induce inflammation, or it can be due to a trauma of the chest. So after a trauma of the chest, we can develop it. And the symptoms, we will have severe chest pain. So the chest pain, which sometimes mimic myocardial infarction, but this chest pain is typical that when the patient is lying flat on his back, when he's sleeping, the pain increases. And when he moves forward, so when he sits and he bent forward, the pain will decrease. So this is the characteristic feature of pericarditis pain. You're hearing me well, right? It's clear for you? Okay. So as we said, it's a severe, sharp, retrosternal chest pain, but the pain will worsen when supine, and it will improve while sitting or upright and leaning forward. Okay, I will try to decrease the pace a bit. So as we said, severe pain that is retrosternal, so it mimics myocardial infarction. It increases with each respiration. So when you take air inside, this will increase the pain. It will improve when we sit, but it will increase when we sleep or when we are in a supine position. So this is a very characteristic pain of pericarditis. How to confirm the diagnosis? It's very easy. We have the history. We ask the patient. He will tell us that he had a viral illness 1 week or 2 weeks or few days prior to his presentation to the emergency department. He had fever. He had virus. He had a vaccine, and he describes the pain as we said. So retrosternal increases when supine and decreases when moving forward. And we do an electrocardiogram. The electrocardiogram, you will see diffuse ST segment elevation. So the ST segment should be down here. You can see that the ST segment is elevated here. And you can see that the PR segment here is depressed. So these are two characteristic features of acute pericarditis. So PR segment depression and widespread ST segment elevation. You see it in all the electrodes, not just in one lead, but you can see it in all the electrodes of the heart. So this is very characteristic of this condition. Same when we do a cardiac ultrasound. So this is a cardiac ultrasound. Here you have the left atrium. Here you have the left ventricle. Here you have the right ventricle, and here you have the aorta. Here you can see there's a space filled with fluid. So this space normally should not have this excessive amount of fluid. This is the pericardial space. So here we have a pericardial effusion post-pericarditis. So the inflammation in this area induced the accumulation of this fluid. So we have a large pericardial effusion surrounding the heart. So this is a very high-risk situation because this fluid can cause compression around the heart. So it can compress mainly the right ventricle because the pressure in the right ventricle is low as compared to the left ventricle. So this cavity is at risk of compression. And in that case, we can have a condition called cardiac tamponade. So the patient will start having hypotension. So he will be in a state of emergency. So in that case, we sometimes need to aspirate this fluid urgently in order to save the life of our patient. Now for the treatment of acute pericarditis, so there is a lot of guidelines about the treatment, but mainly you need to know that we need to give an anti-inflammatory drug, either aspirin or ibuprofen. So either aspirin or ibuprofen, but we need to give a high dose of aspirin. So we give 1 gram of aspirin every 8 hours. We give it for a duration of 2 weeks. So normally the usual dose of aspirin is 100 milligrams, but here we're giving 1000 milligram every 8 hours. So when we increase this dose, it's an anti-inflammatory dose. It does not act on the platelets. It acts on the as anti-inflammatory dose, we said. Or we can give ibuprofen, but aspirin is preferred, but both can be given. Plus, we need to give colchicine for everyone. Colchicine is medications that is approved for acute pericarditis. You give it if the patient is less than 70, you give 0.5 milligram once a day. If the patient is above 70 kilograms, you give it 0.5 milligram twice a day. And you continue this for a duration of 3 months. And after 3 months, you can stop it. You can stop it without tapering. Unlike aspirin, you need to taper it down and don't stop it progressively. So you stop it over 2 weeks. But colchicine, after 3 months, we can stop it directly. We don't need to taper it down. So this is the treatment. We have a protocol, so we can follow it. Now we can ask for cardiac biomarker because, as we said, the patient comes with severe chest pain. Sometimes it can mimic myocardial infarction, the pain. So we need to ask for troponin always. And in pericarditis, you can see that the troponin is always negative. So when we have pericarditis, we can't have a positive troponin. If we have a positive troponin, it means that the myocardium is affected. So either we have associated myocarditis, so inflammation of the myocardium, or we have acute coronary syndrome or a coronary spasm. So, but in general, in pericarditis, you should have a negative troponin or negative cardiac enzymes. Now we move to myocarditis. We said pericarditis is the outer layer of the heart. It's the cover of the heart, if you want. Myocarditis, the myocardium is the main muscle of the heart. It's the middle layer of the heart. So when we have inflammation of this heart layer, we call it myocarditis. The inflammation here, it can weaken the heart muscle and it can cause heart failure. So the heart won't be able to pump blood as expected, because here the inflammation is inside the muscle, which is responsible of pumping blood. And this word, it originates from Greek as well. So myo meaning muscle, and cardia, it means heart. And when we add itis, it means inflammation. So when we combine the three, myocardia and itis, we have myocarditis, which is the inflammation of the muscular layer of the heart. So most of the medical words are from Greek origin. So here is an illustration. So this is the inner layer. The pericardium was here, but the myocardium is the middle layer of the heart, which is the muscular layer. So the inflammation is at this level. So it can lead to heart failure, as we said. It can lead to arrhythmias because the muscle is inflamed. So we can have scar tissue, and the scar tissue can be the origin of the arrhythmia, can lead to sudden death as well. So it's a serious condition, unlike pericarditis, which is not that severe. The causes, like pericarditis, the causes here most common are viruses. So post-viral, we saw a lot of myocarditis post-corona, especially in young patients. Also enteroviruses, adenoviruses, and pyrovirus B19. All of these are less common viruses. It can be due to autoimmune diseases. So we have production of antibodies, like we said in pericarditis. The antibodies which are autoimmune, they will go and attack the host tissues. So it will attack its own tissues. Symptoms, so chest pain as well. The chest pain also can mimic myocardial infarction, abnormal heart rhythms. The diagnosis is based on the clinical presentation, the history of a viral infection in the previous weeks or previous days, and here it's important, elevated cardiac biomarkers. So we need to have positive cardiac biomarkers to differentiate from pericarditis from myocarditis. And to confirm the diagnosis, if we want to confirm it, we can ask for a cardiac MRI. So here is a cardiac MRI. You can see here we have the myocardial. You have a signal on the MRI, and this signal, when you find it, it indicates an inflammation of the myocardial layer of the heart. So the treatment, here is the treatment. We should be supportive therapy. So we need to treat the symptoms. We need to, if the patient has heart failure, we need to treat heart failure. And in case of autoimmune myocarditis, we said we have production of autoimmune antibodies in the blood. In that case, we can give immunosuppressive therapy in order to decrease the amount of production of these antibodies. So supportive therapy, treatment of heart failure, treatment of arrhythmias, and if we have autoimmune condition, underlying autoimmune condition, we can give immunosuppressive medications in order to treat it. Okay. All is clear. Anyone has a question before moving to the next topic? Okay. Great. Great. So when we talk about, now we'll talk about cardiomegaly. So when we say We said cardio means the heart, and megaly it means enlargement. So the cavities are enlarged. So cardiomegaly is enlargement of heart cavities. So here is also an illustration. So here is the first one is a normal heart. You can see the cavities, the left ventricle, the right ventricle, left atrium, right atrium, they have normal size. But here, when we look on this illustration, you can see RV and RA, right ventricle, right atrium, have normal size. But the left side, the left ventricle and the left atrium, they are both enlarged. So this cardiomegaly here, it's affecting only the left side of the heart. The right side of the heart is intact. So either all the cavities are enlarged, or either the left or the right, or either just the ventricle or the atria. So we can have a lot of combinations, but when we find a cavity that is enlarged, for sure we have an underlying condition that we should treat. So we should find this underlying condition. And the diagnosis is based on medical history. So we ask the patient if he has symptoms of heart failure, if you have symptoms of arrhythmias. So physical examination, we look for signs of volume overload, because if we have a failure or enlargement of left ventricle, the fluid will accumulate in the lungs, in the lower extremities. So we need to check for lower limbs edema. We need to check for pulmonary edema. So we need to use the stethoscope to auscultate the patient. We can do an electrocardiogram, and to confirm the diagnosis, we need to do an echocardiogram. So the echocardiogram, I will show you a picture. The echocardiogram will give us clear measurement and it will tell us if the cavity is enlarged or not. So the causes, most common causes is chronic hypertension. So chronic hypertension, first of all, it will lead to hypertrophy of the heart. So the heart will become sicker. But if we keep it untreated, at an end stage, the heart will become dilated. So hypertension, coronary artery disease. So if you have a myocardial infarction left untreated as well, it can lead chronically to dilated heart. Anemia, hyperthyroidism, all of these conditions can lead to dilated cardiomyopathy. So as we said, we can have enlarged left or right, enlarged either ventricle alone or atria alone, or both of them can be enlarged. We can have hypertrophic cardiomyopathy. It means that the myocardium is thickened, but the cavity inside is not dilated, just the muscles that are thickened, as opposed to dilated cardiomyopathy, where the cavity is dilated, but the muscle is thin, it's not thick. So this is the differentiation between these two conditions. Okay, so now we're talking about dilated cardiomyopathy as well. It can be caused by viral myocarditis, so post-viral myocarditis, as we said, corona, enterovirus, HIV, Coxsackie virus. So all of these viruses can cause it. It can be due to ischemic heart disease. So if a coronary artery is blocked and untreated, it will lead to dilation of the heart. So a lot of other conditions, sarcoidosis, autoimmune diseases like lupus, rheumatosis, hemochromatosis, which is accumulation of iron inside the organs, mainly the heart, the liver. So the liver and the heart will become enlarged. We said hyperthyroidism or hypothyroidism can lead it. Drug-related, can be related to drugs, mainly chemotherapeutic agents like doxorubicin and the Herceptin, the doxorubicin, which can lead to irreversible damage, while the Herceptin, which we give for breast cancer, can also lead to heart dysfunction, but it's sometimes reversible. Can be also due to genetic causes, so genetic mutations can lead to this, and also in the postpartum, so after the delivery of a pregnant woman, sometimes she can develop dilated cardiomyopathy, but it's not very frequent. So the symptoms, like any symptom of heart failure, it can lead to volume overload, and when we have volume overload, the fluid will accumulate in the neck, it will accumulate in the lungs, so we have pulmonary edema, it will accumulate in the abdomen, so we'll have ascites. So the fluid will accumulate everywhere, and we can have arrhythmias, so there is a risk to develop irregular pulse. because of the scar tissue formation and the dilation due to the dilation of the heart. And also we said that we can have peripheral edema, so the fluid will accumulate in the lower limbs as well. So the fluid will accumulate in the lungs because the pump has failed, the left ventricle has failed, the myocardium has failed because it's dilated now, it can't pump blood. So the fluid will accumulate in the lungs, in the abdomen, so we'll have ascites, we'll have pulmonary edema, and it will accumulate also in the lower extremities, so we will have peripheral edema as well. So it's a condition of heart failure. Okay, so I have a question. How can silent ischemia heart failure happens? So sometimes we have silent ischemia mainly in patients with diabetes, because patients with diabetes, they tend to feel pain less than patients that are without diabetes. So for example, if a diabetes patient can develop myocardial infarction without knowing it, he can have very mild pain and he stays at home, he will have myocardial ischemia, which is silent. And this will lead on the long term or a few weeks or a few months later to dilated cardiomyopathy and heart failure. So silent ischemia is mainly in patients that have diabetes and autonomic dysfunction due to diabetes. They tend to feel the pain less because of the nerve damage related to diabetes. Yes, sometimes without diabetes, but it's not frequent because if a patient has myocardial infarction, they tend to have symptoms. It's rare to have a myocardial infarction without symptom or without chest pain. Mainly we see it in patients with diabetes, as I told you. Okay, so here is a chest X-ray that we do for the patient. So we said we can do echocardiogram and chest X-ray. So the chest X-ray, can someone tell me here what do we see exactly on this chest X-ray? Anyone wants to interpret it? If someone has an idea, you can write in the chat. Okay, so we said here it's the right lung. Here it's the left lung. Okay. Yes, Muhammad said it's cardiomegaly, exactly. So we have here cardiomegaly. Why? If we measure the diameter of the heart from here to here, so it's, and you measure the diameter of the heart from here, from the chest cavity, sorry, from here to here, you can see that the diameter of the heart is more than the half of the thoracic diameter. So it's cardiomegaly, yes, as you said, two correct answers, so good answers. So we have cardiomegaly here, which is associated with dilated cardiomyopathy. It's the condition itself. So here is the echo. So we have here the left atrium, as I told you before. We have here the aorta. Here we have the right ventricle, and you can see this dilated cavity from here to here. This is the left ventricle. It's very dilated. You can see the left ventricle is bigger than all the other cavities combined. So this is a case of advanced dilated cardiomyopathy. So here the patient for sure is symptomatic. So here is the left ventricle, which is very dilated. So the treatment, as I told you, we need to act on heart failure. We need to act on lifestyle, so diet, low in salt, low in fluid, because these patients have excessive fluid. So we need to have a diet low in salt to avoid fluid accumulation, smoking cessation, weight loss, all of these things, exercise for sure. And we need to give treatment for the heart failure. So all of these treatment act to treat heart failure. So diuretics to treat the symptoms. Diuretics does not lead to improvement of mortality, it just improves symptoms. While beta blocker, ACE inhibitors, ARBs, mineralocorticoid receptor antagonists like spironolactone, for example, all of these treatments are approved for heart failure, and they tend to decrease mortality and improve survival on the long term. So we need to use these medications for such patients. And if the patient does not improve on pharmacologic therapy, we need to place an implantable cardioverter defibrillator, because these patients are at risk of developing arrhythmias. So these patients should have a defibrillator in order to treat the arrhythmia if it occurs. So the device will put it under the skin, on the left side or right side of the chest, and once arrhythmia occurs, the device will sense it, and the device will administer an electric shock in order to reverse the arrhythmia. So it's very important to follow all these rules. Now we'll talk a bit about hypertrophic cardiomyopathy. So as opposed to dilated cardiomyopathy, you can see here the cavity is not enlarged. The cavity is containing the blood, while the muscle itself is very enlarged. You can see here the septum is very enlarged. The muscles here are very enlarged. So it's an enlargement of the myocardium here. So a lot of athletes will have this heart because athletes tend to have hypertrophic heart, but it's not pathological because they are like any other muscle in the body. When you train it, the muscle will become bigger. So it's the same thing happen in athletes. They will have bigger hearts, but it's not pathological. While if the cause is hypertension, so here it's pathological, but we can have also thickening of the heart muscles, which if we keep it like this, it tends to dilate at the end. So we'll have dilation of the heart, not just hypertrophy. In the beginning, we'll have hypertrophy, but if we keep it like this, it can lead to dilated cardiomyopathy, aortic stenosis as well, and we have a lot of other causes. And, we have increased the prevalence of amyloidosis these days. So amyloidosis is also a disease where we have accumulation of abnormal proteins, which will lead to hypertrophic hearts, and it will lead to heart failure as well. So we have a lot of conditions, sarcoidosis as well. So when we detect it, so when we do the echo, we check, we find the hypertrophic cardiomyopathy. If the patient developed sudden cardiac death, so if he had an arrhythmia episode and he had asystole, and we did all the protocol and he came back to life, so in that case we need to put a defibrillator, because here we suspect the cause of his death or his sudden cardiac arrest is the arrhythmia. So here we need to put a defibrillator in order to prevent the occurrence of such episodes. And if the patient has symptoms of heart failure, we can do a surgery. So we can do a myectomy. We can remove part of the muscles, so we can decrease this hypertrophy. And if the patient has symptoms of heart failure, for sure we can put him on treatment of heart failure. And if the patient develops atrial fibrillation, so atrial fibrillation is an arrhythmia originating from the upper cavities of the heart. So when we have it, we need to treat it as well. So ICD, if the patient develops sudden cardiac arrest, surgical myectomy also can be proposed. If the patient has excessive thickening of the myocardium, we can propose a surgery for him, can give drugs to treat heart failure. And if we have arrhythmias, we need to treat the arrhythmias, give medications, appropriate medications. So now we talked about pericarditis, myocarditis, hypertrophic cardiomyopathy, and dilated cardiomyopathy. Now we will talk about the fifth condition, which is the coronary spasm. So when we say spasm, it means involuntary contraction of a muscle, of a vessel, of any muscle. And when we say coronary spasm, it's an involuntary contraction of a coronary artery. So here we're talking about coronary arteries. You can see here we have the aorta. Here is the aorta. And from the aorta, we have the left coronary artery. So here is the left coronary artery. And here we have the right coronary artery. If you look closely to this, to the second image, so you can see there is a narrowing in the right coronary artery. And this narrowing was due to, it wasn't due to a clot or atherosclerosis, it was just due to the spasm. If you look here, the artery becomes spastic and no more blood flow were able to pass this zone of spasm. And here is a real image. So here is an image of we inject iodine contrast in the vessel using a catheter. So this is a coronary angiography. this is a normal vessel. We don't have a spasm here, but suddenly the same patient develop. Sorry, it's not the same patient. I'm showing you a picture of the second patient. If you look closely here, there is a significant spasm, and no more blood were able to pass after this spasm. You can see here this area is not filled with blood, while it should have been filled with blood. So there is drop in the circulation due to the severe spasm. And spasm is related to age, to smoking, to, for example, if the patient is exposed to cold, if the patient is exposed to physical or mental stress, he can have coronary spasm or any cause of stress. So there's a lot of condition, but mainly it's cold, and physical stress and mental stress will induce this condition. So the pain will be like a myocardial infarction, like any other cause of ischemia. It will be pain, mainly pain at rest, and the patients mainly will have pain at night and in the early morning hours. So it's typical. Sometimes the patient comes to us with this presentation. We need to think of coronary vasospasm. And to confirm the diagnosis, we need to do a coronary angiography in order to see the spasm. So when we confirm the diagnosis by imaging or coronary angiography, then we need to add medications like calcium channel blockers and nitrates. So calcium channel blockers and nitrates, they tend to decrease the spasm and prevent the occurrence of the spasm. So these drugs will cause vasodilation and dilation of the coronary arteries. So the two drugs we use in practice to treat coronary vasospasm are calcium channel blockers and nitrates medications. So we need to prescribe these medications to our patient and increase the dose to the maximum tolerated dose for our patients. We have now, we'll talk now about when we see word brady, so it means slow. And when we have bradycardia, it means that the heart is slow. And it means that the heart rate is less than 50 beats per minute. So the normal heart rate is between 50 to 100 beats per minute. When the heart rate drops to less than 50, in that case, we said we have bradycardia. And when the heart rates become above 100 beats per minute, so in that case, we say tachycardia, so it's in a faster heart rate. Anyone wants to comment on this heart racing? Any idea? Just to see if you have an idea about it, and then I will explain it. If someone wants to comment, please feel free to write it in the chat. What do you see here? So what is this? So here we have a long pause. So here there's no electrical activity. It's a significant pause. And here we have episodes of tachycardia. So we have pauses and we have bradycardia and we have tachycardia. We have bradycardia here and we have tachycardia here. So this condition is called tachybrady syndrome. So we have both together. So some patients can have it together. So brady and tachy at the same time. And here the treatment is to put a pacemaker to treat these episodes. So we need to put a pacemaker. So when the pacemaker sends this pulse, the pacemaker will generate an electrical activity. And to treat the tachycardia, we can treat it by medications we can give, for example, beta blockers. So here, for this patient that has tachybrady syndrome, we need to put a pacemaker and we need to give beta blockers. So pacemaker to treat the bradycardia and beta blockers to treat the tachycardia. Okay. So now we finished with cardiovascular disease terminology and diseases. So we talked about a lot of conditions. Now we will talk a bit also about respiratory terminology and disease. So we still have respiratory and urologic and nephrologic. So urologic and nephrology, we will combine them together. So the respiratory, so you hear a lot of words. So we have the nasal cavity. This is the upper respiratory tract. We have the nasopharynx, the oropharynx, and the hypopharynx. So these are the divisions of the pharynx. Then we have the larynx and the trachea. So this is the respiratory system before reaching the lungs. So when we see a word rhine or rhino, it means the nose. So like rhinitis, which is inflammation of the nose. Rhinodynia, it's a pain of the nose. So we have the patient will complain of pain. Rhinorrhagia, when we have excessive blood being secreted by the nose. So we have epistaxis. When we have rhinorrhea, which is excessive mucus secretion. So we see it in cases of viral infections. And we have the rhinovirus, which is the viral responsible for most upper airway tract infection. So we call it rhinovirus. And we have also rhinoplasty, which is the surgical correction of the nose. So these are the most commonly used word when we refer to the nose. And here is the rhinitis. So allergic rhinitis is very common. A lot of patients have it. So they tend to have sneezing, stuffy nose, or runny nose without fever. They have these symptoms when exposed to the allergen. So they will have a lot of mucus, a lot of postnasal drip. So mucus a lot without fever. They can feel headaches. They can feel sometimes dark spots or red eyes or dark spots below the eyes. So all of these are associated with allergic rhinitis. It's very common. A lot of us have it. It's an inflammation of the nose. The most common causes of are exposure to allergies like pollen. Pollen is found in plants and trees. Dust. So pollen and dust are the most common causes in our countries. Animal hair, also mold spores as well, but dust and pollen are the most frequent causes, and they are seasonal. So it depends on which months we are in a year. But you should know pollen and dust. These are the most common. The symptoms can be intermittent, so the patient can have just less than 4 days a week of symptoms. So running the nose 2 days per week, for example, the symptoms can persist and become more than 4 days per week or for over 4 consecutive weeks as well. We can classify them as mild symptoms or moderate to severe symptoms. So mild symptoms, the symptoms will not affect the sleep, while in moderate or severe symptoms, these patients tend to have obstruction of their nose due to accumulation of mucus. They will tend to have apnea at night. They won't be able to sleep well. They will have problems at work, at school, the second day because of the apnea or the lack of sleep they had. So fatigue and all the associated symptoms when the symptoms are severe or when they persist. So how to treat it? So we need to avoid the allergies. If this doesn't help, we need to give oral antihistamines and intranasal corticosteroids. Intranasal corticosteroids are the cornerstone of treatment. So this is the most important therapy to treat allergic rhinitis. So intranasal corticosteroids, we ask the patient to have 2 puffs in each nose before sleep or in the morning. And we monitor the patient. Sometimes we double the dose morning, night, sometimes just give it once a day. So it depends. We can combine oral antihistamine with intranasal corticosteroids. If it doesn't respond, we can give leukotriene receptor antagonist, and we can give immunotherapy in severe cases. But usually, the condition will respond to intranasal corticosteroids. And you can find all of the data about allergic rhinitis in this interesting paper, which was published in 2018. It's a summary of allergic rhinitis if someone is interested. Now, this is the picture of the rhinovirus. So we said this is the most common virus that can cause upper respiratory tract infection. This is the image of the virus under electron microscopy. So this is how the virus looks like. Exactly. So you can see it. So the infection will cause sneezing, sore throat, restlessness, coughing, and fever. It looks like COVID or coronavirus, but it's milder. We won't have a lot of body aches. The fever will be less, and the symptoms will disappear faster. So within a few days. Now we move to the pharynx, which is after the nose. So when we hear pharynx, or we need to think of the pharynx. So pharyngeal is the pharynx area. Pharyngitis is when we have inflammation or infection of the pharynx. So itis means inflammation, like all other pathologies we saw. Pharyngoplegia is the paralysis of the pharynx, and oropharynx we refer to the part of the pharynx that is close to the mouth. So when we talk about pharyngitis, so you can see here the tonsils, the pharynx should not be inflamed, but if we look on this picture, you can see these white patches on the pharynx. So here we need to suspect bacterial infection or bacterial pharyngitis. So when we see this, we need to suspect infection. And it's a common pathology, with 200 per 1,000 people develop acute pharyngitis, and we have a lot of emergency department visits due to acute pharyngitis. The etiologies, we can have viral causes or bacterial causes. So the viral causes, as we said, rhinovirus, coronavirus, adenovirus, these are the most common, while the bacteria, the most common one is group A, beta hemolytic streptococcus. So streptococcus, followed by group C, beta hemolytic strep, and the less common ones are Neisseria, gonorrhea, and other chlamydia or mycoplasma. These are less common, less than 1%. The most common one is streptococcus, and in the virus, the most common one is rhinovirus. So just know streptococcus for bacterial pharyngitis, and rhinovirus for or adenovirus for viral pharyngitis. Coronavirus as well. So here are the symptoms. So we have patient will have pain, throat pain, redness, swelling around the tonsils. White patches are very characteristics. He can have enlarged lymph nodes in the neck. Both viral and bacterial can have these symptoms. So they will have difficulty swallowing, so they won't be able to swallow food as expected. A lot of patients ask us if they need to take antibiotics to treat pharyngitis, yes or no. So we have a score. This score will help us to know if we should give antibiotics or if we should not give antibiotics. So you have the 5 symptoms here. Each symptoms will give a score of 1 point, okay? So if the patient has fever, he will take 1 point. If the patient has pus on the tonsils, he will take 1 point, so white patches on the tonsils. If the symptoms are persisting, so the patient symptoms are getting worse or persisting, 1 point. If the tonsils are severely inflamed, so enlarged tonsils, the patient is not being able to swallow food or to drink water, so here are severely enlarged tonsils, and no cough or coryzal symptoms, so these normally are present in viral. So we give it 1 if we don't have it, because when we don't have, we have the risk of bacterial infection. So when the score is 0 to 1, if we add the symptoms we have, and we have 0 to 1, so here we should not give antibiotics, because here the most common cause is viral. But when the score is 2 to 3, so here it's possible to have antibiotics. Usually we ask the patient to wait 48 hours. If the symptoms do not improve, we start him on antibiotics. And when we have score of 4 to 5, so here is immediate antibiotic prescription, and we should rule out abscess formation in the area, because abscess can cause neck pain and can obstruct the airways. So we need to always look at this score and see how much we have. If the score is very low, so bacterial pharyngitis is less common, so no need to give antibiotics. If the score is higher than 3, for example, in that case, we should focus on giving antibiotics, because we need to treat streptococcus in that case, because we said it's the most common pathogen causing bacterial pharyngitis. Okay, so it's very important to follow this score in order to avoid the prescription of inappropriate antibiotics, which will lead to resistance. Now moving to the larynx, which is the next structure. So when we say laryngo, it means the pharynx. Laryngeal also in relation to the larynx. Laryngitis, same, itis, so we have inflammation of the larynx. Laryngospasm, we have a spasm or contraction of the larynx, so we have pain, it will cause pain in the area. Stenosis as well, laryngostenosis, we have narrowing of the larynx. Laryngoplegia, which is the paralysis of the pharynx, and laryngectomy, which is the surgical excision. Okay, so now we move to the bronchi, which is related to the bronchial passages. So the bronchus, which will transmit the oxygen from the upper airway to the lungs. Bronchus is a singular word, and bronchi is a plural word of the structures. Bronchitis also, so itis, inflammation of the bronchi, and bronchiectasis, which is the destruction and dilation of the bronchi. So now I will show you a few slides about bronchiectasis. So bronchiectasis is a serious condition which will affect the bronchi. So here you see a normal bronchus. So we have the cilia, which will allow for propagation of mucus. We have normal mucus. While in bronchiectasis, you can see that the bronchus is enlarged, is a bit destroyed. We have damaged cilia here. We have excessive mucus. So enlarged and damaged cilia and with excess mucus. This is a characteristic of bronchiectasis. Okay, so here is another cut. So you can see the wall of the bronchus is destructed. We have increased secretion as compared to the normal bronchus, and we have loss of microtubules or loss of cilia. So we have less mucus clearance because we don't have cilia. Cilia will allow for mucus clearance, but here we don't have, so the mucus will accumulate inside. So the causes, most commonly, the cystic fibrosis, which is a condition, severe condition, accumulation of mucus inside the bronchus. We can have mycobacterium, so infections, Staph aureus, Aspergillus, and influenza virus. We can have also tumor obstructing the airway, or foreign body obstructing the airway. So mucus will accumulate inside to cause dilation of the bronchus and destruction of the cilia. So the mucus won't be able to be excreted out. So all of these are related to bronchiectasis. So the treatment, we need to act to allow for the mucus excretion. So sometimes we need to give hypertonic saline. So either we give it inhaled in order to help the clearance of the mucus, and because these patients are at risk to develop infections, so we need to put them sometimes on chronic antibiotherapy because they tend to develop chronic infections in the lungs. So we put them on long-term macrolide antibiotics. So hypertonic saline associated with macrolide is helpful in this condition. Okay, because as I told you, they tend to have recurrent infections. Okay. So I have a question. Can vaping possibly cause this? So we have a few case reports, yes. We have a case series. It was published, I think, in a journal of pediatric pulmonology. So yes, it's associated because we have progressive inflammation and widening and scarring of the bronchi. So it was seen, it was published in the literature. So yes, it's possible to be related to vaping, as you said. Okay. So now we move to when we see pneumo, it means here we're down in the system, we're in the lower respiratory tract, so in the lungs, we have gas exchange, respiration. So when you say pneumonitis, it's inflammation of the lung parenchyma. So pneumonitis does not always mean we have a virus or we have a bacteria. Sometimes the GI tract secretions, so when you have reflux disease, the patient can aspirate the secretions from the stomach. They will go down to the lungs. We call this pneumonitis. So we call it here chemical pneumonitis or gastric pneumonitis because the gastric secretions go to the lungs. While pneumonia is usually due to bacterial or viral or fungal infections affecting the lung parenchyma. When we talk about lobectomy, so it's removal of a part of a lung. So we do this when we have a cancer. We remove the lobe affected by the cancer. And when we say pneumococcus, it's the Streptococcus pneumonia, which is the most common cause of bacterial pneumonia. So it's a gram-positive bacteria. So it's called pneumococcus or Streptococcus pneumonia. So pneumonia, as you can see here, we have the alveoli, which will become filled with fluid, with inflammation, inflammatory cells. So they will fill the alveoli. So here, when the alveoli is filled with these inflammatory molecules, no more gas exchange. We won't have gas exchange. So we can have hypoxia due to inability to send oxygen to the tissues due to the fluid accumulation inside the alveoli. So this is what happens in pneumonia. So symptoms: high fever, cough, fatigue. So like any other infection, loss of appetite, chest pain. So it can mimic any other infection. There is no specific symptoms, but the most specific symptoms is fever with cough. So cough tend to be green or bloody mucus because it's originating from the lower respiratory tract. So usually, sometimes we can see blood with it. Okay, so we will divide the pneumonia to bacterial, viral, and fungal. So in the bacterial, it's the most common type. So pneumonia is most commonly bacterial, not viral. So most commonly bacterial. It can happen in patients that already had a previous viral infection because these patients tend to be more immunosuppressed. So they tend to have more viral infection, more pneumonia. Mainly, they are predisposed to acquire bacterial infection after viral infections. And the most common one we said is Streptococcus. So Streptococcus, we should always think about it. Other causes are Legionella. So Legionella can cause hyponatremia in the blood. So when we see bacterial pneumonia with hyponatremia, so here we need to suspect Legionella infection. So pneumonia with hyponatremia, it's due to Legionella, okay? And we have other types like Mycoplasma, Chlamydia, and Haemophilus influenza. We can also have cases of viral pneumonia. So to differentiate between bacterial and viral, usually bacterial is cause lobar pneumonia. So we have the infection just in one lobe, especially with the Streptococcus pneumonia, which is a typical bacteria. While in viral pneumonia, usually the infection is widespread. So like the case of corona or other virus illness, you can see the infection is spread in the lung. It's not just in a focal area. So this is the main difference. Because they tend to produce the same symptoms, but the difference is the widespread. So usually it's bilateral pneumonia in viral, and in bacterial it's usually just in one lung and in one lobe. This is the most common presentation. And respiratory syncytial virus, SARS-CoV-2, so COVID-19 can cause it. And you can see also fungal. Fungal is less frequent, and you see it in patients with chronic health issues. So patients with weak immune system, they tend to develop fungal infections because the immunity is weak. Most commonly, you have the pneumocystis pneumonia and coccidiomycosis and histoplasmosis and cryptococcus. So we can see it in immunosuppressed. When we see when we see these pathogens, we always need to check the immune system because it's very rare for a patient with a competent immune system to develop such fungal infection. We have a score for pneumonia. So when the patient is presented to the ER, the emergency department, and we diagnose pneumonia, there is a score, we call it curve 65 score. So for each one, the patient will take 1 point, 1, 1, 1, 1. So the C is confusion. If the patient is confused, 1 point. If the patient has a urea above 7, so 1 point. If the respiratory rate is above 30, so also 1 point. If the patient is hypotensive, also 1 point. And if the patient age is above 65, also 1 point. So if the score is low, 0 to 1, there is low risk. Here, we can send the patient home. There is no need to admit the patient to the hospital. We can send him home. While when we have a score of 2, here the probability of mortality in 30 days is 9.2% due to pneumonia complications. So in that case, we prefer to admit the patient to the hospital. No need for intensive care. You can just admit him to the regular room. But when the score is between 3 to 5, so here the patient is confused, or maybe he's hypotensive, he's tachypneic. So here we need to admit the patient to the intensive care unit because the mortality rate at 30 days is 22% for a score between 3 to 5. So this score is very important. It helps us decide who to admit to the hospital and who to discharge home. So if the score is 0, we said we can send the patient home on amoxicillin, while if the score is 1 to 2, we can admit if the score is 2, we can admit the patient to the hospital. We can give him a ceftriaxone, for example, IV, or we can give benzylpenicillin, also IV. If the patient has a high score or severe pneumonia, here we need to admit him to the intensive care unit, and we usually prefer to give ceftriaxone 1 or 2 grams IV per day intravenously. Sometimes we associate gentamicin or azithromycin as well with it. So we have a lot of guidelines. Mainly we need to follow this in order to prevent the misuse of antibiotics. So we still have a few slides about pleura. So pleura, when you see pleura, it's associated with pleural membranes of the lungs. So the pleural is the cover of the lungs. And when we have pleural effusion, so we have fluid around the lungs. So here we saw this picture before, but you can see here the lungs, the right here and the left here. You can see here the angle. We can see it clearly. So there is no pleural effusion here, but here the angle has disappeared. So we have accumulation of fluid. So here is a right-sided pleural effusion. So it's a moderate in intensity pleural effusion on the right side. So chest X-ray is used for the diagnosis of pleural effusion. So we still have just a few slides. Here is about pulmonary. So when you see pulmono, it refers to the lungs. I just want to show you a slide about pulmonary embolism. So pulmonary embolism is due to migration of a blood clot. Usually it originates from the lower limbs and it migrates to the lungs via the venous system. And it will obstruct the pulmonary artery, which will lead to impaired gas exchange, which will lead to dyspnea, will lead to chest pain. So we need to suspect it in the post-operative period, or if a patient, for example, had a long flight for 8 hours or more, immobilization post-surgery. So it's a risk factor to develop pulmonary embolism. And here is a CT scan. We also saw an example in my first lecture today. So you can see blood clots here, blood clot here. This is the pulmonary artery. It's occluded by a blood clot. So this is a case of pulmonary embolism. Okay. So that was the presentation about cardio and respiratory. Any other questions? We have 3 minutes before moving to the next lecture. If you have any questions, please write them in the chat box. Thank you. Okay, thank you. We still have one presentation, the last one. I will start it in 2 minutes. Okay, so can you see the slides? This is the last presentation. Can you hear me and can you see the slides, please? Okay. The slides are clear. Okay, perfect. So the last topic of today, which will be about medical terms and diseases in the urology and nephrology system. So when we hear the word cyst, we hear it a lot in the urologic disorders. It means it refers to the bladder or to a sac. When we hear the word of noct, so it means it occurs at night. Oligo, which means it's few or little. So oliguria, for example, decrease in the urine output. Poly or polyuria, for example, in the urologic system, it means increase in urine output, for example. PL, which means the pelvic area or the kidney area, and renal, which means the kidneys. Okay, so we'll develop these conditions in this lecture. So we'll start by talking about anuria. So when we see the AN, it means without. So and urea, it refers to urine. And when you combine these together, so it's anuria, which is the absence of urine. So what can be the cause of anuria? So we can have a lot of problems. So we can have problems at the level of the kidneys, like pyelonephritis with papillary necrosis. So we have necrosis of the kidneys that is responsible for the filtration of urine. We can have also the polycystic kidney. We can have aneurysm or dissection of the renal vessels. So all of these will cause renal failure and inability of the kidney to pump urine. So we'll have anuria. Other causes are related to conditions post-kidney. So we might have an obstruction in the ducts that are responsible for transmitting the urine. So we can have surgical ligation of the ureters, so due to a surgery, or due to a cancer that is compressing both ureters. So the ureter is here, can have a tumor here compressing these structures. Can have an enlarged prostate, also compressing the urethra. So urethral stricture as well. So we can have a lot of conditions that can lead to absence of urinary flow. So anuria. Okay. So this condition, we said it's absence of urine production. If untreated, it can lead to a life-threatening emergency because here we're talking about acute renal failure. So no more urine output. Okay, sorry. Okay, so the kidneys will stop producing urine due to a blockage or due to a problem inside the kidney. And the treatment here is to need to manage the body fluids carefully. So sometimes if the patient is dehydrated, we can increase the hydration for these patients. If we have an obstruction, if we have a tumor, if we have a renal stone obstructing the passage of urine, we should remove it. And if all of these does not tend to improve the condition, we can treat the patient by dialysis in order to eliminate the toxins that are accumulating in the blood, are not being able to be filtered by the urine. So when we have urine output of less than 1 milliliter per day, we say we have anuria. So it's a very critical condition that can lead to acute kidney failure. And the diagnosis is it's very simple. You need to measure the urinary output via a Foley catheter, urinary catheter. You need to order lab tests. You need to order the creatinine level because these patients will tend to have acute elevation in their creatinine level because of the acute renal condition. Urine analysis and abdominal ultrasound and abdominal CT scan are very important if we're suspecting a tumor causing this decrease in urinary output. So we classify the acute renal failure in 3 stages. So we have stage 1, stage 2, and stage 3. So stage 1 is when we have less than 0.5 milliliter per kilo per hour. So if for example, the patient have 80 kilograms, so the urine output per hour should be 40 milliliter. If the urine output is less than 40 milliliter per hour for at least 6 to 12 hours, so here we have stage 1 acute renal failure. But when it stays prolonged for more than 12 hours, here we're talking about stage 2 renal failure. And when it's for 24 hours, or when we have a complete loss of urine for more than 12 hours, here we are stage 3 acute renal failure. So here we're in a very critical condition. So urine output is very essential in order to classify acute renal failure. Even without looking at the creatinine level, you can just look on the urine output. So the symptoms, not very specific. So loss of appetite, symptoms of acute renal failure, loss of appetite, shortness of breath. If the fluid can accumulate in the lungs, it can lead to chest pain or pressure, can lead to decreased urine output, and sometimes also the fluid will accumulate in the lower limbs because we're not able to excrete the excessive fluid outside in the urine, so we can have peripheral edema in that case. So we talked about anuria and acute renal failure. Now we will talk about dysuria. So as we said in the beginning, when we have dyes, it's bad or painful, and uria refer to the urine. So when we combine dysuria, it's painful urination. So when the patient urinates, he will feel pain upon urination, just upon urination. So we call it dysuria. So dysuria is a sensation of painful or uncomfortable urination. So burning, tingling, or stinging sensation upon urination. It's very uncomfortable for the patient. The bladder contraction can worsen the pain, so the patient will try to do maneuvers in order to increase his bladder contraction in order to increase the urine output, but this will cause increase in burning sensation because the urethra will be more irritated, so more pain. So here, when we see dysuria, what is the differential diagnosis? So most common cause is infectious. So the patient has a urinary tract infection, either cystitis, urethritis, pyelonephritis, so at any level. Sometimes we can have kidney stone obstructing the airway, obstructing the urinary tract. So this will favor the development of urinary stasis and urinary infection. So these are the two most common causes. So urinary infection and kidney stone. So we need to suspect these two conditions when we see a patient presenting with dysuria. And the most common germ when we do urine analysis and urine culture in order to isolate the bacteria, the most common one is the most common germs are gram-negative. So in 84% of cases, the bacteria is a gram-negative type of bacteria. And the vast majority of cases of 75% of all these gram-negatives is Escherichia coli. So E. coli is the most common cause of urinary tract infection that we see. We can also find Klebsiella, Proteus, Pseudomonas, but these are less common. We can also have gram-positive bacteria in less than 15% of cases. So we can have Staphylococcus, Enterococcus, Streptococcus, and Staphylococcus aureus. We can have also fungal or non-bacterial like Candida or mycobacteria or viral UTIs, but these are very, very rare. So you just need to know that the most common one is Escherichia coli, which is 75% of the cases. And the most commonly bacteria we see are gram-negative bacteria. So UTIs, the urinary tract infection, it can affect the urinary system at different levels. So it either affects the kidneys. When it affects the kidneys, we call it pyelonephritis, so infection of the kidneys. So it's high in the system. So here we have symptoms, we have flank pain, we have high fever, but most commonly the symptom will be flank pain with high fever. So here we need to suspect it. We need to do a urine analysis. We need to do a non-injected CT scan or Euroscan of the abdomen. And when we confirm the diagnosis, we can start the empiric antibiotics until we have the culture results. So we start with IV ceftriaxone, which is a broad spectrum. It covers all gram-negative bacteria that we saw here. So it covers all of these bacteria, the ceftriaxone. So we start by giving it. Sometimes the patient has a lower urinary tract infection, so we call it cystitis. So here the kidneys are not infected, it's just the bladder and below the bladder that's the infection here. So here we can have dysuria, so we have burning and urination, but here we don't have fever and we don't have flank pain. So fever and flank pain are found just in pyelonephritis. We don't have fever when we have cystitis or lower urinary tract infection. So fever with flank pain, always pyelonephritis. Dysuria without fever or low-grade fever, it's cystitis until proven otherwise. So here the treatment is different. We don't give IV treatment. We can give a tablet or per os medication. So we give here another drug, which is nitrofurantoin. So here the treatment is different: nitrofurantoin, Bactrim, or fosfomycin. So we have three choices. We give one of these conditions depending on the resistance on the country. So flank pain, high fever with dysuria, it's pyelonephritis, IV ceftriaxone. Until we have the culture result, we can change the antibiotics and target the specific bacteria we have. If we have signs of UTI like dysuria and positive urine analysis without fever or low-grade fever, here we have cystitis, and we can start nitrofurantoin or Bactrim or fosfomycin as antibiotics. It's very important to know that if we do a urine analysis and we find a UTI, but the patient is asymptomatic, here we should not start antibiotics because we're treating the symptoms. The urine analysis could be a contamination. So we always need to treat the symptoms, not the urine analysis or urine culture. So there is no need to put an antibiotic for a patient just because he has a positive urine culture without symptoms. There is no, it's harmful for the patient because we're increasing the resistance in that patient. Another condition which we see in young or babies, it's called enuresis. So this condition is involuntary urination in children. These children tend to urinate, especially at bedtime, involuntary. So he urinates, and a few percentage in the daytime. So here it's a frequent condition in the pediatric population, and the treatment is behavioral. We need to motivate him to urinate in the toilet to avoid this condition. And if this doesn't work, we can give him therapy like giving anticholinergic treatment or desmopressin. So these are treatment, but generally we don't need to give. We just can act on the behavioral therapy of this condition. So urinary frequency, we move now to urinary frequency. So it's the need to urinate more frequently than usual, and it's accompanied by a sense of urgency. So there's no pain or burning, but the patient tells us that he tend to feel the need to urinate more frequently than usual. It can be due to excessive fluid intake, so the patient drinks a lot. It's also a sign of urinary tract infection. So the sign urinary frequency is also considered a symptom or sign of a urinary tract infection. So here are the causes. So diabetes, a lot of diabetic patients tend to, they urinate a lot. This is due to the hyperglycemia, which will attract fluid to go outside the body. Urinary tract or bladder conditions. So sometimes we have pathologies affecting the bladder, especially in older females. It can have hyperactive bladder, enlarged prostate in males. So they tend to have frequent urination, especially at nighttime. So a lot of patients that have enlarged prostate, they go multiple times at night to the toilet. a pregnant patient as well, because they have excessive volume. Medications, a lot of medications can lead to frequent urination. So how do we treat frequent urination? So we need to address the underlying condition. If the patient is diabetic, we need to treat diabetes. If the patient has urinary tract infection, we need to give antibiotics to treat the infection. If the patient is drinking a lot, we need to avoid excessive fluid consumption or bladder irritants like caffeine and alcohol. Caffeine and alcohol, they tend to cause bladder irritation, which will lead to excessive and more frequent urination. So we have, if the behavioral changes does not work, we need to give medication. So we can give anticholinergics, but the agonist. But we rarely reach this stage. Usually, treating the underlying condition will tend to ameliorate the symptoms. Moving now to glomerulonephritis. Sorry. Moving now to glomerulonephritis. So when we say glomerulo, it's associated with the glomeruli of the kidney. So the glomeruli are the parts of the kidney that is responsible for the filtration of the urine. And nephritis is the inflammation. So when we combine both glomerulonephritis, it's the inflammation of the glomeruli of the kidneys. Okay, so here, this slide, you can see we have the kidney. This kidney is cut in half. You can see the glomeruli here. This is the microscopic view. Here, these glomeruli are inflamed, and you can see that when we have a healthy urine, the urine color is normal. But in case of inflamed glomeruli, we tend to produce pink or red. Sometimes we have blood, and foamy or bubbly. So when we see foamy or bubbly urine, we need to suspect an inflammation that is going on at any level of the kidney and the ureters, or infection. But specifically in glomerulonephritis, usually we have pink or red urine with foamy or bubbly. It indicates the inflammation that is occurring at the level of the kidneys. Okay, so we said the glomerulonephritis is the inflammation of the glomeruli. Here is a summary. So it starts in the glomeruli. This is the primary glomerulonephritis, but we have other conditions where the problem starts elsewhere, but it's a secondary glomerulonephritis, so it's a consequence of another problem going on outside of the body. I will show you the examples on the next slide. So either primary, the problem is inside this glomeruli, or secondary, so these glomeruli are affected by a systemic disease occurring elsewhere in the body. And we can have acute or chronic. So acute glomerulonephritis, when the symptom develops suddenly, or the symptom resolves suddenly. So it's very rapid development or resolution of symptoms. Or we can have a chronic conditions, especially if the systemic disease, for example, is not treated. So it develops slowly, and when it develops like this and becomes chronic, it becomes irreversible. So acute, it's reversible, while chronic, it's usually an irreversible condition. Okay, so here are all the classification of glomerulonephritis. So we either, usually it's due to autoimmune conditions. So we have antibodies. We can have the ANCA, so anti-neutrophil citrullinated antibody, which is present in 80% of cases. We can have the IgA. We can have a lot of types of basement membrane antibodies. So it's usually antibody that is attacking this glomeruli, leading to a loss of function in this glomeruli. It can also be due to infection, mainly the hepatitis virus. So here we're talking about systemic diseases affecting the glomeruli also. So hepatitis C, hepatitis B virus, and HIV virus. Also, it can be due to endocarditis, osteomyelitis, staph aureus, prostatic device, or infection. So all of these are systemic conditions affecting other body parts. But there's a correlation between these pathogens, for example, and the development of kidney glomerulonephritis as well. It's not the focus of our lecture, but we just need to know that there's antibodies, there's viruses, there's bacteria implicated. So it's a very complex system. Symptoms, not very specific, but patients can have hematuria, so blood in urine, because due to the inflammation occurring in the glomeruli, they tend to have destruction of these glomeruli or the surrounding blood vessels. So we tend to have hematuria. Proteinuria as well, because we're not being able to retain these proteins because of the destruction of the glomeruli, so the protein will be lost in the urine. And because we're losing proteins, so we lose oncotic pressure inside our vessels. So when we lose oncotic pressure in the vessels, the fluid tend to go outside the vessels because the hydrostatic pressure will be unopposed. So in that case, we'll have peripheral edema. So mainly edema occurring in the abdomen and in the lower limbs. Hypertension as well, because it's associated with this condition. Decreased urine output for sure, because we have damage in the kidneys. And fatigue and weakness, it's a non-specific sign. We can find it in all other inflammatory conditions. Foamy urine, we said, we see a foamy urine, so bubbly urine or foamy urine, because of the inflammation that is occurring inside the kidneys. Dark colored urine, sometimes with blood. Fever, fluid retention, as we said, because of the loss of proteins, we can have fluid retention, and elevated levels of creatinine and urea in the blood. So for sure, the creatinine, when we have acute renal injury due to the glomerulonephritis, the creatinine level tends to go up. Okay, so how to treat this condition? So we need to give medications that are kidney protective, okay? Sometimes you can give ACE inhibitor, which is angiotensin converting enzymes. These are nephroprotective medications. Sorry. We can also give angiotensin receptor blockers. So these are also nephroprotective medications. They tend to reduce the inflammation. They tend to better control the blood pressure, and they decrease the proteinuria that is associated with this condition. Sometimes we can use corticosteroids or immunosuppressants when the disease is more severe. We can't just give nephroprotective medications and wait. We need to give corticosteroids and immunosuppressive medications when the disease is uncontrolled. When the disease is due to an infection, as we said it can be due to streptococcal infection. We call it post-streptococcal glomerulonephritis. So in that case, it can follow a pharyngitis in the upper airways, or it can follow a skin infection, streptococcal infection. So the patient can develop after this infection glomerulonephritis in the kidney related to the infection. So in that case, we treat the infection by antibiotics, we treat the underlying infection. Dietary changes as well, because we said we have hypertension and fluid retention, so we need to limit the sodium in the diet in order to manage the fluid retention. We need to administer diuretics also to treat the volume overload. So it's a very complicated situation because there's a lot of medications we need to give, and with a lifestyle modification as well. So we need to have excessive follow-up for these patients. Okay, so and if we reach a condition that is irreversible, sometimes we can offer kidney transplantation, because sometimes we have acute renal failure, we can't reverse it. So we're at the stage of dialysis or at the stage of kidney transplant. Moving now to the last few slides, we're talking now about nephrolithiasis. So when we say nephrolithiasis, it occurs when there's excess crystal-forming substances that cannot dissolve in the urine. So we have a kidney stone. And this kidney stone, it can cause low urinary volume because of the blockage of the urinary flow. And we can have a lot of types of kidney stones. We have the calcium oxalate and we have the calcium phosphate. These are the two most common types of kidney stones. Struvite stones, uric acid stone, and cystine stones, we'll see them later. These are less common. And to diagnose it, usually we do a non-contrast CT scan, so a Euroscan, and you see the stone and we have the diagnosis. So you can see the stone can be at the level of the kidneys or at the level of the renal pelvis. Usually here it's asymptomatic and there is no obstruction. But when the stone migrates to the ureters and the urinary ducts, then it can lead to obstruction. So like this case here, so it will cause pressure inside the ureter. The pressure will accumulate and go up. This will lead to symptoms and severe pain. So the symptoms, the patient will tend to complain of frequent and painful urinations. He can see blood in the urine because of the stone is causing damage to the urinary tracts. We can have decrease in renal function, increase in creatinine. So it's also a serious condition that we need to act to treat it. For the pain related to this condition, we can use NSAIDs, so non-steroidal anti-inflammatory drugs. They tend to decrease the pain very perfectly. We need to give excessive fluid because sometimes when we give excessive fluid, the stone will dissolve and it will go and will be excreted outside the body without intervention. So just give fluids. If the stone, we're not able to remove the stone by giving excessive fluid, we can propose lithotripsy. So lithotripsy is a tool or technique that uses machines in order to send waves targeted to the stone in order to fragment the stone and extract it from the body. Okay, so we have a lot of treatment plans, but you need to decrease the pain and we need to give fluids first in order to try to eliminate the stone without intervention. So the symptoms, severe pain, as we said, severe pain on the side or at the back, below the ribs. So sometimes we have non-specific pain everywhere. We always have to think about this condition. Pain that radiate to the lower abdomen and groin. Painful urination, very frequent. Pink or red urine, so blood in urine is also very frequent. Frequent urination. So we can have symptoms that look like UTI, urinary tract infection. But here, most commonly, the most common ones, you will see blood in urine and the severe pain at the back with hematuria. This is very suggestive of kidney stone. When we have fever and chills associated with kidney stone, here we need to suspect concomitant urinary tract infection because we said when the urinary tract are blocked, we have stasis of urine, and stasis of urine, so no more circulation of urine. So the bacteria tend to like this environment, and the bacteria will become will have production of bacteria and the infection will develop. So in that case, we need to administer antibiotics as well with hydration. So it's a more complicated case when we have association of kidney stone with urinary tract infection. It can happen. So the types, we said the calcium stones are the most common. So these stones are formed due to excessive mineral called oxalates. So when we have excessive ingestion of oxalate, so we find it in fruit, vegetables, nuts, and chocolate. So this predisposes the development of calcium stone. Unlike struvite stones, so struvite are caused by infections to the urinary tract, and it can become large. So here it can become large. So the risk of obstruction is higher here. Uric acid stone, so when we have chronic dehydration, there is a risk, especially in patients with gout or genetic tendency to develop high level of uric acid. Cystine stones as well, so here also inherited disorders affecting the kidneys, and xanthine stones also caused by enzyme deficiency. So here it's rare conditions to have these types. And silica stones also due to some medications and herbal supplements. You just need to know, in my opinion, the calcium stones, which are the most common due to found in food, and struvite stones that are due to infections in the urine. This is the case. So how to treat if we give pain medications and if we give hydration, but the stone persists, the symptoms persist. So what we can do, so we can check on the imaging, on the scans that we did, if the stone is less than 10 millimeter, so or if the stone is above 10 millimeters. So if the stone is above 10 millimeters, here usually we need to use a lithotripsy or the other tools we have in order to manually excrete the stone. But when the stone is smaller, or when the ureter is smaller in size, so here the management becomes different. So here I will show you also, so it depends, we have a lot of studies about this topic. So I showed you the two studies here. You can, it's the same study talking about this. It depends on the size of the stone, it depends on the size of the ureter. So the management is different. We'll not go into the details. It's not the focus of our lecture today, but you just need to know about these conditions. So now talking about hematuria. So hematuria, when we see heme, it means we have blood. And when we say urea, it means in the urine. So when we say hematuria, it means we have blood in the urine. So here is a nice image published in the Cleveland Clinic. You can see we have different types of urine. So we have the pale yellow, the amber, and the red. So hematuria is this one. So we see clear red urine. Sometimes we can see a normal color of urine, but we can have red blood cells inside. So we call it microscopic hematuria. This condition, we can only see it under the microscope. We don't see it macroscopically. Unlike the condition of gross hematuria, when we see the blood with our eyes. So we have two conditions of hematuria, either microscopic, so just red blood cells in the urine, or macroscopic or gross hematuria, when we see pure blood inside the urine. So here's an example. You can see how the hematuria looks like when we see it in the urine. So the sources of the hematuria, it's either in the kidneys. So when we said we have glomerulonephritis, we already discussed this. It can lead to destruction of the glomeruli, destruction of the surrounding vessels. So we can have hematuria. So sometimes we can have tumors, stones, urethral strictures, infections, and trauma affecting the urinary tract. All of these conditions can lead to hematuria. And a very frequent condition that can cause hematuria is benign prostatic hyperplasia or prostate cancer. So just enlargement of the prostate in males. This will lead to, we'll have lesions in the urinary tract passing inside the prostate. This will lead to the production of hematuria and gross hematuria. So when we see hematuria, the first thing we need to do is to do a urine analysis or urine microscopy and culture. If the culture is positive, so we have a urinary tract infection, then we need to give the appropriate antibiotics. If we don't have an infection, in that case, we need to directly do a CT scan, with injection. And without injection, we do two phases in order to check the cause of the hematuria. If we find stones, we need to then refer the patient to the urologist, and the urologist will manage the stone accordingly, according to the size, to the location, to the severity of the condition. If we find urologic malignancies, also we need to refer the patient to the urologist for surgery or for endoscopic treatment. If we find benign conditions like benign prostatic hypertrophy, BPH, also we need to send the patient to the urologist, because the urologists tend to also can do endoscopic investigations and intervention in order to drop the size of this prostate. So hematuria, first thing to do is urine microscopy, urine analysis and culture. If positive, you treat the infection, you stop here. If negative, there's no infection, so then you need to do imaging. The imaging, you need to look for renal stones, urethral or renal malignancies, or prostate conditions like benign prostate hyperplasia. So this diagram is very easy to understand, and if you follow it, there's we can diagnose all conditions. So proteinuria now. Proteinuria is the protein is a complex of compounds, and urea is, we're repeating it, is urine. So proteinuria means the presence of large amounts of proteins inside the urine. So proteinuria, excessive amount of protein in the urine. Why we have proteinuria? So this one is a healthy kidney. So you can see there's a filter in the kidney. It will not allow the passage. These are the proteins here, proteins molecules here. So they won't be able to pass to the urine because the filtration is intact. While when they have kidney that is damaged, the filtration mechanism is pathological, so all the proteins will go to the urine. And if we measure the proteins in the urine, we'll have excessive amount of protein. Albumin is a protein as well, so we can measure albuminuria, and it will be high in this situation. So symptoms, not specific symptoms, as we said, frequent urination, shortness of breath, tiredness, nausea and vomiting, swelling also, the extremities, lack of appetite, muscle cramping, foamy or bubbly urine. So when we see foamy or bubbly urine, we always need to suspect proteinuria, glomerulonephritis, and we need to suspect proteinuria especially. Okay, we said we will have swelling because when we lose the protein in the urine, the oncotic pressure inside the vessel will drop, so all the fluid will go outside the vessel to the interstitial space, so we'll have edema. This edema is not caused by the heart, it's just purely caused by the loss of proteins in the urine. So the causes, the most common cause is the kidney damage, so intrinsic kidney damage like glomerulonephritis. We have also diabetes. We said diabetic patients, they tend to have diabetic nephropathy. We have infections, urinary tract infections. They sometimes are associated with transient proteinuria. So just proteinuria during the infection. Diabetes, as we said, hypertensive nephropathy as well. So hypertension and diabetes, if untreated, they can progress to nephropathy and proteinuria. So we always have to measure protein levels in diabetes and hypertension patients, because if proteins are high in the urine, we need to prescribe specific treatments in order to delay the progression of diabetes and hypertension to nephropathy. And you have other less frequent causes like medications, NSAIDs, non-steroidal anti-inflammatory drugs. They can cause this, and some antibiotics as well, and chemotherapeutic agents. So how do we treat it? Like any other condition, we need to treat the underlying condition. So if we have diabetes, we treat diabetes. If we have hypertension, we treat hypertension. And like we said, in glomerulonephritis, we need to give nephroprotective drugs, so ACE inhibitors, angiotensin converting enzymes inhibitors, and angiotensin receptor blockers as well. These two medications that tend to reduce proteinuria, and they tend to slow down the progression of diabetes and hypertension to hypertensive or diabetic nephropathy. Dietary change, for sure, we need to drop sodium. We need to decrease sodium, because sodium, increased sodium will cause edema, and these patients already are predisposed to have edema because of the low protein. Lifestyle modifications as well, exercise. We need to monitor these patients, diuretics, and if this condition remains untreated or with the traditional therapy, we can give immunosuppressive therapy, especially if it's associated with autoimmune conditions. And that was it. Thank you for listening. So this was the last lecture of today. I hope it was clear, and I hope that you learned from these cases. I want to thank the presentations for organizing this, and for my colleagues also for giving the lectures. If you have any questions, please feel free to write them in the chat box. we have a poster presentation, I think. So we have two posters. So I invite you to stay to see these posters as well.
السلام عليكم ورحمة الله وبركاته. مساء الخير على الجميع. معكم الدكتور أحمد الثبيتي، أخصائي طب أسرة، مستشفى الأمير منصور العسكري. الصوت واضح أو لا؟ في صوت؟ الله يعطيكم العافية. أعتذر من الجميع، أعرف أنه الوقت طول، ولكن إن شاء الله بإذن الله عندي بوستر أعرضه باختصار. هذه دراسة سويناها اللي هي عن sexual maturity of children on regular hemodialysis role of testosterone and estridiol tertiary multi-center experience. طبعا هذه الدراسة عملناها على 106 مشاركين. 56 منهم كانوا CKD on hemodialysis 3 times per week 4 hours per session. 60 منهم كانوا healthy. طيب لقينا في هذه الدراسة إنه children and adolescent with end-stage renal disease typically have delayed pubertal growth. There is testosterone and estridiol level significantly lower than normal, which is lead to progressive delay in sexual maturation and final adult height. But preemptive transplant can avoid this. We recommend larger multi-center studies to validate possible supportive role of sex hormones therapy in improving sexual function. عندنا هنا مقارنة. أنا عارف والله، معليش المعذرة منكم، ترى أنا ما لي علاقة، بس عارف إنه الوقت طول، بس أنا خلاص بقي جزئية بسيطة وانتهي. عموما هذه مقارنة انعملت للعينتين اللي أخذناها، الكنترولد والبيشنت. بالنسبة للميل كان الاسترايدول in females الميديان حقه 32 while control 150. بالنسبة للفري تستوستيرون in the male الميديان في البيشنت كان 4.39 and in the control الميديان was 86. شاكر الجميع الاستماع وشكرا لكم. بكذا أنا انتهى البوستر حقي، والله يعطيكم الصحة والعافية.
Thank you, Dr. Ahmed. It's a great study.
السلام عليكم ورحمة الله. الصوت واضح؟ بسم الله الرحمن الرحيم. ما راح ناخذ من وقتكم الوقت طويل وتأخرنا كلنا، لكن الابستراكت العنوان لهذا البوستر The Importance of Deep Understanding the Medical Terminology Administrators. Abstract in the realm of healthcare administration, mastering medical terminology is not just beneficial, it's essential. This poster aims to shed light the importance of understanding medical terminology among medical administrators. The background, the medical administrators have an important job in keeping hospital and clinics running smoothly. The key points: clear communication, accurate documentation, enhanced patient care, embracing professional development. In conclusion, understanding the medical terminology is essential for medical administrators, enabling clear communication, accurate document, and improved patient care professionally and medical terminology is key to driving opportunity excellence in healthcare administrations, ensuring positive outcomes for patient and healthcare facilities. Thank you to everyone.
Thank you, Doctor. It's also a nice topic. It's related to the topics we discussed today as well.